the tibia in 3 degrees instead of 5, we have actually contributed to the lateral laxity.
Right.
So that is what we are trying to overcome by reducing the tibial cut. But
Yeah.
if you just went with a pure kinematic plan and replicated what the patient had before surgery, then there would not be any lateral laxity.
Lateral laxity.
You
So
get it?
essentially that lateral extension laxity can be brought down in two ways. You can
By
give,
varicing the tibia
yeah,
or by reducing the tibial cut.
correct. So either you can increase the varus to decrease how much you're cutting laterally, or
Right.
you can reduce the tibial resection. So that also depends on the surgeon's preference for how much varus you want to put on the tibia at the end of the day. You can go up to 5, you can go up to 6. If you want to stick to 3, you can give 3 varus, and you have to decrease the tibial resection to ensure that you don't land up with some lateral laxity.
That's right. That's right. So this is all like you have to understand the plan. So for mechanical alignment, you will create lot of lateral laxity. So that is an abnormal thing for this patient.
How much of varus would you accept, KK sir?
I can go up to 4 degrees in my practice, because the error to the system itself is about 1 degree, half a degree to 1 degree.
Yeah.
So if I err on the other side, it will go up to 5. So in our protocol, extended, restricted, whatever we have published, it is up to 5, up to 4. But I have pushed the envelope, sometimes gone to 5. So now you can see I'm just using this as a sort of a navigation tool again to optimize the workflow. So I don't want to waste time on this. So I'm pinning it about half a millimeter or 9 millimeters, 0.9 millimeters up, and this takes just a second, and then I will just fine tune the cut with a saw, with a burr later on. Are you able to see this?
Yes.
So
the robot
I'm not
has guided.
dislocating the tibia. I'm just using it as a protection tool. So I just cut it.
So the robot has given navigation type of guidance to place the jig in the right place. Yeah.
Relax. So we have still not dislocated the tibia, if you can see that. And
Yes,
this
sir.
makes a huge difference with respect to how the patient recovers. There's not, whenever you pull the tibia out, there is a dislocation of the knee. So a lot of soft tissue gets damaged. And that's one advantage with Mako, because of the haptic boundaries, no soft tissue gets cut. So there is a lot of preservation of soft tissue, and the patient recovery can be faster provided you follow all the principles. Sorry.
Yeah. Sir, the question is, when we are balancing the knee in CORI, the pivot points or the anchor points, are they fixed?
Now they have
or
changed,
able
so
to
you can
go
change
into
it any which way. So it can be
Okay.
central, medial, or lateral pivot points. So it's similar to Mako now. Previously, it was only a central pivot point. So now this.
For this question, just for the benefit of others, basically when you put an anchor point, that side doesn't change. So if you anchor laterally and you give varus, you will cut more on the medial side and make it looser. If you pin on the medial side and give varus, it reduces the resection on the lateral side and brings down the lateral laxity.
So now you can position the burrow and check whether the thing, you can see that the 7 mm which we left it proud actually made the cut accurate. Can you see that? Blue good.
Yes, sir.
So this, it works 100% in our hands. It's very rare that we'll have to reburr the tibia, because if you keep it about 6 or 7 millimeters proud, it's all like already cut as the robot would have cut. Okay. So now I've removed the menisci. There are not many osteophytes, but you can see how the gap is nice and snug, and you can see that the knee is pivoting slightly medially because the lateral side was lax. And you can see that I can pull the lateral side out, but I can't pull the medial side out. Can you see that? I can
Yes.
pull the lateral side out, see, but I can't pull the medial side out. So that's how a normal knee will function.
Right.
And if you look at the alignment is about 2 degrees or 3 degrees of varus. That's what we were planning. And as the knee extends, it will internally rotate. That is normal. And you can see that throughout the range. And you can see that the soft tissue laxity is perfect. So in extension and flexion, lateral is little bit lax than the medial, Mid flexion, there is no laxity. Did you get that?
Yes, sir.
And the range of motion is full.
Yeah. So considering in CR cases, this native kinematics are restored, is there a necessity for a medial pivot poly if you are using CR approach?
The idea for a medial pivot is that the ACL function is still not replicated.
Okay.
So that is the challenge with the injection, with the thing. So your posterior lip on the medial pivot replicates the ACL function.
Okay.
So my thought process is that it will go in the direction of maybe a sort of a single radius femur, because this, although we have done all the replication of the thing, so this is the first time where we take out. So now the pins are ready to go.
Yes, sir.
Because the surgery is essentially over. We will just prepare the tibia and cement and put the liner in the correct position. Although if you want to do till the end, then you must put lower tibial pins.
So that there is a less risk of the implant or keel preparation hitting the pins.
Yeah, keel preparation otherwise will be prevented there. So here we have changed the slope of the tibia from 13 we have brought it down to 9, because 5 degrees we have given the slope. Implant also has about inbuilt, the insert has about 4 degrees of slope.
Okay.
Sir, in case of a valgus knee, if you have to approach the same way, would you leave a bit of valgus even after the surgery? Would you think of same philosophy?
So the valgus and varus knees are completely different to each other. The varus knees fail because of collapse and varus knees, but the valgus knees fail because of instability. So you will not do this same thing for the for the valgus knee, although you could accept up to maybe 3 degrees of 3 degrees of valgus overall. So I may give 2-3 degrees of valgus on the tibia femur, but no valgus varus on the tibia. So here this implant is an anatomic tibia. You can focus from the top, somebody. ఇది చేయండి, switch చేయండి. So the anatomic tibia, if you size properly, it will restore the native rotation. So we don't look at the center point of PCL, Akagila, and all this is like all gone now. We just put the tibia where it needs to be. Mainly the mismatch between tibia and femur should be minimum. If you put the position independently wherever you want, then there is a risk of cement mix karlo. There is a risk of early failure. So most of the failures I see are because of tibiofemoral rotational mismatch nowadays. So the tibia somebody will put like this, like this. So if you internally rotate it, then it will cause change in the Q angle and maltracking.
Right.
Externally rotated too much, then again there is mismatch between femur and tibia. Up to 12-15 degrees it can tolerate. Beyond that, it will not.
So just wanted to point out here that this is the first time that the tibia is being dislocated for tibial preparation.
Correct. This is the only time, and at this time we will finish the cementing, and the amount of time is about 2 to 3 minutes. That's all. So because that is the challenge of the keel. But if you had a keel which was smaller in diameter, we could introduce it in extension from the side. There is no need to dislocate the tibia at all. And that is what some surgeons in the US do, Dr. Rick Berger and all. So if people get an opportunity, I think you should write to him, go and visit him and see how he does surgery in extension. No flexion of the knee. All this hyperflexion, pulling the tibia forward, all this cause a lot of pain.
So obviously in the Mako, because of the haptic boundaries, that PCL island is preserved. And in imageless system, that was the only sort of disadvantage. But I think because of the PCL's insertion, we're not really worried about the PCL island in most cases, right, sir? Or you're taking any conscious effort to avoid that area?
No. I'm not worried about the PCL island.
Yeah.
So I think a little bit of the PCL has got about a 12 millimeter insertion on the tibia. So few fibers, if it gets cut, it actually is beneficial, because we are not able to replicate all our slopes. So that's the biggest challenge for Indian patients. Some of them, as you rightly know, that have a 15-20 degrees of slope. You must have observed the same thing.
Yes.
And we can't replicate that slope on the TKR. And unless you replicate native varus and slope to within 3 or 4 degrees, PCL will get secondarily tight.
Yes.
It's a medial structure. So if you give the more you digress from native tibial varus and slope in the joint replacement, greater will be the PCL tightness.
Yes.
That is why most of the surgeons who do mechanical alignment, they get frustrated and remove the PCL.
PCL.
And I'm sure it's the same in the Sunshine group, your practice as well, that our recession of the PCL has come down significantly because of
Yes.
the understanding that we have now. Just replicating native CPAC and respecting the native tibial varus and slope within certain boundaries allows us to preserve the PCL.
Yes, sir. I think two things that we figured out were, first thing was when we did Mako and we did Velys was that we were giving too much importance to that PCL island. We were pleasantly surprised that it doesn't make a difference. Even if we knock everything off, the PCL is intact in almost every single case.
Yes.
And when we give varus to match the MPTA, native MPTA, the amount of releases we need to do for a CR knee are drastically reduced.
Correct.
I think
So,
conventional surgeons are always surprised.
So you cannot say that varus knee means that varus will require medial release and all these things. That's all obsolete concepts now. So you have to analyze what is the type of varus, what is the CPAC type, what is the sagittal alignment type, and then you can see that subtle changes in the sagittal, coronal plane and rotational plane. Rotation is the last, of course. Can balance the knee without having to, resort to too many soft tissue releases in majority of the situations.
Yes, sir.
And it's a much more elegant way of doing the surgery where okay, my knee kinematics are getting restored as close as possible. Given a choice, I would do a single radius femoral component with some sort of a medial pivot component nowadays. But
Right.
I think I can live with this sort of a situation where you can see that there is external rotation in flexion and internal rotation in extension. That is what happens in the native knee.
Yeah.
So if the lateral compartment must not be too tight in flexion.
Yes.
So that understanding we all have. And if you make this lateral compartment too tight, then the patient will have condylar lift off, which is more common in the PS knees than the CR.
Yes.
So now you can see that the knee is fully extending. There is no varus valgus laxity. There is no mid flexion laxity, full flexion, and it is stable in flexion.
Yes, sir.
Okay.
Yeah.
And I think I can leave you there, but I can show you how the vastus medialis comes back. So
Yes, that I think that's also important.
yeah, so we'll actually have to give a periarticular infiltration. Those people who are not doing, please do this. Pain management is an important part of TKR. We can no longer just operate the patient and allow them to be in pain. They'll have a very bad memory. They'll not come back for other side. So all steps which you want to do, you can see how the petalized tracking. We have not given any rotation.
Yes.
So if patient has no mal tracking before surgery, they don't need any this thing. So you can see here, can you focus here? Yeah, you can see here how nicely that flap is preserved.
Yes.
And you just repair it like the abductor repair there, and
Right.
then this patient is good to go.
Yeah.
So I'll leave you here.
Thank you.
Thank Dr. Balaraaju and his team for the opportunity, and all the best for the conference. Unfortunately, I have to go to Delhi, so I'll not be able to see you guys. But all the best.
Thank you. Thank you very much, sir.
Thank you, sir, for great surgery. Thank you.
Thank you, sir, for Dr. Krishna, sir, for remarkable startup our conference.
Give a great applause to our great doctors. Really, doctors, we are so blessed to see you all here. And also one more thing, that we are very blessed to see all these in the live show. Very thankful to you, sir.
Live CORI TKR, Dr. Krishna Kiran, sir, has a robotic influenced our conference TKR, is a Dr. Rajshekar Papu, sir. Image versus imageless robot is a Parharsa Malpur, sir. Thank you, sir. Thank you so much.
Go ahead, sir.
Okay, let's move on to some talks now. Let's discuss on image versus imageless robot by Dr. Praharsha. I would like to invite Dr. Alvareddy sir to join the stage as moderator and Srinivas sir also to please join us the stage, and Dr. Karthik.
Good morning, everyone. I'd like to thank Dr. Balaraaju Naidu and the ONUS team for this inviting me for the second edition of this great conference. I think one place where all aspects of robotics and all the robotic systems are covered in detail for the delegates to discuss and learn about the different systems. So today my talk is on imageless versus image-based robotics. It's not a competition because all robots are excellent. It's just to point out some workflow differences or some technical differences between all of them. So now adoption of robotics in arthroplasty is on the rise in India. As we can see in Hyderabad and in almost all states, every hospital is getting a robot or acquiring a robot now. And surgeons have access to different robotic systems from different manufacturers. But all robots are not created the same. And there are some differences in the pre-surgical planning, in the autonomy of the robot, and how the robot executes this bone resection, which people need to understand. So quickly on the autonomy part, you have fully autonomous systems which do not rely on surgeon handling at all. So the robot performs the entire bone resection independently without any participation of the surgeon. The surgeon literally stands on the sides and on the side and watches. This is basically from the Meril, MISSO or the CUVIS systems, which are fully autonomous systems. These semi-autonomous systems are controlled and manipulated by the surgeon, but the robotic system again fine-tunes and controls the surgeon's input. And the best examples are Mako, Velys, and in a way, CORI also, where you will be using the saw attachments with the robotic arm, but you cannot push the robotic arm to perform a resection beyond a particular planned boundary. And then you have passive robotic systems also, which is a step up from the older navigation like ROSA, which the cuts or the bone resection is performed by the surgeon with a manual saw, but the jig placement and the accuracy of the jig placement is much better than a navigation system because it cannot move. Now coming to the main part of this talk, which is classification based on imaging. And you have image-based systems. And these are the systems that require preoperative imaging in the form of a CT scan in majority of the cases. Some systems MRI, but not so commonly. The software converts the CT scan data into segmented slices, which then creates the three-dimensional patient-specific model on which you can do surgical pre-planning even before the surgery is performed. So you can get all the information about the plan, about the native anatomy and everything of the patient prior to the surgery itself. And this is how it looks like. This is from the Mako. And it can help you even before the surgery in adjusting your components virtually to match any plan you want, any sort of alignment philosophy you want, to ensure that the petrofemoral relationship, you can see how the anterior trochlear relationship is maintained to get the native slope. You can characterize bone defects, cysts, osteophyte size and location in gross deformities and severe deformities. And it is very reliable, highly reliable in sizing of components to avoid notching, overhang, and have any technical issues as compared to an imageless system. Now, imageless or image-free systems are the ones which have no preoperative imaging. So the patient can walk in, ask for robotic, and you have nothing to do before the surgery. You can offer them robotic instantly and go ahead with the surgery. And this is reliant on surgeon-derived intraoperative landmark registration. And the surgical planning can be visualized intraoperatively. And after the entire registration process, you have to do landmark registration and validation for these systems. And you can see the system uses some approximation software. So it is essentially like what we saw with the CORI system. You're painting or mapping the surface of the femur. The software takes all those multiple points to give you what is the most prominent point of what you have mapped to say this is 9 millimeters or this is 10 millimeters based on the singular point that it derives from what you have done. But there is always a potential for error especially in inexperienced hands or in the starting part, if you get registration errors, you will get execution errors as well. This is a very simple one. Just to summarize the main differences, you don't need preoperative imaging in the case of image-free robotics. There is no radiation exposure in image-free robotics because every patient who has to get a CT scan is obviously getting exposed to some additional radiation and additional cost. The workflow, it does take some time in the sense the surgery doesn't take time. The planning takes some time. So you need to get the patient in at least 1 to 3 days before the surgery to get the CT scan done. It has to be processed by the company person. They have to give you the surgical pre-plan. So there is some amount of lead time for these cases. Whereas in the case of image-free robotics, patient walks in and you can schedule him for surgery as soon as possible. Coming to precision, we'll come to some of the articles on that, but image-based is high in all the planes, especially because there is 3D reconstruction. In the case of image-free robotics, it is moderate because it is also derived from the surgeon inputs. Suitability, probably image-based ones are very useful in the case of severe and gross deformities with a lot of osteophytes or defects. It helps you in planning. Now, just when we saw all these points on the left are all the points that the surgeon has to register. And on the right side, it is what you have to do in the case of an image-based, where already a 3D model is there. You simply go and capture certain points. The points which can potentially cause an error are the knee center, the medial and lateral epicondyle, the white sides lines. When you do this manually, there is a high potential for error. Whereas in the case of image-based, this is automatically calculated and seen on the CT. So the potential for error is very low. And similarly, the tibial center or the ACL footprint is relatively okay, but the sagittal axis inaccuracies can be more with imageless. So all these are substituted by the automated process or on the CT scan. Now, when you go back to the literature and see what is the whole, why are we having a sort of a debate or discussing this in detail, there is a potential error with surgeon-derived landmarks. And this is mainly in the axial plane. So this is one cadaveric study which showed that when people were registering the femoral component, especially for the epicondyles, there is a 17-degree error range in this particular cadaver study for rotational positioning. Of course, it was a single user cadaver, small number. The findings were not generalizable across all surgeons and all experience categories. And again, this is a JBJS article which has shown the variability of femoral rotational alignment in total knee arthroplasty. And here you can see less than 17% of femoral components were rotated within 5 degrees of the transepicondylar axis. If that was the reference you wanted to choose, there was a huge variation, 13 degrees of internal rotation to 15 degrees of external rotation. So basically this was, as you can notice the trend here, we are focusing on the axial plane and less on the coronal plane. So we did a quick study in our own experience with the Mako, where we actually altered the software to see how accurate the CT is versus how accurate the surgeon is. And we were able to compare the differences in the bone resection thickness. We were able to see how the component was going to be positioned in the axial plane if we went by the surgeon's picked landmarks. So we did a registration where in the same patient, we have the CT scan, and we also did registration of the medial lateral epicondyles. What is the most prominent distal surface? What is the most prominent posterior surface? And the highest point on the lateral tibial plateau to see whether we are able to match it. And you can see that in our results, we found that mainly the transepicondylar axis, what we think we are marking correctly, was extremely variable. And this is probably because of variable prominence, soft tissue cover, and that makes a big difference. And we were finding that we were marking sometimes as far as 1.3 centimeters away from the true prominence of the medial or lateral epicondyle. So we had a wide variation from 8 to almost 10 degrees of internal to external rotation in this case. So looking at some other literature, looking at surgical accuracy of image-free versus image-based, there is no debate about coronal plane positioning, and even to sagittal plane positioning, both systems are equally accurate. And there was a difference in tibial slope, but again, that is not really clinically relevant. And there is no difference. All these studies which claim that there is a difference in patient-reported outcome measures are very far-fetched, because most of them just showing statistical significance is not clinically relevant. There is only like 1.2 point difference, which can go either way in favor of any system. And looking again at one more study, which was looking at the accuracy, the image-free systems, because you do an intraoperative registration and there can be bone loss. In the cases with more bone loss where the tibia is already in a little bit of varus, you may get a final alignment of your implant also, which is more varus than what you plan. So you may plan for 3-degree varus, you may get 5 degrees. And the tibial slope was also varying more in case of the image-based system. And finally, I think this we have shown even with the CT planning, there is very less chance of having overhang, or there is less chance of having any awkward or unreliable restoration of the anterior or posterior offsets. There is better sizing with image-based robotics, especially with partial knee cases where the posterior extent of the implant is very important to prevent any posterior blowout, etc. So just to conclude, all robotic systems are definitely superior to conventional methods. I think that is the take home, that if you have access to a robotic system, the benefits that it adds are, as you have seen in the surgery shown in the morning with an image-free system, the amount of time you dislocate the tibia, the amount of soft tissue releases you do, the amount of time that you spend on bone resection is drastically reduced from conventional techniques. So they're definitely more accurate. Imageless and image-based systems are very comparable in the coronal plane accuracy, and I would say sagittal as well. There are some concerns about image-less systems in the axial plane or femoral rotation. And that is why Dr. Krishna Kiran has published in his experience with the CORI. We are working on something with Velys and Mako as well. Imageless systems are good to go, and we just recommend that you use a posterior condylar axis reference-based approach and don't register the epicondyles intraoperatively. Just use the posterior condyle. So if you want to do 3 degrees, fine. At least you're reliably 3 degrees from the PCA. You want to be parallel to the PCA, you can set it and you can reliably get it. So when you do this, you get better accurate complement placement and balancing. And finally, clinical outcomes is not just about using a robot or not using a robot. In the short term, they depend on the approach, soft tissue releases. In the long term, maybe it depends on the alignment philosophy. A lot of literature is coming on this, how you balance the knee, whether it is CR or PS, and it's not so much on the type of robotic system used. So I think even through the day, when we see different systems, we should all keep an open mind to see how it is benefiting the workflow as compared to conventional cases, to take that step to do different alignment philosophies rather than focusing only on the superiority of one system over the other. Thank you.
Thank you, Dr. Praharsha. It was an excellent overview of image-based and image without image based things. I think next we'll invite Dr. Mithun Achi to give his talk on current consensus on single stage and bilateral TKR.
Please welcome, sir.
So good morning, everyone. Thanks for the opportunity to ONUS Hospital and Dr. Balaraaju Garu for this. I've been asked to talk about current consensus on bilateral TKR versus single TKR. 15 years back, not 15, maybe 17 years back, when our sir used to take us to different conferences, I had a chance to meet the legend Dr. Chittaranjan Ranawat, and I asked him this concept, that shall we do bilateral single stage or shall I do single stage single TKR? And he said one very beautiful thing. He said that, I'm sorry if it is going against the major consensus here. He said that, doctor, if in your consent form, one of the complications you mention of bilateral simultaneous single TKR as death, then you go ahead. If the patient accepts this complication, kindly go ahead. And I was very surprised because that time totally replacements were just being done left and right. And I was wondering why Dr. Ranawat told the same. But still, over a period of time, those words stuck in my mind. And in my practice of this past 17, 18 years, I have rarely, if ever, done bilateral single stage simultaneous TKR. Having said that, that might not be the major idea that is there in the fraternity. So I just wanted to understand what could be the reason why most of my peers and colleagues all over the world perhaps will be doing bilateral TKR single stage. And this is obviously, we know the bilateral total knee replacement, we have the advantages. It is single admission, it is single anesthesia, it reduces hospital time and reduces recovery period compared to a stage procedure. For example, if you're doing stage procedure, nowadays, the time frame that is being allotted or being recommended is 3 months between one TKR to second TKR. At least 90 days is what they are saying is the time that you should prefer if you're going for a stage procedure for whatever reason. So obviously bilateral TKR has got its advantages, but it has got its disadvantages also. It has got a higher risk. It's got an increased chance of blood clots and increased blood loss only because the volume is double. Whatever you're doing it double. So the complication chance is also double. So is bilateral TKR really safe, or more correctly, is it really necessary, is what the question that all of us need to answer when we are going to operate a patient with the same particular problem. So we have to weigh the risk, we have to weigh the safety that is involved. So I went through PubMed, I did some research because I usually don't do bilateral, but for this talk, I tried to understand what is the concept. And I went through many papers, and this paper, it showed that actually bilateral TKR can reduce costs with similar safety profiles and rehabilitation outcomes compared to the two-stage bilateral TKR. This was one study published in PubMed in, I think, 2021. And this was another study where they did a 30-day mortality on single anesthesia bilateral TKR compared to unilateral and staged. And they found that single anesthesia SAB TKR is at least as safe as unilateral TKR or staged bilateral TKR in appropriately selected cases. Now this new word started coming out, appropriately selected cases. So surgeons should wait at least 90 days before the second procedure. So I started wondering, what is this word appropriately selected? How can we determine what is this appropriately selected? I went to another paper, and in this paper, they have mentioned that simultaneous bilateral TKR is safe for properly selected patients. So you see, this word is being often repeated. It's not like bilateral TKR is generalized for all patients, and they are putting a small comma and saying that properly selected patients or appropriately selected patients, you have to undergo bilateral TKR. And I started to do a small research in this. And from various papers, I understood this is a big New Zealand registry that was published. And they found out that bilateral TKR, the appropriately selected patients usually are age less than 75 years. Non-complex deformity surgery. That's because this type of surgeries can be a long time consuming sometimes, and putting the patient at extended anesthesia risk might be one of the problems where these particular patients might have a problem. BMI of less than 40. That is another one of the core principles of total knee replacement, that if you're 40 plus, even forget bilateral, it's better not to do single TKR also. And maybe you have to balance your options and go ahead. And ASA grade 1 or 2. So these are the 4 important points I came across various papers where all of them were talking that this appropriately selected patients or properly selected patients should have these 4 criteria to be met. So obviously we know the ASA grades more than us, maybe the anesthetists know. So ASA 1 is healthy patients, ASA 2 is mild to moderate systemic disease caused by the surgical condition or by pathological process or medically well controlled. So this is the criteria where you stop your bilateral. If it is ASA 3, there is no recommendation in the literature that you can go ahead with a bilateral TKR. That is severe disease process which limits activity but is not incapacitating. ASA 4 is severe incapacitating disease, which is a constant threat to life. ASA 5 is moribund patient, not expected to survive 24 hours. Obviously, if you don't do TKR on that, and ASA 6. There is a recommendation by the government of India. I don't know if many of you don't know, but whether you know it or not, there is a recommendation by the government of India, the Ministry of Health and Family Welfare, where the recommendation for bilateral arthroplasty, it clearly mentions there is limited evidence. That is, evidence is very, very less that simultaneous bilateral TKR is safe. But however, if you have to go ahead with a simultaneous bilateral total knee replacement, the government of India recommends the patients be aged below 70 years. They should be 70 years or younger. ASA status of 1 or 2, the chance of increased complications are less. So this is the standard treatment guidelines updated in the ministry's website since 2017. So this is a one very, very important point that I request all of you to understand, that God forbid, if you attempt 70 plus patients, bilateral TKR with maybe ASS status 1 or 2, you're going against the government's guidelines. If any untoward incident happens, God forbid, you are liable for legal proceedings. So there is definitely a guideline from the government of India. So I would request my colleagues to keep this in mind. Doing bilateral knee replacement is not wrong in correct selected patients. That's the summary of my presentation. You can go ahead and do it, but you have to be very, very selective. If you personally ask me, if it is a bilateral knee replacement, the patient demands, maybe in his 50s I'll attempt, but 99.99% of the time, I go for single stage or a stage total knee replacement with a gap of 3 months or 6 months, because there is no hurry in trying to give. I tell the patients, this is not a race that you have to win with your neighbor. Your neighbor got bilateral knee replacement, wonderful. But if you're coming to me, I'll be very, very, what shall I say, selective about my patients that undergo bilateral knee, maybe 1% of my practice, extremely rare. So the beautiful Shakespeare's adage, to do or not to do, that is the question. So that is the question you have to answer whenever the patient comes to you for any particular surgery, whether it be bilateral, staged or single. How you do it is what guides your practice, and you will have, believe me, zero mortality and zero morbidity, major morbidity, if you are very careful about how you select your patients and what type of surgery you attempt on them. So thank you so much for this chance.
Hello, sir. I think most of the time it's more difficult to convince the anesthetist for bilateral TKR than the patient for the stage.
Yeah.
And I suppose most of the centers are following 65 years as a guideline rather than the 70,
Yes, true.
as you have mentioned.
Yes.
Is it true, sir?
Yeah, obviously, it is very true that 65 is a cutoff, unofficial cutoff for us. But if you're attempting 66, 67, 68, below 70, at least legally you're safe. That is one thing I want you to understand, because it is a guideline from the government of India. And many times in legal proceedings, this can be taken as a reference point. And many of us are unaware of this. Many of the colleagues, I don't know if to you, it might be a new slide that I have shown, that 65 years, less than 35 BMI, maybe one mild systemic disease might convince me for a bilateral, that too very rarely. There is one sentence that my sir used to say. He said, if a patient comes in walking, you should not go back in a stretcher. So I would advise you to be very careful of how you choose your bilateral cases, because we can explain everything. We can explain infection, we can explain dislocation, we can explain patellar instability, not robotics, but we can't explain death. So we have to be very, very selective. Be very careful, especially youngsters. I'm not trying to tell my colleagues who are much better than me, but the youngsters who are starting the procedure, just be very careful of how you do your cases, how you select your cases.
Thank you, Mithun Achi. 1 minute. The recent Calcutta court also has, the case has gone against the doctors recently.
Yes. They got suspended, sir, for 6 months.
Yeah, that's it. Your statement is true in one way. And is some people, they do it little early. Is it 3 months or the period is very?
Sir, the recommended
1.5 months.
Literature recommended is 3 months, sir.
3 months.
But it all depends upon your appetite also, with your, as the anesthetist decides also whether the fitness is there. So obviously it's a multidisciplinary approach. In our center, we obviously.
Is there any consensus other than 3 months, or some people do it with 1 week also, or 3 days like that also?
There is no literature support for that.
No literature
says
support.
3 months.
So this has to be very clear.
Yes, sir.
So doing on after 3 days or 1 week, there is no literature support.
No support is there.
Okay.
Only 30 days, 3 months is the ideal time for a staged bilateral TKR.
Because the inflammatory markers, they come down after 6 weeks, they say, or 3 months.
Yes, sir. So
very sure.
Regain your physiology. That is
Regain
your physiology to what it was pre-operative level for the second side to be attempted.
Thank you. Very
you,
good talk. And next we will invite Dr. Ramon Reddy Garu to give his talk on problems in robotic TKR.
Please welcome, sir. Give a round of applause. I request everyone to clap and welcome the guest.
Yeah, good morning. Dr. Mithun, thanks a lot for enlightening. I didn't know about that Ministry of Health advice. Till date, I was doing even above 70. I have to rethink about it. Yeah, my criteria are hemoglobin more than 12, no medical comorbidities at all. Any patients with stents, ABGs, no. Insulin diabetes, no. And obesity, yes, definitely. Right. And as the panel said, do you recommend after 3 days, 7 days? No, it's very, very high risk. Now, remember the Workhorse triad. You operate the next 5 days, 7 days, patients don't eat, don't drink properly. You take the patient back to the theater, the risk of pulmonary embolism, stroke, and heart attacks are very, very high. So don't do it after 3 days. Yes, 3 months. My cutoff is 6 weeks on an average. Right. Dr. Balaraaju, I don't know where he is. He invited me for a robotic talk. I'm not a high volume robotics surgeon. So I said, I can't talk much about robotics. He said, what can you present? I said, problems. Problems in robotics. And then is it problems using robotics or is it complications after robotics? My journey with robotics or computer navigation is more than 13, 14 years. Started in this was one of the first cases 11 years ago. You can see the deformity. More than 7 to 10 surgeries from the age of 14. Right? And look at this deformity, the distal femur, malunited. It's not possible to do a conventional total knee replacement. Yeah, 11 years ago, there was no robotic in Hyderabad. When you put a straight line through the femur, probably the intermediate jig, the rod will not go through. To add to the problem, there is proximal femur deformity. So what do you do? I was told that I was one of the first to use this material. Gyroscope is an equipment in the car. How to balance your car. So the same technology was used in this small piece of equipment from one of the implant companies. Oh, it just does distal femur and proximal tibia. It is just a chance patient weight. So till date, she is doing well. So why are we talking about robotics and patient weight? There are many problems. I'm not against robotics, but you have to understand the limits. There are many types of robotics in knee replacement. One is where there is a burr and one where there are no records of how much damage is happening with the saw, but off the record, unofficially, I came to know that neurovascular injuries have happened in the city and across the country. So one has to verify. At least one case has gone for amputation. The second problem with the robotic is it is implant specific or company specific. So you can't use a robotic of one company for another implant of another company. So it is limited. The third problem with robotics is the algorithms, the software is not from Indian patients. All the data is collected from Western patients, and then the equipment which you get in India is based on those patients. So you have to understand this. There are problems with fixation of pins and problem of mapping the articular surfaces. The distal femur and proximal tibia, if you don't get your mapping correct, right from step 1, 2 millimeters, the robotic equipment will take you down the wrong road. Indian patients are totally different category of compared to the Western patients. She knows she was in UK. Very straightforward, simple knee arthritis in Western patients. But what you get in India, most of them, more than 95% are women. They are 5'2", 5'3" height and obese. Some of them have got inherent lot of stiffness. If you look at the femur,
తర్వాత
there is
అక్కడ నుంచి ఇక్కడికి
nothing
వస్తారా?
going.
కెమెరా
Osteoporosis more than 90%.
ఓకే అంటే ఇట్లా
Abnormal deformities and every third patient.
నెక్స్ట్ మనమేనా ప్రదీప్?
No, it falls
started,
into
na?
this category. So how is robotics going to help?
ఈ టాప్ తర్వాత మనం అడగా.
The picture is not there, right? More than 100 kilos. The knee diameter is really, really big. So when you do a robotic knee,
They will ask weight
the
also.
pins,
Weight,
they are
height.
short. In a big
Because
knee,
we can
it's
generally we
really
have to check weight
difficult
also.
to see how deep the pin is going in. Right? It is very difficult to dislocate the tibia. If you can't dislocate the tibia, you can't snap. If you can't snap, you won't get the right measurements for you to do the surgery. Similarly, the condyles, posterior condyles, you have to map it. Otherwise, the sizing of the femur won't be accurate. There is medial parapatellar, mid-vastus, subvastus approaches. So when you want to use the pins, especially in subvastus, the muscle can get damaged. In big patients again, sometimes you have to use the pins through the muscle. So a lot of robotic equipment is meant for medial parapatellar. So for surgeons like me, where I use mid-vastus most of the times, it is sometimes a problem. Now, the next question is, how far can we go with robotics? This gentleman is 65 years, very tall and huge. Some surgeon has done high tibial osteotomy using Ilizaro for a varus knee more than 10 years ago. You can see the deformity. When the patient came to me, we didn't have the robotic, it was coming in. I said, there's a lot of deformity. We have two choices. Break the bone, tibia, correct it, put a plate, and then you come back after a year for knee replacement or wait for robotic knee replacement. Oh, he waited for 6 months. Now, this was one of my first cases where I experienced the limitations of robotics. You can see the pin sites here. So I attempted using robotics for this. Huge man, very difficult to dislocate the tibia. The company person is not there. For 2 hours, we really struggled to map the femur and tibia. At the end, I abandoned it, used my conventional techniques, and finished the surgery. So it is a half robotic knee replacement. Was one of my first cases. So you learn the lesson. It looks deformed, almost same as the first case. I had the robotic on standby, but use a simple manual technique. Osteoporosis is one of the major problems, not just in women in India, but again in men as well. If you put the pins, make sure they are stable. If they're not stable, don't use the robotic equipment. This is a major problem with robotics use in India. Remember that. You'll get wrong measurements. When you're doing final trialing of components, you cannot make an accurate assessment. Even while using the burr and all, you know, what you call the tracker pins, they come off. Where you put them in the distal femur and proximal tibia. Once they come off and you put them back again in a wrong place, all your parameters are wrong on the screen. Think about it. If you're doing a knee replacement using robotic, make sure the patient's bone mineral density is good. If it is not, talk to the patient. Not many talk about this. Everything looks fine, patient is happy. 3 months later, this can happen. When we do platings, nailings in bones and remove the equipment, there are refractures. If that can happen in a strong young bone, don't you think it can happen in a robotic-based knee replacement? Yes, it can. What is the incidence? Nobody still knows. We are still getting the numbers in. So whenever I use robotic, in the pin sites, at least a small, whether it works or not, I don't know, but I do that.
ఓన్ చేసి మేము ఓపెన్ చేసి పిన్స్
Pin track infections. It could be small, there could be osteomyelitis. What is the significance? Still, we don't have an accurate data. Now, let us come to abnormal anatomy, fixed deformities, and bone loss. Major problem while using robotics. Look at this kind of knee. Completely stiff, fixed flexion deformity of more than 40 degrees, medial tibial plateau bone loss. We just can't do any mapping of the tibia at all. What is the normal articular surface here of the tibia? We don't know. Right?
మేడం యాంటీబయోటిక్స్ గివెన్
Be careful when you're
Sir.
attempting to do robotic equipment in these kind of patients. So, straightforward, use your common sense, use your manual techniques, and get out safely. When you look at the intra-op pictures, the amount of bone loss, I'm not sure what kind of systems will help me to do a knee replacement properly using the robotics. Another patient from Bangladesh. If you look at the left knee, there's complete tibial posterior slope. This was completely stuck. So how do I do a robotic knee replacement? So this is a problem. This is a limitation in robotics. Remember that. Post-op, again, simple manual techniques, one at a time. As Dr. Mithun said, give a 6 weeks gap and get out safely. It's very small percentage of these kind of fractures, deformities, proximal tibial plateau fracture. What is the normal articular surface here? Right? It is so wide, the surface. You can't do mapping here. And the robotic equipment is not going to support you. So, again, simple manual techniques. This is my personal opinion at this stage, right? The present day robotics have limitations. Now, 30, 40 years ago, if someone had said, you are going to get modular prostheses, ceramics, MDMs and all, we could not have imagined. I compare the present day robotics to Austin Moore prosthesis. It works, but it has got its limitations. It is not perfect. The robotics are going to get better. It might be 10 years, 20 years, 30 years. It is going to come, right? Just like the hip replacement or the knees replacements. At the moment, I feel the robotics are not perfect. It has got its limitations. My take-home message is very simple. All the young surgeons, don't rush into surgeries. You need to know your subject properly: anatomy, mechanics, metallurgy, and designs. Only a good conventional surgeon can become a good robotic surgeon. Select your cases properly, straightforward, knee arthritis, low BMI, no deformities, no stiffness. These are the cases where you can do a robotic knee replacement safely. Robotics is not a substitute for ignorance. When I say ignorance, doesn't mean in a bad meaning. It means lack of knowledge of knee replacement and lack of expertise. No, a lot of, we try to sell robotics, but it is not a replacement for our lack of knowledge while doing the surgery. Be the master of technology. I believe in robotics very strongly, but you should know, you should not become a slave of the technology. You are accountable, responsible to the patient. Counsel the patient properly. Don't say robotic is super. No, you have to tell the backside as well, negative sides as well. Just like Dr. Mithun said, we have a duty to the patient. Every second patient of mine says, I want robotic. I make them sit, explain, finally they come for manual. This is my worry. We are becoming so addicted to technology, we are forgetting. Don't become a slave of technology, right? It happens, right? Just 1 month ago, in UP, you follow the GPS, it went off the road, off the bridge. All 5 people died in that car crash. You are the driver. The surgeon is the driver, then the passenger is the patient. Both of you can suffer if you don't use the robotics properly. Thank you. Any questions? I never counsel a patient for robotic.
Hello, mic test. 1, 2,
If
3.
they ask me for robotic, then only I offer.
So
Hello,
mic test 1.
Proactively.
Already
Proactively, I
market
never
is
tell.
proactive. When market is proactive, we need not bother.
Yeah.
How would you counsel a patient?
I don't. I don't counsel a patient for robotic at all. I just say, this is the implant I use. This is what the outcome is. If they say, what about robotic? Then it is a 20 to 30 minutes counseling of where it should be used and where it should not be used. I show them the literature and then I leave it to them. It's a patient's responsibility as well to read and come back.
So, I mean, as a surgeon, you are saying robotics have got no additional advantage over conventional TKR. Is that the take-home message?
100% yes at the moment, yes.
Okay.
Right. And just as a final line, we are told there are 4 or 5 benefits of robotics. Less time, less scar, less pain, less blood loss, and high precision. Only one of them is true, less blood loss. All the steps are similar to conventional. Only the intramedullary jig is not there. That's where the major bleeding is. Nothing else, nothing else. So let us not use robotics in a wrong way. That's all. All right. Thank you.
Thank you very much, sir, for the enlightening talk. And I would like to thank the panelists and the moderators for helping us with the session. Now let's move on to the live surgery, CORI with UKR. I would like to switch to Dr. Sunil sir's surgery there. I would like to invite the moderators for this session. Dr. Raj Shekhar, please join us on the stage.
Really good to it.
Dr. Aditya sir, please join us on the stage for the moderating. Praharsha, please join us. Dr. Nagarjuna, please join us. I was just wondering.
Hello, Dr. Sunil, you're able to hear us from the auditorium?
Yes, I am. Can you hear me?
Yes. So this is Dr. Praharsha from
Hi,
Samsung.
Praharsha. Yes, I can
hi.
see you. Good morning, all.
Morning.
Morning, Sunil sir. Dr. Nagarjun here.
Hi, Nagarjuna. How are you?
Good, sir. All good.
Yeah. I mean, I'm sure the audience is spellbound now after the talks. Now they'll be wondering whether to go ahead with robotics or not, I guess. Anyway, so I have with me Dr. Srinivas Reddy, my colleague, Dr. Lokesh, our colleague consultant, Srinivas and Lokesh, and Dr. Kalyan Reddy, and also the fantastic team at Yashoda Somaji Guda. Srinivas is going to tell us about brief about the patient, and then I'll show you the approach. Yeah. Over to you, Srinivas.
Yeah, hi, good morning. So this is a case of 50 years female, complaints of pain at both knees. So difficulty in walking for longer distance. For that, we operated on her right side, UKR on February this year. She is doing very well on right side now. So now on examination, left knee, she has a medial joint line tenderness, crepitus was there, and varus deformity, it was correctable. Range of movements are 0 to 130 degrees. So this is the standing X-ray stitch film showing varus deformity. And this is the latest X-ray. There is a clear cut in the left knee. There is a clear cut kissing sign, bone on bone. So varus valgus tessus. It shows there is a correctable deformity. Thank you.
Yeah. Okay. Now, can you all see there? Can you zoom in on there, or if you can get the camera? Can you see the intra-op pictures now?
Yes, now we are able to see it.
Right. Okay. So Praharsha, what we have is, like Srinivas said, it's a 50-year-old female. We already did the right UKR, robotic, and she's doing fantastic. Now she's come back for the left knee, and you could all see the pictures, especially the varus valgus stress views. You can see the lateral joint line is well maintained with the lateral cartilage, and
Yes.
also the approach for my other colleagues. So we are going a bit more medial, as we always do for the UKR. And you must have seen some of the UKRs hanging out. That's what I used to do for my Oxfords. Now this is being a fixed bearing. It doesn't matter much. So you can use your regular TKR approach, the TKR position rather. And if you can see my markings, what I do is the patellar marking first, and also the patellar tendon. And the pins go about 4 finger breadths below on the medial side, both on the femoral and the tibial side. And coming to the approach, we go the medial parapatellar. And the first and foremost thing, what we need to check is the other side of the knee that we always do for the UKR. And I always suggest all my colleagues to keep the TKR always on the standby. Because, the most important thing is to consent the patient. That's more important. Even if you're taking for a UKR, always tell the patient on table, you might change it to a total knee replacement, which what happened for me last week actually. So if you can see there, can you all see the inside of the knee? Brother, can you come this side? I have some pointer. Forceps here. Can you see the inside of the knee now?
For the benefit of the audience, they want to see the lateral view of the preoperative X-ray, sir. Can you just
Lateral view, yes.
we have time, we can just switch over.
Can you focus there, brother? Srinivas, can you show them the lateral view?
Sir, what is the distal extent of your incision, sir? Like, is it the same
Sorry,
as the
Nagarjuna,
conventional TKR?
Nagarjuna, can you be louder?
Yeah, what is the distal extent of your skin incision, sir? Is it the same as the
Up to
conventional
the,
or robotic?
no, the tibial tuberosity.
It's the same, or we are
Yes.
a little conservative in
Almost,
your incisions?
no, better than, much less than your conventional TKR. As you can see, she is quite a chubby lady. And that's why you can see my incision a little bit more than what I would do. My incision will be at least a half an inch less than this. But here you can see a lot of adipose tissue here.
Yes.
So
have
Dr.
you all seen
Sunil,
the
I
lateral
just
view?
wanted to point out, like if you put robotics aside for 1 second, in terms of your experience, as you're an experienced surgeon, have you expanded your indications like the literature supports in the case of either an FFD or a hyperextension? Are you more concerned about those knees? Would you do something differently in your planning?
Yes, I mean, I have not extended yet because the robotic UKRs are not as common as we would do the total knee replacements. If
Right.
at all I have significant flexion deformities and all, I would rather go for the conventional.
Okay.
So can you summarize the indications of this surgery for the benefit of the beginners who are just planning to start their UKR in their career, sir? Just in few points, if you can summarize, what are your indications?
Yeah, for the most important thing is we all know the Oxford criteria, the Conan criteria. Especially, you should have the correctable deformity. The varus deformity should not be more than 50 degrees, and majority of your deformity should be correctable. And also, you have to make sure the patient is not too obese. And apart from the varus deformity, the flexion deformity also. Okay. With these varus and flexion, usually we take around 15 degrees. And we should also check when you're examining clinically that this is correctable. As you can see in this clinically, just relax on this place. So if you can see this lady, this is correctable. And the most important thing you should also be doing apart from clinical examination on your x-rays, I always do my varus valgus stress views. And if the patient is affordable, then we should also at least do MRI to make sure the ACL is intact. It doesn't matter much with the fixed bearing what we're doing now. If you're planning for Oxford, you should definitely make sure that the ACL is intact. And the majority of these are anteromedial OAs. Yeah.
Yeah, I think that's the important point for the delegates is that if you have a functional ACL and it's fine, then you can consider doing mobile bearing uni. But if you have any
Yeah.
doubts about the functional status, or if it's an ACL deficient knee, but it's only anteromedial osteoarthritis, you can still do a uni, but you have to do a fixed bearing so that you can prevent the chances of a polyspin out.
Absolutely true. Yeah.
How frequently do you do MRIs for your planned uni patients, sir? That is also one
Frankly
thing.
speaking, for all the patients.
All the patients.
Because I don't want surprises on table. So majority, if somebody can afford 50,000 extra, I'm sure they can afford another 2,000-3,000 for the MRI. Nowadays, we all know as surgeons how cheap the MRIs have become nowadays.
Good morning, sir.
So right now, as you can see, this is forceps for me. It's only the medial OA. Okay, you can see the femur there, and we have just checked that one. And now, if you can see there, the osteophytes. That's what I'm going to take off before embarking on further. Can I have nibbler, please? And also, if you can see, I just released just below. I'm not releasing much of the MCL, which that's what we do for most of our UKRs. We don't want to do much of soft tissue releases. So I'm going up to the equator now. So it's essential that we take off all the osteophytes before you start off. Right. So as you can see now, we got rid of most of the osteophytes now. Okay, fine. So now let's go for the pin placement. So which will be about 4 finger breadths approximately. And as we all know, it's 3 cortices. The 4th cortice is just about we're touching. So we're going perpendicular to the bone. And also we should make sure that the patient is not osteoporotic. That's vital. We don't want any pin fractures post-operatively. Okay. Exactly. So as I reach the 4th cortex, yeah, just about we're going in. You can feel the sudden tightness around your pin. Good. Fantastic. So as you can see, the pins are quite robust now. Going on to the femoral side, again 4 finger breadths above the patella. Uh, 11 blade, please.
As you saw in the case of TKR, usually the pin placement is exactly like what we saw in the morning, that we place
Sorry,
them
say that again?
No, we were just saying in the morning we saw the TKR done by Dr. Krishna Kiran. There we are
Yeah.
able to place intra-incisional femoral pins, but in uni you can avoid that so that your incision length can be very minimal.
Absolutely
So
true.
here we'll
Yes,
take
yeah.
stab incisions and place it on the medial side, but still keep it towards the joint. I think majority of literature has proven that the higher your pin placement or more proximal your pin placement, the chances of a periprosthetic fracture are significantly higher.
Is
You are
higher.
putting
Yes,
more towards the
absolutely.
metaphysis.
True. Yeah. So only thing is you want clearance when you're putting your implant and all.
At this point, do we have any specific precautions that we take to place our pins in a specific way that will not affect the patella subluxation or retraction, sir? Like, do we take any specific precautions in that?
In the uni or total?
Uni, sir. In this case.
Like 1 second. Come on, please. Come on. 1 second. Just a second. I'm just placing that pin. I want to concentrate there. Yeah, go. Keep going. Keep going. Keep going. Yeah, right, thank you. Sorry. So your question was how to avoid patella interaction there?
Retraction when will the pin affect retraction of the patella in this, or any precautions that you take to prevent the that to happen?
Well, as I said, you're about 4-finger breadths from the tibia and also 4 fingers above the patella. So it should not alter any of your patella. See, you can retract the patella easily because I've placed the pins much away from that. I don't see any patella retraction from there. Moments. No, let me check. So the next thing we are going to do is make sure that your trackers are visible nicely. Yeah. And you also want to make sure it's visible all through when you're rotating. Okay, fine, come. So we're going with the hip, knee, ankle axis. The first thing, as you all know, would be to do the hip rotation. Okay. Okay, so we are solid there. Okay, can we get the thingy off, please? Can we have the thingy techno? So I don't know if you can see the screen. Can you see the computer screen now? Yes?
We can see that, sir. We can see that. Yeah.
Yeah. So as you can see, I can see the femur in blue and tibia in gray. You want to make sure that it's in the center.
We are missing out on the camera view. We have to probably shift off the screen to that.
Yeah. So, can we get that one, please? No. This one. Can we show this one? Yeah.
We're not able to see the screen, sir. Yeah. Now we got it. Now we got it.
Boss, one of you focus here. Brother, you only focus here. Yeah. Great. Yeah. So we have the feed from the robo directly. Yeah.
Yeah, that is
so
fine.
you're okay there?
Yeah, this is good.
Right. Okay. Fantastic. So now what I'm checking is I'm making sure that I can see all through. So there my femur, as you can see. So that's where I can get. So probably, let's see. Let's go for a trial. If not, I'll loosen my things. Can I have the foot pedal, please? So we are loosening the side support to get the hip rotation. Okay. Next. Hold there, please. Lateral. Right. So there are different ways to put the femur checkpoint. Once you've done your first 100, you can cheat a bit. You can get the thingies on your tibia and the femur there. Otherwise, you also have the checkpoints. My only worry is after finishing the surgery, you might leave them in there. Okay, so let's get the hip center of rotation. As you can see now, I'm trying to go along the circle. You want to keep the error as low as possible. So you can still see some areas are grayish, not green. Turning green now. Right, fantastic. You can see the error is 0.5. Normal acceptable error is about 1. Okay, so that's my neutral. You can see. And then the range of movements. That's the range of movements I am getting. The stress, please. The Z. Thank you. Cool. So as you can see the intro-op image, you retract a bit or give traction and then put the Z retractor there on the medial. And then now again, you're checking.
Is the retractor placed between the articulating surfaces?
Yes, on the medial side.
So it's almost, you're using it like a tensioner.
Yeah, so we want to see the stress how much soft tissue opening is there? We don't. Okay, one second. Hmm. Hmm. Why is it not making sound?
Are you giving any valgus directed force at this point, sir?
I'm giving valgus stress with my Z retractor.
Not with the hand, right, sir?
Not with the hand, no. Right. So now we have landmarks. Yeah, come. Can I have moments, please? Hold on to that. Humorous on that. Otherwise, easier is to put the K-wires. Can I have K-wires, please? 2 K-wires. It's okay. Get me K-wires. Easier is to get the K-wires. As we know, the hands will be coming in between. So we'll put the K-wire first. Can I have a swap, please? K-wires?
Anybody has any doubts with the workflow, anything that you want to ask, please feel free to ask either to the surgeon or to the panel.
One more? Thicker than that. Yeah.
I think a lot of focus has to be there about the selection criteria of these cases, because usually when you assure the patient regarding uni, probably like few of them, if we are not counseling them properly, they may not be happy if they go for TKR as a decision on table. So it's always better to counsel them. It can go either ways, and prepare them regarding a possible total knee that can happen.
Yeah, absolutely true. I'm just putting 2 K-wires. This is much easier to retract. As you can see, can I have the cutter, please? So will be easier. K-wire cutter, please. Cutter. Watch it. Can I have artery clip?
On the femur, you placed it in the trochlea.
Sorry, sir?
Where did you place your K-wire in the femur, sir? On the femur?
Femur just beyond the midpoint, because I have to mark my midpoint, as you can see there. Just beyond the midpoint. That is my midpoint. Can I have some marker, please, in my hand?
Can we zoom the image, sir? Because it's not visible that clearly regarding the placement of the K-wire.
Yeah. You can see there. Lag and backs there. One second. I don't want to see the K-wire. So I don't know if you can see now. So that's the midpoint of my femur. Yeah, so I should put my marker there. So right next to that. Yeah, thank you. Come. Right. Okay. So now we're going on to the tide mark. Tide mark is the, can I have hard marker pen, please? So the most worn out area, antemost point where you have the tibia and femoral articulation. So that's my tide mark. That's going to be my first point, then the center of the knee, and then the most distal point and the most posterior point. So these are my points that I'm going to tell. So as you can see there, that's my tide mark. And then the midpoint of the femur, like we have checked before. And the most distal point and the most posterior point. You have to flex the knee to get that one. Right. Okay. So now we are going on to femur collection. Langenbach's that place. So this is what you want to make sure, you want to avoid. Go back, please. Fine. Okay, fine. So you don't want any air pockets. Okay, so first is to mark out. No, go back. Go back, you're going to tibia. Yeah. So easier is to get your borders first, then you get onto your regular. Flex the knee, please.
Seems like a beautiful technique, sir. You just bordered out everything and filling it in between.
That will be much easier. And the more points you give, the easier it is for the robo. We keep hearing the same saying, garbage in and garbage out. So you want to be very careful when you're doing your pins and the markings. Okay, fine. So you've done that one. So now we are going on to the tibia. Hold on to this one, please. Second. Good. Lord. 4 months now, please. This one, yeah. Take the top, yeah. Hold it. Something to clean and then, yeah. So you want to visualize forceps for me. You want to make sure, see what I've done was to take off the antemost portion of the medial meniscus. Can you all see now?
Some adjustment of the camera light has to be done, I think. Or the camera. So I think again for the delegates, this is what I was just pointing out in my presentation also, that in the case of an image-free system, you have to be very, very sure that there are no interposing soft tissues, menisci, etc. If you can register on a menisci, the robot will think that your tibia is much higher than where it is supposed to be. So all that soft tissue, that is why he's taking so much time to clear everything out of his way before he starts giving an input to the robot about where the bone surface is.
Yeah, absolutely. So we're going ahead now. So that's my midpoint. And this is the lowest point on the tibia. And the most posterior point, the easier way is extend and then give a valgus stress. You'll see better. Okay, go back once, please. So you're giving a valgus stress and then, yeah. That's the most posterior point. That would be difficult one. Usually the anterior point, the most medial, and the intercordial rms. And this is where most of the UKR surgeons worry as to how much you want to put it. So just go along the intercordial. This is where, frankly speaking, I feel more secure and more confident doing robotic UKR than the regular ones, because having done lots of Oxfords and this, I feel this is much easier, less adrenaline pumping in. Okay, so now we are marking the tibia. So I'm going with the anterior half first.
Regarding your registration of posterior tibial point, is it by tactile sensation or visualization?
Posterior tibial by visualization. Tactile, it's difficult, no, sir? Shashi, can you hold this one, please? You move out. Tibia. Okay, actually, you hold. Yeah. Lights on, please. Top light on. Suction. So, like I said, I want to visualize when I'm marking. I don't want to have air points. See, once I've taken my foot off the pedal, I'm safe. And I'm making sure that I'm marking. Yeah.
What is the amount of flexion that you're giving at this point, sir, when you're going
20
post?
degrees. 20 degrees flexion and valgus stress.
So probably I assume that that is your most comfortable position to paint the posterior part of the tibia.
True, absolutely. Yeah. So now if you see the model that has come up, so you want to align with the yellow marks. As you can see there, it tells us the size of femur is 3. Okay, and you want to make sure the implants you're going to put. Okay, so yeah, review tibia. So if you are looking at there, so we are in line with the markers. As you can see, the line there, you can move it up posteriorly, anteriorly, and then distally as well. So we'll come to that when we're doing the planning. Yeah. So that's our tibia. The most important thing is not to touch the slope. Okay, see, this calculates automatically with the leftover lateralmost cartilage, because as we all know, UKRs we do primarily in the anteromedial OA. So there is a posterolateral cartilage which is intact that gives us the slope. So you want to keep it as much as possible. So this gives us tibia size 5 with a thickness poly of 8.
For the sake of balancing, what slope are you ready to accept for a medial uni?
I wouldn't change much, like I said, but I'd stick with the regular, whatever is the patient. So that would be around 4 or 5 posterior slope. At the most 1 or 2 degrees here and there, but not too much. Next slide. Okay. So here we can see the graph there. So we are tight all over. There is 9 degrees varus. Okay. So this is where we are going to plan our uni.
So I'll just show the delegates again, like in the previous case, the graph baseline and all the points are coming only below, and they're in orange, which you can see here. So as you go from extension to flexion, it's getting tighter and tighter. So it's very tight in flexion, and in extension, it is probably a neutral limb without hyperextension or FFD. And that is why we're closer to the baseline and showing little loose in full extension. As we keep flexing across the range, it becomes tighter.
Okay. So we are changing the component flexion and also rising.
So can you just specify what changes you're making to the component to bring about the change in the graph?
What we're going to do is, this is tight. Yeah.
Yeah, it's
So
very
we're
tight
going
in
to
flexion as well.
It is, yes.
Yeah.
So varus, we don't want to overcorrect the varus. So as you can see, the varus here is 9 degrees. So I'll be bringing it around to 2 to 3 degrees, which is acceptable. You don't want to bring it to neutral. Again, patient will complain of medial tenderness. So we're going to look at the varus valgus first.
One point here, for the interest of the audience, is the stress graph taken with the Z retractor in or without, sir? Like, what do you prefer first, or
Z
what do you?
retractor, Acha, with that.
So very similar to the total knee that we saw in the morning. Here, the graph, again, you have to get it as close to the baseline as possible. So usually, especially because as far as uni is concerned, our experience is with the Mako, we accept anywhere between 1 to 1.5 millimeters of laxity is what you want. You don't want your uni to be too tight, because it will get overloaded and it can fail that way. You don't want to overcorrect it too much to cause a lateral compartment overload at the same time. So the aim of this whole balancing strategy is to get it to as close to baseline as possible through the range of movement, so that you'll attain balance and not overload the medial insert. So in this, you can change how proud your femur is, just like in a TKR. That means whether you are distalizing it or you're resecting more bone to proximalize it in case you have a tight extension gap. You can flex the femoral component. You can increase the tibial slope or decrease the tibial slope. And I think in uni, we don't give as much varus as we do in the case of a total knee. Maybe anywhere between 0 to 3 degrees is acceptable on the tibial component. So CT based, again, it's because it's not cartilage based, sometimes it can exaggerate what the slope is. But in our experience, we can go up to even 10 degrees also. This is, yes. Yes, yes. So it can be as high as 9 or 10 also. It may not be required. You can always take a decision based on the balancing. At the end of the day, the balancing is key. So you may start with a standard set slope of we keep around 5 degrees. If you need to, for the sake of balancing, we are okay going up to probably 8 to 10 degrees. But it's usually rare. It's not really required.
What is the upper limit of your femoral component flexion with Mako?
So femoral component flexion as such will be a little different in image base. The reason is we are not looking at absolute number over there. So in the case of Mako or image base, what we have is we have what is called as cartilage mapping. So just like how you can see the anterior flange of the femur, when we map the cartilage, we will be able to see cartilage in this area over here. So the goal there is to keep the tip just at the level of the cartilage so that it's a very smooth transition. Whatever flexion is required for that, we will accept it because it is a pure resurfacing procedure. Once you implant your femoral component, it should be just in line with the cartilage. So we do cartilage mapping there. And similarly on the tibia, we do ACL mapping. So you will be very sure that whatever point you have marked for your ACL, the lateral extent of your tibial tray will be medial to the ACL insertion. So the risk of you undermining the ACL will be almost zero.
I think this is a good point to take. Cartilage mapping is probably the thing that we should take from this.
Right. Okay. Okay, sorry. Can I have the glove change, please? Okay, guys, if you can see there, we're just playing around like on the video games. So what we are doing is to bring it to a little bit laxity post-op and also varus of about 3 to 4 degrees. We would expect the laxity to be about 1 to 2 millimeters. Now, as you can see the screen, now the graph is above the baseline. You can see all the markers. The graph is above the baseline. We have a varus, pre-varus of 9 degrees and posterior post-surgery varus of 7 degrees. I'm going to accept that, but when I'm placing mine, I would put somewhere in a bit more less varus. So this is where you can see I haven't changed much of the posterior slope, but I did about 1 degree, like I said. And here the component varus, as it is highlighted on the left lower side, the tibia, it is in 2 degrees. The component valgus there is 0, and the flexion is 31. Yeah, you're happy with the graph there?
Yes, I think it's very well corrected from the tightness that it had, especially in flexion.
Yeah.
So what is the final tibial slope that you have set here?
7 degrees.
7 degrees. Yeah. Okay.
Yeah. All right.
So is it the instrumentation error that you are considering while accepting that amount of virus, or you are just technically
Absolutely.
that your experience?
No, absolutely true. If I go back on the screen, look at the amount of varus I've put on tibia. It's only 2 degrees. And also if you see on the femur, it's only 0 degrees. So that's why I'm accepting around 7. But when I'm placing my component, I'll make sure that the extra 3-4 degrees is also corrected. Because it's always
expect that to be, sir?
No, it's always better to undercorrect. See, that is why we always, like the rest of the speakers said, don't just blindly trust the robo. You also should be watching yourself. So you go with your instinct and also your experience. So always undercorrect, undercut. If required, we can always do further cutting later.
Beautiful points.
Right. So as you can see the graph here, it tells us where it is loading. You can see the femur that's loading in the center, and also tibia, it's nicely loading there. And as I go along with my graph, it shows, that's a beauty here. It shows where the femur is loading, so there is no edge loading. Our main worry with the uni would be, if it is edge loading, there's always a chance of early loosening. Okay? Right. Femur checkpoint, please. Two hormones, please. Hold on to that. Hold that. Can I have a smaller one, please? Right. Okay. There we are. Thank you. Bit more difficult, as you can understand, compared to the total. Total, everything is like the peeled banana. So everything is there. Here you'll have to struggle a bit. Okay, so refine. Yeah, put it on cut schema. Okay, so the difference between total and uni is, again, if you see the probe, it is 5 millimeter compared to the regular one we do with a 6.
This is regarding the burr diameter.
Yes,
Yeah.
the diameter of the burr. This is smaller.
Advantage, sir? Any added advantage over that?
To cut less soft tissue. We don't want to do much soft tissue damage.
Is it the only advantage, sir? Anything else?
Well, that's the only advantage. Earlier days, as you remember, before CORI, it was Navio with Smith & Nephew. What I understand is that those days, it was only 5 millimeter burr. Later on, they improved it to 6 millimeter to make life easier for the surgeons. I guess, especially for the colleague surgeons also. Because most of us, as you do more numbers, what you do is you want to give this to your fellows, for them also get the feel of the robo.
So, Dr. Sunil, what exactly is the safety mechanism? For example, in the image base, you have haptic boundary. So let's say I'm burring into the lateral side of the femur, it stops me. So what is stopping you here? Is it the retraction of the burr head or is it something else?
Yes. Yeah, the burr head is retracted. It won't function. If you see there, now I've already reached where I want to cut.
Yes.
I'm pressing there. If you see there, that the burr doesn't work.
Right.
So it just simply retracts. So here we have everything. We have the haptic mechanism, the sound, and also if you see there, the burr doesn't move. If I go beyond my borders, see, I'm trying to go beyond my borders. If I'm inside the border, I don't know if you can see. If I'm inside, you can see the burr coming out.
Yes.
Okay. And if I'm going beyond my borders, it doesn't open at all.
So that's the point for the delegates, the safety mechanism in the case of this sort of an imageless system where that, so haptic boundaries, fortunately or unfortunately, are patented by Stryker. And that's how they're making their money. So in this scenario, the burr head will retract into the protective sleeve and the speed will reduce so that it will not burr any bone beyond that margin. So that's how it works.
So unless we plunge it in, we are not beyond the boundaries usually. And one more thing is, as you told, it slows down and retracts rather than suddenly stopping as in Mako.
I totally agree with you. Whilst you're doing, you want to make sure that you don't do it really fast as well, because you want to give the computer some time to analyze. If you just keep pressing on it, by the time it takes that extra probably 10 seconds, if you'd have already done, then that'll be a disaster. So you want to go watch the computer whilst you're doing, make sure that, like, when you're using your laptop, you get that sign where it circulates, keeps on going. So you want to make sure it's not doing that.
In the image, the red marks that we get, it's quite acceptable. Like, it's not that it is wrong. So for the benefit of the audience, this is the discussion. And we have to be very keen that we are just erasing that green boundary of that. So even if there are few red marks here and there, it's nothing much to worry about, because that is just the refineness of the instrumentation and not anything else.
So once I have done that, I'll have the nibbler, please. Hold it. Nibbler for me. I'm just tidying up the borders rather than cutting into the tissues. And can I also have Rasp, please. So if you see there, you're asking Nagarjun about the borders.
The red
So
marks.
that's what I'm doing. Yeah. So once I go there, I'm trying to rasp it out rather than go really flush into that. Check the top there. Right. Extend, please. Right. Okay. Hold there. Okay. Can I have the bar again, please?
One advantage of this system is we can go manually, correct whatever we feel like, and refine things in between, which is the beauty of this particular robot actually. As it was shown in the first case in the morning, some surgeons do save time by just conventionally taking off one cut with the saw and later refining it by using a burr. And that is very much accepted because even these come at an expense. The number of times we're going to use these burrs is going to be significantly increased when you do that. It's not just about all burr mode. We can even use a hybrid mode, like doing a part of it with the saw and part of it refining it with the burr. Because most of the sclerotic bone, when we plunge on it, it is going to take that sharpness of the burr, and we have to take more consumables. That is again a point of concern here when we come to finances.
That's what I do with my robotic TKRs. I usually use the saw to cut initially to take off the sclerotic bone. So
Any
that should be easier.
burr-based system is slower in terms of bone preparation. That is why even with Mako, they were having a full burr workflow for unicondylar. It turned out to be a big nuisance for the surgeon. His hands will be cramping like crazy. Then they made it half and half. They made it like a tibia cut with saw, and then posterior cut of the femur with saw, and the other things you do it with a burr. So it's 50-50. As far as TKR is concerned, that is the same reason why saw-based systems are much faster. So Velys, Mako, all these things are relatively faster, and that is why it's very, very rare that after 25 to 30 cases, the robotic surgery is longer than conventional surgery. It will always be faster.
Now, if you watch there, I'm trying to triangulate there to get that hole. If you can see the blue and the green. So you want to be in the center. The green is the tip of the bar and the blue is the direction of the bar. Yeah. So you can see I've gone gray. Always
It's
interesting.
actually, yeah. A thrombosis, I think Dr. Krishna Kiran himself has published about himself. It can cause
Sorry, I didn't
a thrombosis. No, they're asking whether the constant burring can cause occupational hazard for the surgeon.
Yeah. That's why you should always keep changing. That's how you get your junior colleagues interested in the surgery as well. So always what I suggest is once you have done enough numbers, get your junior colleagues also to get a feel of the burr and then let them do.
Even in our experience, the two occupational hazards will be, one is this, you will get severe cramping and potential issues there. Second thing is hearing loss. So not with a uni, burr is better, but the saw, like in Mako, can probably you do 1,000 cases, you'll be a little deaf. Because
Fortunately, CORI is good in that way. We don't get much.
CORI is a little better. So we are actually doing a study on that. The peak sound is almost like 105 to 110 decibels. Luckily, bone preparation time is only three minutes. But if you are a successful high volume surgeon, then probably start wearing some. There are people who wear gun range earmuffs while operating with robots because they are far louder than conventional saws.
Okay, guys, coming to here.
Bone dust, possible, yes, especially with the burr-based ones.
Right. So now we have put the trial femur there, and you can see there, that's nicely sitting all around. Okay. Right. Now get the tibia out, the femur out, please. Now we are going on to the tibia. Can you all see there?
Yes, sir, it's visible.
Yeah, fantastic. Come. May I have caucus, please? Left hand to left hand open, right hand open. Thank you. There you go. Take it off. Thank you. We also have different modes on this bar. It's called speed mode, wherein we take off the sheath. Okay, can I have diathermy, please, and forceps? So I'm taking off the leftover meniscus. I really feel people who have done enough UKRs, majority will switch over to the robotic because it really takes your stress off when you're doing the tibia, especially because you're worried about the direction. Can I have a nibble, please? Take your hand off. Hold it. Valgus stress. Osteotome for me. Osteotome, please. Hold it. Thank you. Smaller one.
Hello.
Taking off a small amount of osteophyte at the back. Yeah,
Sir,
caucus,
in
please.
this case, ACL is intact?
Yes, it is intact. I'll show you that in a second.
Because intraoperatively, we have not observed you checking it.
Yeah, I have.
So
I've actually showed you whilst when I was doing that, I mean, when I was doing the check on the medial compartment and the lateral compartment as well. That's when I watched, but I didn't display to you about the ACL. I'll show that in a second. Yeah, and I've got MRIs of the knee as well to make sure the ACL is intact.
did you ever plan ACL augmentation while doing UKR?
Frankly speaking, you won't believe, yes, when I just returned back from London, that was almost 10 years ago. That's an interesting story. It was a army Jawan who was 36, who had medial OA plus significant medial OA plus torn ACL. So at the time we didn't have robotics. So I said I'm doing ACLR plus medial uni. And guess what this Subedar or whatever you call the doctor there, he said, I'm cheating the Jawan. Then I had to write a 3-page letter. Boss, there's a new technique because doctor didn't know what is the medial UKR is. He was just thinking that there's nothing called partial knee.
Okay.
The only thing they heard was total knee replacement. Then I had to write 2-page letter. Then came the apology.
Okay, how many years did that knee survive?
Still going on.
So
It's
how
10
many
years.
10 years. Okay.
10 years now. Yes, sir. Because he's very young. So
I think Dr. Sunil has a beautiful series of cases regarding ACL repair, and he has his own technique, if I'm correct. And it was published also.
Absolutely, Nagarjun. Yes, ACL repair also, which as you actually we see it more often now. Early days when I started my ACLs 20 years ago, majority were reconstructions. But now we can see that the ACLs are lax. Knife for me. ACLs are lax, and you wonder what to do with that because they're not completely torn. So that's where I suggest that better to repair so that you give a bit of stability. Right. Okay. So I was struggling with that thick meniscus. I'm sorry.
Did you ever reduce the slope, tibial slope in ACL deficient knees in UKRs?
Yes, but I didn't do any ACLs, any medial knees so far without ACL.
Without ACL.
I would rather do an osteotomy.
Okay.
Because I'm a bit worried because your knee is not stable. So even though you do your fixed bearing, it's more of extending your indications. But my indication in that scenario would be to go straight away for a osteotomy, high tibial osteotomy, and then plan for the slope accordingly.
Slope. Okay. So how many times you have converted to a TKR after making UKR cuts?
So far 2 times, sir. One was last week.
Okay.
Right. Okay. I don't know
What
if
was the reason?
The lateral side also was partially involved. So it was like, a centimeter of the bone involvement. But I don't want-
But
Can
how
I
did you
have,
observe
open
that through this? So how did you observe that cartilage from this incision? Because it's not possible to see. Did you do scopy?
No, 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 no. I'll show you now. You can see from here also. Can I have a grabber, artery clip, something? So then osteophyte at the back. No, I'll show you in this one only. Always when you do the incision, the first things and first and foremost things you are going to do, like, okay, thank you. So what you do is once you've done the incision, get your finger out. So if you see there on the lateral compartment, you can see whole of the lateral compartment there. I don't know if you can watch that. Swap there, please.
No, it's not visible for us.
Beyond the pin, we are.
Moments.
Beyond the pin, we are not able to see.
I'll show you. There you go. Hold it. Can you see there?
Yeah.
Yeah.
Not
So
totally.
whole of the lateral compartment, you can see a bit of trochlea is accepted, but not the lateral compartment. You have to watch everything. And your question about ACL, sir, the ACL is there. As you can see, can I have something to probe this one, please?
Yeah.
So this is the ACL. As we know, the attachment is to the lateral. See, I'm probing my ACL. Can you see there?
Yeah.
Yes?
Yeah.
So the ACL is intact. So that's perfect. And the lateral compartment is pristine, right? Okay. So we'll go ahead with the tibia now. Come.
I think at this point, like a surgeon with arthroscopy background will have clear advantage in arthroplasty like this.
Frankly,
In terms of assessment of ACL.
yeah, I agree with you, Nagarjun. And also, frankly speaking, I mean, I worked there for 10 years in UK. I don't know who has subdivided like scopy, plasty and all. Sometimes it does help if you have knowledge of both. See, sometimes when I'm doing my scopy, I might have to open up. So sometimes these plasty incisions, revision knee replacements, these do definitely help us. So I would urge all the colleagues to have experience of both. Just don't stick to one area, one area and say I'm a scopy surgeon. I would suggest that you should have exposure of both. See, if you have to open up the joint, you don't want to be left over.
True, sir. Agreed.
Right. Okay. So coming back, so we're on the tibia now. So we have two modes on the tibia. So like you see, Dr. Loki is showing us that speed mode, much easier. Yeah, take off this sleeve. Take off the sleeve, please. Careful. Take a mop. Yeah, fine. So you can see now. Okay, so we can just undermine there. Right. Okay, watch here, please. The tendon, patella tendon. See there. Watch your hand, please.
Sir, can you highlight the like precautions that we take while using this speed mode, sir?
Absolutely. See, because now it is unsheathed, so you have to make sure you're not very close to soft tissues. And you can see there where my end of the probe is. So I'm being careful. That's right next to me is the patella tendon. Yeah. So it's much easier to go with this mode.
Yeah, the point to be taken is all the protective mechanisms of the sheath are not there here. We have to be extra confident or extra like skillful to handle these things. Again, it depends on the experience of the surgeon because Dr. Sunil has done hundreds of them. Probably it's not a tough job for him.
Yeah, initial ones, yes. Please go with the regular mode. Once you start using that on a regular day-to-day basis, I'm sure you'll appreciate that this is much quicker. See, I'm almost down now. Okay. No, you can get this one that. So this is where we use a reciprocating saw. And always I'm worried about the fractures with the reciprocating saw. If you're going too deep. Suction, please. And also you always wonder how much to cut laterally. So sometimes you might be cutting more onto the tibial spine and you lose your ACL. So this is where this robotics definitely help for more precision.
I think on the tibia side, two issues, sir. One is undermining the ACL, and second one is how deep we go.
The depth of the
in the
tibial cut.
depth of the tibial cut, causing a stress riser or a fracture.
Absolutely.
I think there was a beautiful image in the beginning of our planning which shows the extent of the tibial cut or burring, so which the robot itself gives. There was a pointer which was actually placed in the exact location where we should limit our cut to prevent the undermining of the ACL.
Dr. Kalyan. Am I visible? Right. Okay. Can I see the tibia? Yeah. Right. So this is the beauty in India. There in UK, you're left with, I'm sure lots of my colleagues there and agree with me. You're left with only one nurse to struggle. Here we have good colleagues around helping us. So, oh, sorry. So now I'm a sculptor now. So actually what I see here is based on my planning. Probably I've overmarked the posterior. That's why always visualize when you're cutting. Don't just blindly follow the robo. So that's yeah. Okay, we'll do one thing. Keep it there and then give a valgus press it. You take off your hand, lady. Can I have suction, please?
Is your
So that's
burr
the
going to
back.
stop when you're going posterior, sir, here at this point?
Yes, yes, absolutely, absolutely true. See, this is the beauty of this system. If you are with fully automatic, our main concern would be if it's entirely depending on your markings, and sometimes it goes haywire, you're gone. It might injure your vessel. See here, I'm taking so much time to cut the tibia, and I don't think it's the same with the fully automatic. I mean, anyway, my colleagues who does them regularly can tell me. So this is entirely in my control. I can do at my pace, and I don't have to be worried. Right? Can I have flash flip? So we've done most of it now. So the rasp has two sides, on the inferior side and also onto the sides. So all the markings there can be rasped out. Okay, okay, right. Okay, so can I have the bar again, please? So you want to make sure you've cut the anterior enough. Okay, so the majority is gone. Right, so a bit more on the anterior end. Can I have 4 months here? Okay. Yeah. Leave it up. Yeah. So just bit of there. Diathermy and force it for me. So with the tibia, it's usually your call. What size? Usual, whatever the robo suggests. But you can also eyeball and see there physically.
He finalizes the file, then it is done.
Yes, yes, yes. I guess you guys are waiting for the next lectures.
I think the procedure is almost done. I think once we do trials and do a stress graph reading, then it's done.
Absolutely. So I'm just taking out that corner, the anterior corner, as you can see. It's like a sci-fi movie, isn't it? Okay, come, get me the RAS now, please. So that's a corner that was troubling me. Okay, can I get the tibia? What size is that? So in the tibia, you can see at the back, there's a small, what do you call, projection that you can go into, hit onto that posteriorly, and then you pull over, tug over, that you'll know the exact size. So now if you see there, can you focus there? If they can see, lift it up and show them. I don't know if they can see. So this was size 2. So there's still more space. Can I have size 3, please? Still more space there.
Sir, can we see
both
that
the
jig again, sir? Can we see the instrument again, sir, for the benefit of the audience? Because it's not
sure.
seen.
Both the UKR and TKR, both the UKR and TKR, what I suggest is you want to place the implant as much possible on the periphery because you don't want it to sink. Now, coming to the instrument, you can see there the sizer at the posterior end. You have a small hook-like thing. So it hooks onto the posterior aspect of the tibia, and then you size it. You see how much coverage is there. Okay. So I'm going to the next size 3. So that seems much better. See there? Can you all appreciate that?
Yes.
Size 3. I think you have to raise it up. Okay, let me get the leg down for you. Can you appreciate that? Can you see better?
Yes. Yes, sir. Yes,
Yeah.
yes.
Bunch of height and let this go. Oh, careful. The mark.
As Dr. Sunil was telling, even in uni or total concept of cortical loading remains the same, especially in osteoporotic patients where there is a lot of chance of sinking. We should focus even more on these cortical loading principles in uni because we are just dealing with like half and half.
So we are going with size 3 now. So let's go back with the femur. Now I'm going to take out my KVS. Nibbler, please. So when you're doing your final trials, you want to make sure nothing is coming in the way of the soft tissues and your implants. Always check that you have come out completely. That's another important thing. You don't want surprises on your x-rays. Yeah, yesterday I had a patient who went for an MRI wrist, and on the MRI, they said there is metal artifact. He wasn't sure what happened. Then later they realized he had some, the angioplasty from the radial artery. And whilst the doctor was doing, they left a small piece of metal there that was not realized even by the patient or the doctor. So that will be interesting. So always, even if you do a mistake, I'm sure you want to know first.
So just as an add-on, I think in this scenario, you will be doing the tibial keel preparation manually in this case, right?
No, first I'm trialing this.
Okay.
So the keel will come on to that. As you can see now, that's beautifully seated.
Right.
I'll show that in a second. Okay, let me show you one second. Can you see the tibia now?
Yes.
Can we adjust the light? So that's, see the anterior. Brother, can you turn the camera this way?
It's
See,
flush with the anterior cortex.
It's flush with the anterior, flush with the medial. Yeah?
Yeah. Yeah.
That's a medial. Flush there and flush here. So that's sitting fantastic. Right. Okay,
Right.
come. Come. One second. Lift it up, please. We'll do one thing. We'll put the poly later. Yeah, thank you.
I think poly later is a little easier with uni always.
Much easier. Much
Yeah,
easier. I
because
know.
it doesn't engage the posterior like we can in TKR.
Suction, please. There you go. All right. Lift the leg and flex the knee, please. All right, fantastic. Thank you, boys. Right, impactor now. What's the size? So we are with 8 now. Let's try. So let's see whether our undercutting help. Yeah, fantastic. There you go. Impactor once again.
Any note on slope of the poly, sir, in this instrumentation?
It remains the same, isn't it? Like we discussed, I went on one degree extra onto 7. The initial slope was 6. So to get the balance, right? Okay. So now, first things first, full extension. Okay, and then full flexion, no spitting out of the poly. And now let's see on the image. Okay, so if I correct it, it's coming to about 5 degrees. So probably when I put my implants and all, see that's coming to about 3. Okay, between 3 to 4. The flexion here is interesting. Now, this is in relation with the head of the femur. So always what we say is anywhere around 5 to 6 degrees is okay. We don't have to have 0 flexion. Now, if you can appreciate there, I'm sure all of you can see that it's completely dead straight. Yeah.
Yes.
So that's what to 1-2 when you're trying to extend it more.
Yeah. So now we are coming to the range of movement. Yeah. Okay. Continue. So now let's see our graph. So that's really beautiful. Can you all see the...
Beautiful, sir. Nothing comes down.
Yes, it's just exactly on the horizontal. As you can see there, we are much less, around 1 millimeter of laxity, if at all anterior and posterior. All through the midway, we are fully tight there. Can you see there?
Yes.
So that's well balanced. Yeah, fantastic. Any questions?
I think it's pretty clear. And what we planned for exactly that graph, the same graph is being reproduced at the end with the trials, which is the important point to note.
Absolutely.
Yeah.
Thank you. So we'll go on
to
preparation
also, or we conclude this session? How did we?
Yeah,
I'll leave it to you. You have to
manual, so we can proceed, I think. Yeah.
Where
So
are we now?
I think Dr. Sunil will move on to the next talk, since the tibial
Yeah,
preparation part is manual based on the sizing you have done. So again, thank you for a great surgery.
If anyone wants
Thank
to
you very much.
tibial keel preparation instrumentation, you can just have a look at that.
Yeah.
Instrumentation.
Anyone in the... Yeah, sorry to interrupt. Anyone in the audience have any questions? There seems to be a big audience, like lots of interest. Okay, anyway, guys, thank you for having me. And unfortunately, I have to leave out of station, so I won't be joining you in the conference. And I should thank Dr. Balaraaju for conducting such a fantastic event. And also the Yashoda staff, especially the theater staff, they have done a fantastic work, the Yashoda management and team. So we'll hopefully have more robotic. Yeah. So today we have lots of gadgets. I'm sure lots of us boys like gadgets. So I'm sure it'll be interesting session all day through. Okay, thank you. And you want to stay on or you want to proceed further with your talk?
So just if you can show us the keel preparation instruments, I think we can log off.
Oh, yeah, absolutely. Yeah. Okay. Focus for me. In our moments. Moments, please. Lift up the leg. Yes, thank you. So now we can see there, we have an instrument there with 2 points. Yeah. So that's what I'm going to put there. So the keel preparation, not exactly the keel preparation like you see in the Oxford, where you have to cut through. All I have to do is this. Right. And show me the implant, please. No, so show me the trial implant with the keel. So I have two, like you can see, 2 pegs there. Okay. So this is what we're going to have. The pegs there. And then that's what is going to be. Right, Shashi, and this is now. Okay.
You drill it or you just bang it, sir? How does it go?
Yes, you just have to, like you have seen, I'll show you the 2 points. Can I have diathermy, please? So this is 2 points there. Open the original. See, there is one there and one here. We are going to mark it. And this is our keel. I'm going to put further small drills so that your cement is nicely integrated inside. Yeah. I'm not sure if you were expecting something more like in your Oxford, where you have to drill through the slot and all. Yeah, open that one. I'll show you that implant in a second. Original UP, no? So, I mean, after moving over to robotic, I would say UKR is much, much easier compared to your. I did the 2 phases of Oxford. The first phase where you have to see 6 points, parallel and anteroposterior, all these things. Whenever you do that, you always have your heart beating more than 120 or so. So this is much, much easier once you have done your planning. If you have seen me, I was quiet and muted when I was doing the planning. That's the only phase, probably about 5 minutes. Once you're done your planning again, it's a very easy game.
I think that's one thing which people neglect to talk about. Yes, there is definitely a benefit to patients, which will all be, justified by literature in due course. But even from a surgeon's perspective, the amount of time, anxiety, stress, decision making that robotics reduces during surgery and the trial and retrial recut methods has significantly come down with robotic, which makes your efficiency much more. You can do more number of cases with half the stress.
And lifespan is more.
Lifespan is more, correct. You may be a little deaf at the end, but you are at least living longer.
Right. Okay. So coming back to that, that's my original tibia implant. As you can see, there are only 2 pegs there. So that's what I'm going to place it where I have drilled my holes. Yeah. So that's my tibia keel preparation. Okay, boys. Okay. Can I have the wash and something to clean up, please? That I mean forceps.
Wonderful, sir. Actually, most expected and anticipated topic, and it was so beautifully portrayed by you and presented also.
Thank you.
I think most
Thank
of the
you. Thank you all.
Rasha, I think like we were having a discussion regarding one ski athlete who had a uni. I think you can share your experience regarding.
I think if people follow sports a lot, there is a US athlete, female athlete who is an Olympic skier called Lindsey Vonn. So we recently, as far as the striker is concerned, the Dr. Martin Roche from Hospital for Special Surgery is a pioneer and designer for the Mako robot. So that lady had actually retired completely from international sports around 2-3 years back. She was already post ACL reconstruction with medial arthritis. And this week she's participating in the international championships on behalf of USA again because she underwent Mako uni after an ACL reconstruction. And she's squatting more than what majority of orthopedic surgeons can squat in the gym as well, which is very great.
Yeah, there's a point
Oh,
to
that's
note.
nice.
Like, all these unis do wonders. Basically, it's not just like you get back to your radials. It's you can sport, you can be as active as before.
Do extreme activities with a partial knee at a young age, and it does last. Even despite that heavy activity, it can last as long as 7 to 10 years, and it's an excellent stopgap for people with arthritis. So when HTO is not an option, definitely consider a uni.
Even better.
Yeah. I mean, I feel uni is far easier to do with the robotic and also far easier to revise to a total knee compared to your HTO.
HTO, that's true.
So, yeah, given a chance, if somebody is there young, I'd rather do UKR, give it some more 10, 15 years, and then go for a TKR rather than a HTO, because we all struggled changing from a HTO to a total knee. So again, getting the access, again, probably the robotic again might help in those scenarios once you get the HK access. But anyway, that's individual choice.
We'll conclude here. Thank you, sir.
Thank you. Thank you for having me.
Thank you, sir. Thank you for valuable words as well as we are so blessed to see all these live surgeries. Thank you so much.
Thank you so much, sir. It's really
Thank
great
you once
to do
again for the panelists for joining this live. And then now let's move on to the next live surgery, which is a relive from Dr. Ratnakar sir on Velys. I would like to invite the next panelists onto the stage. Dr. Jagmohan Reddy sir, please join us. And Dr. Sharad Babu. Dr. Jahangir Basha. Dr. Sheshikant sir, please join us.
Pointer. Marker. Pointer.
Sir, welcome to second ONUS robotic surgery. We have a very senior orthopedic surgeon, Dr. Ratnakar sir. He's going to give a relive with using a Velys robo. As you all know that Velys is from Depuy Johnson & Johnson. It came into the market in 2019, but from 2022 onwards, it is available in India. So over to you, sir.
Thank you, sir. Thank you very much. First of all, good morning, everyone. I think I should thank Dr. Balaraaju because it's a great effort. It's not an easy thing to bring all the robots on one platform to discuss about various things on how the robo works and what is the disadvantage and advantage with various robots. It's a great effort lying with, I should thank Dr. Balaraaju, Ravi and Karthik also. Thanks for the panel. So the Velys robo is a table mounted. It is not a mission should come to the, you can operate both the things. It contains a satellite station and base station. So there is a calibration. Initially, the robo functions. We should do the calibration for every time before the surgery. Once the calibration is done, this is the screen where we can plan. So whether you want a mechanical alignment or a patient-specific alignment or kinematic alignment, what we think, I think a lot of lectures has to come on that. And you can choose whether a PS or CR, anterior referencing or posterior referencing, and your points of marking like primary cut based on posterior condyles or transepicondylar axis or right side line. Depends upon the patient profile, you can change the flexion or extension where you want the component, pre-planned, and what is the slope also. So you can manage your patient-specific thing or surgeon-specific thing every time. This is the planning screen, initial planning screen. So next, the robo will come. You can attach it to the table or otherwise you can operate, but it is a cumbersome because the assistant can't go around if you had this such a bulk mission here. So this is a slim thing. Once you attach this mission, I'd like to move forward a little bit. So it's a table mode, table railing. Once it is attached, we can attach the saw. So we need to saw calibration, means it will assess the weight of the saw. This is the initial procedure. It will take few seconds. Once it is done, you can move away the robo. So it doesn't come in the field. It is required for only cuts. So it's not obstructing any of you going around the table. So once it is done, the procedure is regular. I'll approach a midline, parapatellar. The incision as required, minimal for me because I'll put pins outside, or if you want to put pins inside the incision, it's an extra inch of cut will be there. So no releases. I'll remove the meniscus, as I said, medial meniscus as far I can see that, and lateral meniscus because it should not come in the registration. I required exposure on the tibial plateau is required, and minimal exposure or minimal release which required for the tibial subluxation. So no medial releases, nothing. So I want, next comes the pin placement. This is the femoral array. Once it is done, the tibial array also. And 2 separate checkpoints should be there. And the important step is registration. That's more important, where we need to spend some time on this. So entire procedure, this registration is important. All the parameters. Why registration is so important is it gives an axis identification for you, how much depth you need to cut, and important thing is balance algorithm. If registration goes wrong, everything is wrong. Sorry. So based on your tibial checkpoint, femoral checkpoint, this is the order of registration in Mako robo, sorry, Velys robo, femur rotation, medial malleolus and lateral malleolus, that's for tibial axis, center of tibia, identify the point on the highest or lowest point, depends upon where you want the cut. Lateral condyle, usually lateral plateau will be the highest, 9 mm from the top point. Femur center, right side line, and mapping of medial distal condyle, lateral condyle, and posteromedial and posterolateral. This is the order. So I'll take the PCA axis, not the transepicondylar axis. That gives a rotational advantage for me. And anterior cortex. You should draw a line from the bow of the femur till you get the flange of the trochlea. And this is the validation, whether your points are right or not. This is an important point. If anything is wrong, you can go back and check and redo that mapping again. So mapping is more important. It highlights the highest point. Usually the system takes the highest point of the cartilage, from where the cut usually measured depends upon the implant. If anything you don't feel, go back again, redo it. So after that, we'll get the initial alignment. So the system gives how much varus. The first column shows the varus, valgus angle. Second is flexion and extension. And if you see this one, that's the medial and lateral line. The red lines indicates the minimal space for the implant, like 9 mm from the tibia and 9 mm from the femur. That includes both insert and tibial component. Tibial component is 4 mm and insert is 5 mm. That's the basic thing. And you can see what are the sizes and everything. So those 2 parallel lines is the balance. If anything is there, here you can change. It's like algorithm. Once it is done, you can change various parameters. So this is how the base station, the system shows. The first column generally indicates an extension gap. Second column indicates a flexion gap. And this is for femur flexion or extension. And this is the slope. Where this column gives the red means the enough space is not there. This is a tight thing. You should match the white lines. That is a minimum 10 mm gap. Or sorry, minimum both 9 and 9 mm gap. So any system gives the minimal basic insert. That is 5 mm. You can see the component size at the base and insert. And this is the time where you can play around. If you want measured resection, like a femur and tibia, you can change all the components and get it to the properly balanced here. So by changing various parameters or extension gap or flexion gap or femoral upsizing or downsizing, you can match these parameters to the near normal thing. Whatever you change, that is visible here. So obviously 1 to 2 mm is the thing that you need to balance properly. So you can get all the parameters to the near normal. or your desired level. If you want to change your insert higher up also, you can change little bit. So it depends upon. Usually I don't do anything. It's like a gap balancing for me. I'll take the tibia cut at 2 degrees to 3 degrees varus without any adjustments. Once the tibia is done for me, so here the robo comes back, adjust to the femoral condyle level. So I'm a tibia first guy, not the femur first. So I'll give 2 to 3 degrees of varus cut for the tibia. If you lost the checkpoint, once it is done, you can, the saw will come according to whatever you planned. You can't manipulate anything here. If you feel enough height is not there, I mean, enough cut is not there, you can change these parameters, go back again. And it's not like Mako that have a haptic boundaries. It's completely tactile sensation. Its button is in your control. Only the plane is not in your control. So you can stop whenever you want. So after that, after the tibia cut, this is what where tensor sensor, where the gaps equal or not, it will stretch your, stretch your ligaments also. So considering it, functional balancing is more important because we are not able to remove the posterior osteophytes and everything. It is not like, don't completely follow the mission and do the adjustments initially, because most of the knees becomes lax because posterior osteophytes and other osteophytes, we can't, unless we do the complete cuts, we can't able to remove it. So this is a sensor tensor. You can do the medial stress and lateral stress, again, redo the graph again. So initially, we can adjust for a major resection. If you're tibial balancing, you have a second time of check your balancing and plan your algorithm according how do you have to cut. So without release, after the 2 to 3 degrees tibia cut, almost you can see the lines are almost parallel. No need for any release most of the times. So I removed the femoral osteophytes and tibial cut. The balance are almost near normal, whatever your desired. If you want extra insert or increase the height of the insert, you can increase the cut also if you are not satisfied. So most of the times we don't require what we do in the conventional release, the medial tightness and everything. It can be go through the cuts also without releasing much. That is the idea of the robo. Once it is done, but the box cut is manual for the Velys system. It is not automatic like a CORI or something. You need to do the manual saw if you are a CS surgeon. So after that is the trial component placement, removing the rest of the osteophytes. And the final check, you can see how placed with the minimum releases. The line should be parallel. And mechanical or mechanical or kinematic element depends upon your patient choice and your choice. Mostly you will follow the restricted kinematics. What we say is 2 to 3 degrees of varus or valgus thing. And if both lines are parallel, that is beautifully balanced. And it gives flexion and extension. So once it is done, robo work is over. Now this is the routine thing, tibia preparation and there are 2 types of tibia in attune system. One is a regular one is a stem extension. Once it is done, the part is almost similar. Implanting. I do cementing on the components as well as on the bone base. For me, the tibia goes first, followed by femur. And this is the vitamin E poly. Advantage with this poly, the attune system, the poly goes with the femur size, not with the tibia size. And either way, you can adjust 2 sizes, plus or minus for the attune system. And this is the sliding poly. You can easily insert in. So once it is done. These are, I can't go deep into prographs. I'll simply show the X-rays, how it looks. So various examples of attune knee robotic thing. This is a stem extension. Fusion tibia. This is the regular tibia, how it appears in the X-ray. I think I'll end here. Thank you.
Thank you, sir. It was a great demonstration on Velys system, sir. Sir, you do all trials with the pins and then you remove the pins and you do the real implants. Especially in tibia, normally we mark the rotations. So it will sit correctly as a rotation, sir, with the tibial base. There is a possibility that it may change a little bit rotation of the tibia.
Generally for robotic, we can play around the rotation because I'll take the PCA axis. It's not 3 degrees for me. If the medial tightness is there, I can do the external rotation up to 7 degrees. So once you, because gap balancing gives what is the femur rotation component also. Once you cut the tibia, when you flex it, you will see how much gap is there between the medial side and lateral side. If you feel it's too much lateral gap is there, you can dial it down. You can do the external rotation 5 to 7 degrees. It's not like 3 degrees norm. You should follow in that.
Ratnakar, in this case, when did you decide to go for a PS instead of CR? When do you make the decision whether to do a CR or PS?
Mostly, I'll try to preserve for a CR guy. Unless if I plan for PS, that is gone. I can't
all
preserve
the
it.
X-rays which you showed,
Yeah,
all are PS.
because I send the box cut also for you.
Okay.
Because box cut, I want to show the box cut is not manual. Okay. If I feel the insert is not sitting properly, if I do the bone cuts or release the PCL. Yeah. So release the PCL or bone cuts. If the PCL is tight and the flexion gap is showing the insert is lifting off, I'll sacrifice it.
Sir, in other systems, you have a deep dish, that is anterior curvature of the poly. Even you can simply resect the PCL and put it at dish. You have attuned that also system available?
No need to remove it completely also if it is gap is not too much, unless, but if you feel the posterior osteophytes, you're not reaching behind the PCL, I need to sacrifice it. Otherwise, I don't sacrifice PCL. I'll do the minimal cuts and release it because it's an anterior deep dish also.
Sir, few of your cases shows bones are a little bit osteoporotic. Have you noticed any pins loosening while doing the trial or while taking the what you call measurements?
That is where the extra checkpoint should be there. Most of the people try to do the checkpoint on the arrays because if arrays can be moved because the vibration of the saw or some assistance also, the hand will touch. We never realize it. If you take a checkpoint on the arrays, difficult to assess it. That's where the checkpoint should be separate on the bone.
Should not recommend checkpoints on the array.
Any robot doesn't recommend it, but it is easy. We can reproduce it. So checkpoint should be separate. It should not be on the arrays. That's where the alignment.
Any questions from the audience? Dr. Bansilal? Thank you, sir.
Thank you very much,
it's a
sir.
Great demonstration. So may I request Dr. Raju also please come onto the dais. Ratnakar sir, please come here, sir. Panel discussion. Questions? So we will have a quick 5 to 10 minutes of due to this. About the small panel discussion about the Velys. When we entered this hall this morning, Dr. Bansilal from Government Hospital, Karimnagar, he wants to purchase a robo for government sector. So he's asking which robo is better. We have around 5-6 robos here. CUVIS is here, CORI is here, Mako is here, Velys here. What should I buy? Dr. Bansi has asked a nice question. Shall I buy a Velys? Shall I buy a Mako? Shall I buy a CUVIS? Shall I buy a Rosa? Shall I buy a CORI? So just I am revising myself about all the brand names. Sir, Sharad sir, you are one of the favorite of Velys system. So what do you recommend out of all 6 robos? Obviously, you recommend Velys. Why you recommend Velys, sir?
I've been trained in only in Velys. I have not seen much of other robos as hospital purchased Velys, but I'm very happy with the system. So as it is, there's no pre-operative planning like CT scan or MRIs, nothing is needed. Everything on table we can assess, and it gives a very good balance. It's easy to operate. We can mount the Velys system onto the table. So accuracy, what I see is very, very good.
Yeah.
So that's why I prefer Velys.
So sorry, is telling it's imageless, live, capture the data, wall mounted, easy to transport from one place to other place. And accuracy, precision cut, 5 mm cut, up to 0.5 mm cut. Yeah, that's very thing, sir.
One more thing is, for the conventional or traditional method surgeons can easily cope up with this Velys also because it's the same blade-like mechanism. So very easy to go with that for them.
As such, there is no bad robos.
Yeah.
If you want, what is your advantage? See, any robo is good. Technology we need to adapt because technology is in everyone's life.
Yeah.
If you deny it also, you can't upgrade yourself. So we need to follow what's going on. So that's where the robo gives an edge. If you are not training it, you can't tell the next generation what's next because technology never stops. Second thing is, if you are thinking of logistics, what do you want? If you are moving one theater to one theater, it should be flexible to move, easy to maintain. Second thing is, logistics wise, how much cost happens for every case?
Yes.
The, what do you say, disposables.
Yes.
These things we need to consider. And every robo in a matter, it is good, but you need to train accordingly. If you try to avoid CT scan, that's an advantage because CT scans, the radiation in that, so always we say it's 100 X-rays for something.
Yes. So Raju, I think you have used 3-4 robos in your hospital.
Yeah.
So what is your learning curve, sir? Which takes more learning curve? Is it Mako or Velys or CORI or
I think we did around, I think 200 cases of Velys till now. I think the initial for the first 30-40 cases, it was a little difficult to do the Velys initially. But I think now it's pretty much good. Like we complete the case in around 35 to 40 minutes max, by doing a CR in fact. And we have seen that doing a CR with the Velys is really good, like in balancing the joint and also the alignment and everything. And we hardly do the pike resting by doing a CR in Velys.
So you mean to say there's no difference in learning curve? All are equal?
No, there is difference in the learning curve. But
which is easy to learn?
Comparing to other, I have experience more with the Mako and I've seen CUVIS and Velys. I think Mako has the lesser learning curve because it's haptic boundary, everything is there and based on the balancing and joint balancing. But I think Velys is also just 5 to 10 minutes difference, that's all. Nothing major than that.
Okay. Sir, what is your thought, sir? Ratnakar, sir? Which is easy to...
No, haptic boundaries here feel safe. CT based because CT is also a double check. So Mako, easy to learn, error free. But learning on the image and everything, you require a little bit of training because once you adapt it, that will be easy because the system doesn't give you more space. So that system doesn't come in surgery. It's only required for the cuts. So it is like a routine surgery.
Yeah.
You need to spend 5 minutes for registration and 5 minutes for planning. That's it.
Yeah, especially with Velys, what we have noticed is initially, if you're doing a TEA-based workflow, other than the PCA-based workflow, you have a surgeon-derived landmarks. And there's some amount of error what we have noticed. So to prevent the TEA-based errors, we better choose the PCA directly and then do a better planning. I think that makes much difference.
So you won't use transepicondylar?
No, I think because there is around 8 to 13 millimeter of variation.
Reproducing TEA is very difficult.
Difficult, okay. So you define posterior condylar referencing is better than transapical
Yes.
points. Okay. So Dr. Sarath sir, how the Velys has advantage in managing the severe deformities like severe valgus, severe varus, or hyperextension of the knee? What is the advantage of Velys to correct the severe deformities?
Going for severe deformities, basically clinical assessment is very, very important, not only depending on the robo. When you have a huge defect on the medial side, on the tibia, so you should not take the deepest point because it cuts more tibia.
Yeah.
So where to take the point is very, very important. Usually what I do when the big defect is there, I usually place a bone graft over there and take a checkpoint from there.
Okay.
So that gives a minimal cut. Later, if you want to cut more, depending on the gaps, we can later we can do the cuts later time.
Yeah.
So planning is important. If it is a severe varus and recurvatum, mainly, basically, we should always do very, very minimal cuts. So it may show a little tighter on the robo, but it's all about, in the end, it's a clinical assessment. And usually in recurvatum deformities, when you cut tibia, it opens up. So minimal cuts you need to take in the recurvatum. And considering about rheumatoid knees, whenever you're planning on a rheumatoid knee, when you have a very lax knees, so I don't use tensioner. So tensioner will open up everything. So I don't use tensioner. I plan directly femur and tibia cut at a time.
At a time. Thank you, sir. So, Dr. Shashikant, sir, what challenges do you face in making the robo TKR, sir? So, if patient comes to you, walks to your office, and you want to offer, okay. Jahangir, sir.
The robo has limitations always. In very severe deformities, we can't go straight forward with robo. There you need your experience with the conventional techniques. Okay, and in case of Velys robo, I am using Velys. There is a very good freedom. Okay, but in tibia will have 4 degrees of freedom, whereas in femur you will have nearly 10 degrees of freedom. With that, you can manage the case.
Yeah, but what are the challenges if a patient comes? How you will convince for robo? Obviously, robo is a bit costlier than the traditional.
I came from Rayalaseema area where everybody asks for free.
Yeah.
Okay, Arogyasri, everything they will ask. But the thing
So
is,
you have included
yeah.
robotic in Arogyasri, sir, in Andhra?
No, it's not.
Okay.
But people are ignorant there. They will ask poor economic area.
Yeah.
So when the patient comes, we tell them the advantages of a robo over the traditional method.
Yeah.
As 5 of them are there, everybody knows. Thing is, there convincing the patient little bit difficult thing. But once you tell them the advantages, some of them may convert or may not convert, and then there come the cost effect there. So few people will ask very less cost where we cannot do the surgeries, and few people accept that. And thing is, in very severe deformities, selection of patient is also very important. Just you can't go and tell everybody you can go for robo.
So I think you are practicing in Kadapa, I think, sir.
Yeah.
Kadapa this. How many times you use the reusable saw and arrays? Saw, how many cases do you use? And arrays, how many cases do you use?
We most of the time we can't compromise there because it is a blade, 2 mm blade where we use it in there. If you go on using that for 2 or 3 cases.
How many cases in your experience, sir?
Hardly 1 or 2. That's
all.
Not more than, because if you cut that, more bone will go, and if there will 1 or 2 mm defect will be there again with your assessment and the final result.
Okay. What about arrays, sir?
Arrays, we can go for ETO and use them.
How many times? 4, 5 times, or?
Yeah, 10 times you will use.
Sir, how many times you use blade?
It all depends on your staff, sir.
Yeah.
How they are managing the arrays.
3, 4 times saw?
Yeah, definitely around 10 times we can use it.
10 times saw?
Yeah, arrays. Depends on how we manage those.
Yes. In Apollo, I think, Ratnakar sir, everything is disposable, I think. So even they have, robo is not disposable, I think, sir. Robo machine is not disposable, sir. Sir, Raju, the final question.
Regarding the patient education, whether to choose a conventional or a robotics, especially the robotic precision, joint balancing and alignment makes a lot of difference, because I think a lot of patients now are aware of what is happening, especially in the case of severe deformities, like more than 20 degrees of varus, or if there is a more than 10 to 15 degrees of hyperextension. Such kind of cases, we need to know exactly what is happening in the joint, and we can see lively, like how much is the values, how much amount of laxity is there, especially how to correct the lateral laxity and the rotation, how to for the component placement of femoral rotation to prevent all that. So that makes a lot of difference actually.
Ratnakar sir.
Robo is just a tool, but you are working.
Yes.
Robo doesn't give the planning, you are planning. So, see, deformities are not without deformity. You are the surgeon, you are the planning. Robo is just a mission, will give you an advantage for a better cutting. That's what's your precision. But you are planning that precision. So deformities or non-deformities, it's a regular surgery only. You need to plan where to cut and give instructions to the robo. Robo is not planning your surgery.
Yes.
That's the mistake people will do.
Yes, correct. Sir, how this Velys has integrated with artificial intelligence and virtual reality, Dr. Sarath sir?
I mean, Velys basically the precision, the accuracy, everything is very, very good. So what they say, and after using all this long time Velys since 1.5 years, accuracy is very, very good. It is integration and everything. So it's good.
Yes, sir. We got robo instructions from Ravi Teja.
So good.
Sir, you should finish
Virtual
off.
reality, see, next generation augmented reality and virtual reality, that's a costly thing that is still experimenting. Most of the shoulders were done and total hips are also done in the augmented reality. So what the robos or companies are doing is they are collecting data of the patients. They'll pull up, they'll generate new algorithm.
Yes.
That is where the artificial intelligence will come into that. It's like radiology also what we learn. They'll scan so many x-rays so that artificial intelligence without human, they can predict the diagnosis. That's what they are doing.
Yeah, that's it, sir. In summary, sir, Velys is a good robo, precision, 0.5 mm cut, reproducible, imageless, intraoperative live recording. It's a good, it has a very high speed camera, hydrophobic.
How do you convince the patients and
Yes, sir, that's a very
your trade secret?
It's a very good question, sir. Just it's a learning has no age limit. I learned robo recently after joining the current Institute Care Hospital. There is no age limit to learn. So you can convince them, sir. Only hurdle I face is the economic cost. We have to tell that this is this. We have to convince the insurance authorities that it should include in the insurance. Then we can convert most of the cases into the robotics, sir. As Jahangir sir told that he's going to represent a letter to the Health Ministry and Chief Minister and Prime Minister that robo should include in Ayushman Bharat and Aragyasri. That is a well point. If that is there, we can do robos easily. Dr. Bansilal can do in Kamaradi easily. Thank you once again, sir. Thank you.
Thank you, Jagan sir.
sir.
Thank you. Whenever you're on the stage, we always enjoy the discussion. So thank you all the panelists for joining us and sharing your thoughts. Now let's move on to the next live surgery from ONUS Hospital. Dr. Balaraaju is doing a knee. I would like to invite the panelists onto the stage. Dr. Kunal, Dr. Hari Prakash, Dr. Rajshekhar, and Dr. Sai Fani. Please join us on the stage for the panel.
Good morning, Ravi Teja. Are you able to hear me? Hello, Ravi.
Yeah, we are ready, Dr. Balaraaju. You can start.
Are you able to hear me, Ravi?
Yes, we can hear you. You can start.
Yeah. Thank you so much for all faculty members who all the way came from Bangalore, Mumbai, and Delhi. Special thanks to all our faculty members who accepted our invitation and joined. And almost 110 registrations were done from delegates. Thank you so much for attending the conference. Thank you so much, all the delegates and faculty members. And as the time is pressing, we have opened the joint. Can you open the PPT once?
Can you open the PPT?
This is a 63 years old patient. She's almost weight is around 110 kgs and BMI is around 39.5. She underwent left TKR in October 2023, almost 14 months ago, and she is very happy with the robotic surgery. As Mithun sir said, you are not supposed to do for high risk patients simultaneous bilateral. So I posted this after 1 year, and she is comfortable. And now I am planning for a right TKR. And this patient is, can you show the X-ray? X-ray is like, stage 4 arthritis. We calculated OMAX score, that is around 63. And what we are doing is a CUVIS live robotic TKR. As the panel discussion went a long time, we opened the joint, tourniquet time is up. And let me show you registration time, how I do registration. So standard approach I go, midline parapatellar approach. I was trained under Dr. Guruvar Reddy sir, so standard approach we use there, midline paramedian approach. And for CUVIS robotic TKR, we insert 2 pins into the tibia. You are able to see, right? So 10 centimeters below the tibial tuberosity. So the green one are trackers for the tibia. The
Dr.
pink one.
Balaraaju, can you shift the screen to the OR? Yeah, it's still the
Before going for, can you just open a walking video? Walking video once. Walking video. This is the yesterday I have taken this walking video. Play, please. I think it's not playing. Can you open up next slide? So she's limping, and the other side is done. So she's comfortable walking with the left TKR. Okay, next slide, please. This is a 3D plan. Before going for any surgery, we get a 3D CT scan. Can you open the video once? So this is known as J-Planner software, where auto segmentation is done in 2 hours. And it is all fully automated, where a surgeon need to upload the CD to the laptop, and it automatically segments the exact size. And it takes automatically center of the femur, various points on the knee, various points on the ankle and hip joint. And finally, it generates the 3D plan. This is image versus imageless robot. So image, this is what CT based. So we use before surgery only. We'll come to know what is the exact size of the femur, what is the exact size of the tibia. These are the various landmarks, like medial epicondyle, lateral epicondyle, anterior cortex of the femur, posterior medial condyle, posterior lateral condyle. We take it, and finally it generates the image like this. You can see here. I can this size, the size of the femur before surgery, it is around F. The opposite side I used E size femur. This is tentatively this is the plan, like F size femur. It is not overhanging anywhere. And we can check in 360 degrees whether anteriorly how much bone it is cutting, posteriorly how much it is cutting, whether is there any notching of the femur or not. Next, go ahead. Next, little slightly forward. This is the final plan we will get. And the tibia side also we got around 4 size. So robotics means I actually love robotics because you can measure really in 0.1 mm. So if you look at the femur side, the size of the medial side, it is cutting 8 mm and lateral side is 5.4 mm. It's all about mm because the poly thickness plays around 9 mm. The entire surgery aims to make the poly around 9 mm. I'll be planning the surgery around gap balancing technique as well as major resection I will be following in the surgery. And if you look at the femur distal side, medial lateral 8 mm and lateral side 5.4 mm. Posterior side, medial side 10 mm and lateral side 8.1 mm. The femur size of the posterior condyle thickness in the Meril, anything is around 9.4 mm. So I'll try to resect the same thickness on the posterior lateral side so that it will be trying to match and patient will don't have any mid flexion instability. And tibia side, as usual, medial side plan given around 1.7 and lateral side around 4.9. In the standard approaches, we take around 8 mm on the lateral side and 2 mm on the medial side. But in the robotics, you can play around 1 mm, 0.1 mm like that. Can you show the next slide? So this is one of the important slide where with the help of robotics only exactly you can reproduce what is the normal kinematics of the knee joint, whatever the patient has, 30 years back, what is the patient is having, exactly we can able to reproduce. For example, if I external rotate the femur, flexion medial gap increases, flexion lateral gap decreases. In the subsequent, while doing the surgery, I'll tell how exactly external rotation will be increasing, will be causing the flexion medial gap, flexion lateral gap, and even if you flex the femoral component, if you look at flex the femoral component, then flexion gap decreases and extension gap increases. These two things I'll show you while I'm doing the surgery. Yeah. Now I'll be going for any questions till now, Ravitej or moderator sir?
Yeah, it's very clear. Please proceed with the surgery, please.
Yeah, now I'll be doing the registrations, initial registration and final registration I'll be doing. So initial registration with RMSE value will be measuring. So this is the medial epicondyle. Collect, please.
Can you switch over to the OT view? Still on the PowerPoints.
Collect, please.
Dr. Balraj.
Collect. Yes, sir.
I'm Dr. Hari. We are not able to. Yeah, now we can see you.
Correct. Collect. 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 So this is the initial RMSE value, root mean square error. It should be less than 10. So it came out 8. If any technician or any technician done J-Planner software, here we can rectify that. If it is coming more than 10, I'll repeat and check it again in the J-Planner and come back. So initial RMSE value should be less than 10. Here it is 8.30, good. Next again, I'm going to collect 40 points on the femur. Collect. 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 So now I'll be doing on the posterior medial side. Collect. 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 If you look at here, the final RMSE value should be less than 1, but because of lot of osteophytes, I am taking consideration 1.5 as a reference value. If it is more than 1.5, I would have again retaken. Again, I am giving the medial epicondyle landmarks. Collect. Collect. So many surgeons ask whether the robo makes a mistake or not. Usually it won't make mistakes because you are giving lot of data intraoperatively so that it is not going to commit any mistake. The femur side registration done. Now I am coming to the tibia side. Tibia side also 7 points on the tibia side. Collect. 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 Collect.
So do you
So if you
collect
look
all
at
these
the
points
initial
before the
RMS on the tibia
osteophyte?
side, it is 7.5. What?
Do you collect all these points before the osteophyte removal?
Yeah, before osteophytes, because pre-op CT is taken with the help of, as osteophytes are there. Again, if you remove the osteophytes and register, RMSE value may go up. Collect, please. Collect. 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 collect, 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 collect.
For the
Collect.
audience benefit, it's important to collect the points over a large surface area so that the articular surface is well reconstructed,
Collect,
and not to
collect.
move the probe during the collection of the points.
Back, collect, 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 collect. Here the final RMSE value on the tibia side it is 0.54. So it's good that it's come less than 1, but on the femur side it is more than less than 1.5. It's acceptable. Again, third time I'm again registering whether that points are correct or not. If any point is not correct, then the system will not accept it.
So when you say these points, what are the exact points that you are referring to for the benefit of audience?
These are the medial side of the tibia, lateral side of the tibia, anterior tibia and tibial tuberosity, and medial condyle of the tibia and medial lateral condyle of the tibia.
So when these points are marked on the J planner, some soft tissue is not taken into account. Sometimes we are unable to reach that point.
Correct.
It's viable to mark it more anteriorly without erasing soft tissues. We can reach
Next,
it.
please. So automatically, once the registration is done, usually this automatically generates the image. You see here. So I am now I'll be doing gap checking. So this is the neutral gap checking. Collect, please. Capture with the varus gap check. Collect. Collect. So almost varus is around 6 degrees of varus without any stress. If I give stress, it's going up to 8 in the extension. Again, in the 90 degrees of flexion, collect, please. Collect. Collect. These are without any moving of osteophytes actually. So now I'll try to remove osteophytes and check it again. Once we remove osteophytes, we will get at least 1 mm gap again. In CUVIS system, usually osteophytes will be removed once the registration is done.
So can you show the plan of whatever values you have captured now?
You are able to see on the screen, sir.
It is blinking. So because we need to know what is the flexion status, extension status, which side is tight.
Can someone show that, Raviteja?
Yes. I think they're working on that. I think that the screen is blinking on our side.
So at least to understand basically how much was the pre-op FFD or pre-op varus?
Yeah, I think we can see on your screen
Around
there.
6 degrees of varus pre-op, and flexion is around also 8 degrees. I'll show you again once I remove the osteophytes.
So how much soft tissue did you release? First
I
point.
release only anterior 1/3 of the triangle. Discuss.
And how much osteophytes are you removing?
What?
What osteophytes are you removing now on the femur, tibia until the midline, or you're going up to the back?
No. I'll be removing only anterior 1/3 because the technique what I follow is I'll try to balance the knee on the lateral side. If you look at the image on the left side, that is gaps are showing around 8 and 9 on the maximum means with stress it is coming 8 and 9. So I'll be trying to insert a poly around 9. And if I want to, again, before going ahead, if I want to increase the extension gap, can you just flex, can you just increase the femur cut by 1 mm distal? You see here, 9 mm is the cut increased. Again, one more. See, it is 10. So I'll try to keep it at 9 mm poly. I'm trying to aim it. Keep it 9. Yeah, 9 here. So finally, once the bone cuts are done, either I can land up in 9 most of the time. If the joint is lax, I can keep it around 11 mm poly. For females, usually I keep 1 mm laxity. So I am trying to keep around 9 mm here. And if I want to increase, I'll try to balance knee on the lateral side. Medial side, I'll balance on the soft tissue release. Usually, I don't want to keep any varus or valgus. If required, I'll keep it either tibia or femur on the varus side. Sometimes, if anyone wants to balance on the medial side also, if anyone wants to balance, can you just keep varus on the tibia side?
Balaraaju, Dr. Fani here.
Yeah.
Can you please recapture the tensions, I mean, in the extension and flexion ones so that we can start balancing?
Yeah, again, slight osteophytes removed. That's why again you are asking.
Yes.
Yeah, capture. 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 So usually it won't change because we did a minimal soft tissue release. Minimal soft tissue release. And most of the time, as I mentioned, I'll try to balance only on the lateral side.
So you are tight on your posteromedial. Your flexion and medial is tight. It's 4 against the 7.
Yes,
7.
posteromedial it is tight. Now, if I want to show just for demonstration purpose, slightly external rotate it. If I want to increase the flexion medial, decrease the flexion medial gap, just internal rotate it 1 degree. Rotate.
You can fix the lateral and then rotate. To your center of rotation, you can keep it lateral and then you can rotate it.
I don't want to make it complicated. Lock at if I don't want to decrease the gap on the lateral side or arrange whatever it is showing, it is locking of the component. That side it will not cut. So if you look at here, almost medial and lateral it is balancing. 10 mm. Flexion extension gap, I am flexion extension medial gap I need to reduce. So just I need to flex the component, extend the extension is there. Yeah, decrease it, flex it. You see here, now it is 9. And increase the slope. So if I want to increase the slope, tibia slope, then only flexion gap will increase. Can you increase slope once? How much it is flexion? Slope is 3 degrees. Increase once. You see here 8 mm, 8 mm. And if I want to increase the both tibia and femur cut, I'll try to increase the tibia cut. So my aim is.
Do you change anything in the rotations on the femur to
at the moment
increase
external
your
rotation 2
flexion
degrees I
medial
kept.
gap? Sorry.
But problem is here is flexion extension extension medial gap is more. So I'll try to reduce that 1 mm also. Keep it in varus, femur. Lock it to the lateral side. Lock it lateral and make it 8 and 8. Extension gap should decrease.
So you're
extension
saying
medial.
before going ahead with the bony cuts, you're just trying to balance the lateral side.
Yeah, correct.
And
if I want to increase, make it 8, 9 and 9, I'll just increase the tibia cut. That's it.
And
I don't want to keep 9 mm on the medial side.
And how do you proceed with the medial side? What is the difference in the gaps between the lateral and medial side?
Usually, see, that's what I'm saying.
Because
till
you said
date,
you will
know,
balance the medial side by releasing the soft tissue
Correct,
and
correct.
osteophytes. So how do you know that how much gap would increase after you do that? How do you assess that?
For example, you are asking, usually the medial side, whatever, if I release the anterior rim side, that's what I'm saying. If gap is around 8 and 8, right? For this case, I am not going to release anything. If it is tight around 3 mm, 4 mm, then I'll try to release it. Usually, if I do bone medial side reduction osteotomy, I get around 2 to 3 mm. For this case, I am not going to perform any osteotomy or even soft tissue release also.
So that you are
Medial
going
side
to
extension
decide
reduce.
after putting your trial component?
10 of 9.
That soft tissue release, you are going to decide after putting your trial components?
Yes, correct. Are you now you are able to see here? I want to balance on the lateral side 9 mm gap, and the medial side also almost I reduce. I balanced in 9 and 8. But if I want, I am planning poly 9 mm. But sometimes if the joint is lax, sometimes it may land up 11. Now I am going ahead with cuts. Any questions till now? Hari?
What all are the changes which you have done now?
What's the final positioning of the
Final
femur and
positioning of
tibia?
the, yeah.
If you look at that screen, can you show that screen one? This output is not there.
It's not very clear.
It's not
No,
very
that
clear.
camera is there. Without camera, direct screen is there, then it comes good. You see, go back. This is the final output I am given. Before surgery, I kept, external rotation 2 degrees, valgus on the femur side 2 degrees, and flexion is 0. But distal cut I increased by 1 mm, external rotation 2 mm. The blue one is whatever you are seeing there, blue one. The middle side flexion under the flexion, that is external rotation. Valgus cut I given because I don't want to increase the flexion medial gap. Tibia cut also I kept in varus so that I am trying to balance the knee in flexion and extension only 9 mm. I am not going to release any soft tissue after the surgery, even on the medial side or any side.
Balaraaju, I cannot see here, but your flexion is still tight, appears to be. Do you want to increase your slope or anything?
Where in the medial side or lateral side?
Maximum, all right.
Max, I am trying to balance on the maximum side because once the cuts are done, you can try to release either. If you want to decrease in the increase, you can easily release the posterior capsule, medial side, that's it. But preoperatively, I try to balance the knee on the lateral side intraoperatively, and once the cuts are done, I'll try to balance on the lateral side, medial side. Chalo, we're going with docking of the femur. So for docking of the femur, usually general surgery robot takes 1 hour, 1.5 hours.
Balaraaju,
yeah,
there is a question from the floor, like, is the PCL and all resected, is what sir was asking?
PCL removed. I do all surgeries PS.
So you have removed it already?
Yeah, I removed it.
Right.
Because panel discussion was going on, that's what the time, almost turning a time, I waited for 35 minutes. So that's where I did a PCL. Before going ahead, I do remove the PCL. Because once the registration done, again you remove the PCL and everything again goes off. Robot dock first.
The osteophytes are to be removed after the registration.
Yes, after the registration.
Gap balance, you can remove the menisci and the ACL, PCL so that you know what the soft tissue laxity would be. And after this balancing, once we translate the tibia anteriorly to prepare the keel of the tibia, that also improves the laxity. That also causes some laxity.
We don't.
Spike, please. These are the extra pin I am putting for, is a fully automated robot where there is no need of, surgeon holding the spikes, all that. So these are the 2 pins I keep it on the medial and lateral side.
Where did you put
so
that
fortunately the docking robot takes less than 1 minute.
Can you please tell the pin placement for retraction?
What did you say? retraction. Just in the anterior 1/3 of the tibia and the medial and anterior 1/3 of the tibia and the medial. This recently I changed this to make it, what we want to say is orthopedic surgeon can go for a break first. Robot will finish the surgery and come out. Accuracy rate is the robot please.
If the IT team can look into the picture quality as well as streaming of the video.
And also the cameraman, if he can focus on the surgery that is going on and screen.
For the audience, during the resection, there are three options. You can choose the complete resection or the extension gap. So he's gone for the complete one in this case.
Proper enter
yeah, femur,
spikes
entire femur first.
Proper. Manchi spike. Okay. Tibia cut aituntadi.
There are two ways to attach the robo onto the bone. One is the clamp method and the second is with pins. So if you put the clamp, you avoid putting two pins and reduces chances of periprosthetic fractures.
ఎందుకు ఏమైతుంది ఏం కాదు సరేలే ఉన్నాను ఏమైంది అడ్డమేం లేదు కదా రెగ్యులర్ వేస్తుంది
We are not able to see anything clearly what you want to show there.
Camera please, this one.
Yes.
You are able to.
Can you zoom in?
Lights off, no? Now you are able to see the screen?
Yes. A better angle would be even better.
Just wait, we are trying to adjust it. Table height, please.
So for the audience, there are three arrays which are to be picked up by the optical tracking system. One is for the femur, one is for the tibia, and the third is for the robo. So all three should be aligned well for them to be picked up in that range. So they'll have to adjust the height of the table as well as the robo and the arrays. And then only they can proceed. Once they achieve that position, then they fix the robo onto the bone.
That give output directly, this camera you keep it properly. That camera, the desktop, it's blinking. Okay, now is it clear? Now we dock the robot. Now
Balaraaju garu.
Yes sir.
కొంచెం ఇంకా క్లోజ్ గా కెమెరా క్లోజ్ అప్ పెడితే బెటర్ జాయింట్ కి.
Correct. Collect. So again, once docked it, again it will ask for registration. Collect. Collect. So again, while docking also, robot will be asking for collect. So you can see here, the robot will move only on the yellow border. And you can see there. Saline, please. Suction పోయించుడా suction ఆన్ చేయండి suction they are not able to see the robot movement camera. Yeah, are able to see the blue one is the what it is going to cut. Yellow border is the what is the exact saline slope, please?
కెమెరా కొంచెం క్లోజ్ అప్ లో పెడితే బెటర్ ఇంకా.
Cameras, they are asking close up, please. And usually the registration will take around 4 minutes. The cutting will take around 8 to 10 minutes.
ఏరియల్ వ్యూ ఇస్తే బెటర్ కొంచెం.
యా ఈ సైడ్ వ్యూ ఉంది, పై నుంచి చూపిస్తే బెటర్.
Can the camera come from the head and this is better, yes, right.
So the bird trajectory is from medial to lateral, superior to inferior, cutting the distal cut, and it leaves a rim of bone in the periphery to protect the soft tissues, which can be later removed by a nibbler. The soft tissue retraction here is done by the pins, which are placed for the tracker system.
It is a 6-axis robot, we call it as, it will continuously, there is no need to stop the robot while you are doing distal femur cut. The surgeon role is here to check whether robot is cutting perfect or not. 99.99% it won't make any mistakes, but sometimes due to technical errors, sometimes, robot markers might move, or if properly not fixed, or femur markers might move. Once if it is moved, then surgeon has to stop the robotic, because that's how the patient positioning will come to known by the system. Why I like the robotics of CUVIS is it's fully automated. Error rate is almost nil, unless surgeons preoperatively, rather than marking medial epicondyle, lateral epicondyle marks, then error will be shown while doing the registration. Whatever the cutting it is making, it is almost 0.1 mm accuracy. Means the company says that is a sub-millimeter accuracy.
Dr. Balaraaju, it's a self-irrigating burr. So how do you protect the surroundings from the water being splashed around through the markers and everything?
I am not able to hear, Kunal. Can you little bit louder?
So being a self-irrigating burr, how do you prevent the water being splashed around from the...
That's why I use a helmet first of all. And then usually I use arthroscopy set. And usually my surgeon, I'll be out of the field. If you zoom out the camera, I'll be usually out of the field for 10 minutes. Usually for patients, we call it as, error. Can you zoom out and show me where exactly I am positioned? Zoom out and show. It is completely you are out of the field. Usually I come to the field after the tibia cut is made. Or if you want to register and then get it. And meanwhile, any more questions, Kunal? Because it takes around 6 to 8 minutes to cut the femur. I know you regularly does more than 300 surgeries. I know. Any more questions specific related to CUVIS?
So there's a question regarding the sterility if the water is being splashed around. So we can use a plastic hood to protect the water being splashed around. And if you see, there are marker for the bone movements also on the screen on the right side in all three planes, mediolateral, superior, inferior, anteroposterior. So if the patient moves, then the robo stops cutting. So we have had instances in which the patient was being given ketamine and for anesthesia and he was snoring. And the patient moved and the robo was not cutting. So we had to take the patient out from ketamine so that patient doesn't snore. It's very sensitive for movements.
We are taking distal posteromedial cut, chamfer cut actually.
Yeah, can you zoom into the cuts again? The old view.
I request Kunal and as a designer team for academic team from Meril, I request him to irrigation system also self taken by the robot. Like it's like Arthrex, they have the system. You need to incorporate this in the next version.
MISSO will come with it, I'm sure.
And one more problem we're getting with this markers. Suddenly if the spillage of the saline is there, that will stop. That is also problem is there. Maybe you need to cover that entire robot marker in a specific direction so that only the marker should be visible. That's where tibia marker, if you look at it, I covered with a mob.
So if the audience can see, a rim of bone is left behind. So it protects the soft tissue sleeve collaterals, and you're sure the burr won't cut it. Some people also.
Close. Now the tibia is cutting on the femur, robot is cutting on the medial side. Before taking this robot, many companies have claimed that it is an automated robot, it might cut vessels. It is a myth actually, it won't cut the vessels unless you kept your bone markers in such a way that you did not check it. It won't cut it. Whatever the haptic mechanism also there, in this haptic mechanism is also there. You see here the direction how it is moving. So usually bone cuts will be done in 8 to 10 minutes. Sometimes it may extend up to 14 minutes if any technical issues comes.
Did you ever had to revisit your bone cuts after you have cut with the robo? In any case?
Never. Maybe on the tibia side I did once or twice. This is the 100th robot surgery we are doing. Today we are cutting cake also. This is the 100th surgery after in last 1.5 years. The robot now it is making the lug hole. Exactly, it is going to make around 9 mm hole on the for lug holes. You see here, it is not going to make any mistake. Next step, please. Next. These are sometime technical issues come out of 10 or 20 cases. I get once or twice. Usually it is a seamless. Next. No, tibia. Lagal on the film. See, once the marking is done, if any technical issue also comes, it will not go and cut other place. Exact it goes there. I think some technical issue we are getting while making the lug hole. Go to the next lug hole. Please confirm. Next step. Pin name not there. Go ahead, next step.
It's almost the same, sir. The cuts and everything is almost the same. We can keep the cutting jig because we know the size before. So we can have that appropriate size cutting jig and we can do the cuts. Yeah. Initially also once or twice when we were putting the femoral pins for docking the robo, we had put it a little posteriorly. And when the burr goes and touches something else other than the bone, it stops there. It will not proceed further. And I had to take out the femoral pin and wherein the spatial orientation is completely lost. So we had to change it to manual. So we can do it with the same size cutting block.
Sometimes the bone is sclerotic, so the burr stops because of bone movements. So you need to have a sharp burr.
As Kunal said, the bone is very sclerotic and usually it cut it, but increase the saline. If bone is very sclerotic, the problem with this robot is the check and sleeve also damages. That's why it stops. Again, I change the burr. Very hard bone, 110 kg lady with, very hard bones.
So how frequently you change your burr, for how many cases?
This is the first time I changed it while doing the surgery.
Okay. So for every
Usually
case, you are
one burr I
taking a
use
new
it
burr.
for, usually one burr I use it for 2 cases, 2-3 cases. So the burr is, the beauty of the robot, it won't cut like blindly. It checks, gets a haptic feedback and go ahead. Now it is making the box cut.
The freedom cut that you call.
Can you zoom in, please? You see here how the robot is moving. While doing conventional surgery, sometimes you need to manipulate the femur exactly to sit it. But once you do cut with the CUVIS system, femur very nicely goes and fit into the cuts. You no need to manipulate. Mosquito, please. Mosquito. No, go ahead. Usually, sometimes while doing box cut, the bone will come sometimes as an obstacle. So I'll remove with the artery to save the time. Otherwise, again, it will take 1 minute to restore it.
Any reason you do all PS knees other than CR?
I did not
The
get you.
robotic. Any reason you are doing all posterior stabilized knees with the robotic, not CR?
I was trained with my boss, Dr. Reddy sir. Usually my patients are, our patients are very happy first 3 months. I feel, we did a study, CR patients might be unhappy in the first 1 or 2 months. Even, good results with PS, maybe surgeon will be taking little time extra to cut the box cut. But, I feel, lax knees for female, tight knees for male makes good difference. So femur cut is done. Now we are going ahead with TBR TBR verification. Yeah. Here is this. ఇంత దూరం వచ్చింది.
I think you should press into the soft tissue.
It is into the soft tissue only.
And almost onto the bone. Yeah, that's when.
Spike, please.
So while collecting the points also, it is always important. You are not putting on the soft tissue or even the cartilage. You have to
Please,
put
light.
onto the bone.
Now it is cutting on the medial side.
There is no need to translate the tibia for the tibial cut. It will easily cut, leaving a haptic boundary, protecting the collaterals also. The only thing is the patella tendon, one has to be careful. One can hold the patella with a towel clamp or put a spike to protect the patella tendon when it cuts the lateral side.
But I think when it is cutting on the lateral side also, it's coming from the medial side. It's not coming directly from the lateral side.
The bone is really sclerotic. First time I am seeing this kind of female with, obese patient is having sclerotic bone. Any patient is weighing more than 100 cases, I usually use extension rod for, longevity. This patient is also I am planning for extension rod on the tibia side. This is for extra safety I am using, that's it.
So I've seen some surgeons doing a freehand cut less than the required tibial cut to help the robo execute it better in sclerotic bones. They cut off the tibial spines.
So even surgeon puts a spike and presses, the system will detect and stop it. So even patient coughs, intra-abdominal pressure increases, then robot will stop. That much of haptic feedback engineers have built into the system. So bone movement, you just see it, bone movement is decreased. Just I want to try to protect the meniscus. I am just applying a firm pressure. I'll try to remove it and see it. Go ahead. So tip medial side cuts finished. Now only left on the lateral side. The advantage with this robot, this is going to cut even keel preparation also, it's going to do it. But for keel preparation, we need to subluxate the knee. But to save the time, even we are doing it manually on the keel side. Otherwise, it will do. For sabon purpose, usually we demonstrate for the keel preparation also. Robot will simultaneously cut slowly on the lateral side. Usually the speed of the robot is around 50 mm per second. You see here, the speed is around 14 mm.
So the trajectory is from medial to lateral to protect the tendon while it's cutting the lateral side of the tibial plateau.
Kunal, the most time while cutting lateral side, surgeon gets spillage. Wherever it is getting freeze error means bone is sclerotic, robot wants to come out and again go back. Last almost 1 minute surgery left. You see here, while cutting on the lateral side, it may damage vessels. That's why speed naturally it came up to 5.3 mm. Usually I operate around 39 to 43 mm per second. Because of sclerosis, I am changing one more burr. In the initial days, I used one burr for 10 cases, but the problem with using 10 cases is the check and sleeve is damaged. So now I am changing every alternate case, one new burr we are taking. Burr cost is around 3,000 rupees. 13,000 is MRP quoted by the Meril, but you will get from other vendors 3,000 rupees. So I'll change the every alternate case burr. If required, we are using new burr for every case.
It's almost the cost of a saw blades only.
Yeah, correct.
So when the bone is sclerotic, do you increase the speed or decrease the speed? How do you adjust it?
No, it is automated. You can't decrease. You can increase the speed, decrease the speed, but on the lateral side of the tibia, you can't control the speed. Now the cuts are complete. So I was focusing on the cuts. So you can ask questions now.
So the cuts are done now. The surgeon would be removing the extra bones surrounding the cuts and clearing out the soft tissues which are in the way before doing the trialing. Any questions from the audience?
Thank you. As time is pressing, I'll try to finish it off trials and check the gap balance and hand over to the next discussions. Just I'll finish it off next 5 minutes.
Sorry, come again.
Hurry, I'll be finishing in another 5 minutes.
So if you have to finish the posterior lateral part of tibia, unless we finish the entire of medial part of tibia, we can't advance to lateral. Is that right?
So there's the sequence, the medial part antero to posterior, then the lateral part again antero to posterior. So you can stop the robo in between, or it stops on its own if there is bone movement, but you cannot skip a step and go ahead.
Yeah. So, I mean, if you want to avoid the mill going too posterior, I think in the planning, it's always better to get the tibia as anterior as possible so that you have some bony clearance.
Yeah, you can do that, or you can undersize the tibia also. And suppose you put a size 1 on the J planner and put a size 2 or 3 once you are preparing the keel.
Central spec. Central spec. Central spec. Central spec.
It is done manually, sir. We can do it even robotic, but it is done manually.
Chinna spec.
No, sir, not really. It's same like how we do in the conventional. Yeah. The keel placement is mainly to know the rotation of the tibia. So,
so Dr. Balaraaju, there's a question from the audience.
Yes.
Does CUVIS tell us the poly size for which the cuts are being taken to balance the knee?
I did not get you. Once again, please.
Does CUVIS tell us the poly size after the cuts are taken to balance the joint? Polyethylene size.
I think I'm not able to hear your question.
You want to answer that?
Poly is basically aimed. We cannot tell it at 9, but after cuts and everything are taken, it may go up to 9. But aim is to whatever planning is done is based on 9 mm poly.
Poly can be changed. What is the question?
No, in the planning, can we plan ahead the poly size is what they were asking.
No. Usually in the planning, we plan the femur implant size. Means if it is F, that's it. And I'll try to balance on the lateral side. So posterolateral condyle of the femur thickness, I want to make sure that it should be matching the posterior condyle thickness of the femur. And I'll be checking, intraoperatively more reliable data we will get it. No, usually we poly size will decide after registration. After, all the osteophytes are removed, then we will take it. Osteophyte, osteodome. So poly size only while doing surgery, you can change it. If you want to keep it 11, you can keep it, increase the tibia cut, you will get it 9 mm or 10 mm. Lift.
This is the first time tibia is being translated anteriorly while they're preparing the tibia.
Now, whatever I am doing is just whatever the osteophytes left, I am removing. That's it. Central spec. So now I am removing the medial meniscus, lateral meniscus for preparation of the just tibia. Whatever the bone, I keep the component slightly anteriorly so that there is a myth going on that it might.
there is an answer to your question. So either we put one size less or we put it a little anteriorly so that it doesn't go all the way posterior. The rest of the thing we can cut it manually with the saw.
Okay.
Yeah, that might happen.
Can you give one mic to audience so that they'll ask some questions? Joshi sir.
Dr. Balaraaju, the audience question is, since the posterior osteophytes are approachable at this stage and we have removed them at this stage, does it change your gaps?
Usually it won't change any gap actually. If I see, sometimes, if your planning is not perfect, sometimes the flexion gaps might change. But for me, never flexion gaps did not change because I put it in 1 mm less. If you keep, for example, if you keep slope 5 mm or 6 mm flexion gap increase, but I never want to increase the flexion gaps because it creates the mid flexion instability in the later date. So no patient ever complained that I have no instability while taking steps or like walking. So surgeons should be very careful while doing the while balancing the posterior cuts.
So his question was, now do you take out the posterior osteophytes on the femur and tibia when you are able to access it now?
I'll remove it. Osteophytes, if are there on the femur side, I'll try to remove it.
Yes. So removing those osteophytes, does it affect your flexion and extension gap?
Slightly, it might. That's what I'm saying. Now I'll check. Now I put a gap balancing around 9 mm poly. Let me check now. Osteophytes are there, but let me check it. Usually it will increase by 1 or 2 mm. The advantage with CUVIS striker system Mako, where all things can be perfectly planned before surgery. But with CUVIS, you can't plan exact gaps. For CUVIS, for Mako, Praharsha should tell, whatever the gaps you are planning, accurately you will cut it. You are checking and cutting. Here is everything is prefixed. You can't change the cuts. If you want to change it, you can change it, but it takes time, and again, a lot of time waste will be there.
Sir, is it possible you had said the osteophyte should be removed after the registration? So if we do the osteophytectomy before the registration, how would it affect the procedure?
So it's a CT based robo. CT has accounted for those osteophytes. So we have to do the registration with the osteophytes on so that the RMSE value doesn't decrease more than 1. And only the osteophytes which are approachable without much soft tissue release. So that is till the equator of the tibia, anterior 1/3 can be removed. We don't have to release till the posteromedial part of the tibia. What I feel is if there are too many posterior osteophytes leading to FFD, we don't increase the DFC in the pre-planning because we expect that after removing those osteophytes, there will be some laxity and it will correct itself out. So the X-ray also has to be taken into account.
Yeah, that's why in Mako also it's the same thing, just like how Dr. Nija was pointing out. You're able to, with image-based, see all your osteophytes. And that is why Dr. Suhas was here and we have all published that technique of how to do for gross deformities. So you will purposefully leave it little tighter. So how much will that be? It is usually any osteophyte which is posterior to the femur, even up to a centimeter size, will add up around 1 to 2 millimeters of extension gap at the end. So FFDs will not try to keep it very loose or like you said, cut anything distal cut, increasing cuts, we won't do it. What standard cuts are required, we'll do it depending on the sizes of the osteophytes which are there. Second point is that as far as the registration is concerned, it is ideal that you don't take it out. So usually if the osteophytes are big, it is preferable for you not to take it out. You can take them out, there's no problem, but you should not register in that area. Because those points which you selected the start of the registration process should not be lying on top of a place which you're going to remove later. When you come for the final verification, it will show it as an inaccuracy. And that in the CUVIS system, it comes as that mean value changing. In the case of the Mako, if that final verification bubble lands in that area, you will get some amount of inaccuracy. Yeah, so it's ideal that you don't, but if you take it out also, it's not a big deal. You just have to register away from that osteophyte area. Let's say medial femur is there. You can remove it, but register everything either behind the osteophyte on the bone or in front of the osteophyte. So don't register anywhere near that osteophyte area. So that will not cause any major issue. It's just a recommendation from their side. Avoid all that confusion. Just keep your osteophytes, do the registration process. And then as part of your exposure, you can take out osteophytes, everything, and then take your laxity. So that is why as an institution, our preference is always to take out all accessible osteophytes so that you get a good representation of what your true laxity is, so that you don't get surprises at the end of the case. Yeah.
Capture.
So we have the trial implants in and the gap check.
You see here, the final gaps came out around captured means without any stress around 11 mm poly. So I planned 9 mm, but it is increased by 2 mm. But how I make my patients happy is I keep female patients slightly joint lax, means almost 2 mm less poly I'll keep it. So I'm happy with that. So I'm going with only 9 mm poly. I'm not going to increase the 11 mm because tight knees for females are really unhappy. What do you say, Kunal? What your take on it?
Yeah, this seems a well-balanced knee. I think the soft tissue releases due to the osteophyte removal has led to increase from 9 to 11. And this acceptable 2-degree varus and well-balanced in both flexion extension.
If you look at here, no, varus is around 1 or 2 degrees. There is a previous concept that you need to keep the knees in 0 degrees varus. No, what the present literature is suggesting, you try to restore the Indian knees as a slightly to normal kinematics. So I'm happy 11 mm poly, but as a female, I want to reduce it to, if I keep 11 mm poly, the flexion gap will increase by around 2 mm more. So any more questions? Because the time is pressing and we are exceeded by the timings. We will go ahead with the next sessions. Any questions from the audience?
So what's the slope of the tibia final?
Slope of the tibia is 4 mm.
4 degrees. Yeah.
4 degrees. If you look at all the surgery, all are pre-planned. I may change to only 1 or 2 mm on the external rotation, valgus, distal femur. It's all 1 mm, 2 mm. But if you look at the femur, how snugly it fits, there is no even 0.1 mm gap on the medial side or lateral side.
I think we'll close this session now. Well-balanced knee. Thank you. Thank you, Dr. Balaraaju, for the excellent demonstration.
Thank you, Sai Fani. Thank you, Hari. Thank you, Kunal and Rajshekhar sir. Thank you all.
Thank you all panelists for such an insightful conversation. I think next we'll move on to the relive of Mako. So we'd like to invite Dr. Suhas on stage and would like to invite the panelists as well. So
Video
Dr.
stop.
Supreet,
Video stop.
please join us.
Stop. You guys stop.
Dr. Rajiv Reddy, Dr. Praful, and Dr. Praharsha.
Good afternoon, everyone. I think while the panel groups and comes up on stage, I would like to thank the ONUS Hospital and everybody who was involved in organizing for giving me this invitation. As you can see, robotics has become very popular, and any objective of a conference like this should be twofold. One is to understand the differences between one robot to the other. I think every user would vouch that their particular system is the best. But there are subtle differences between most systems, which probably if you're planning to get into robotics or acquire a system, maybe that is the time you should go into the due diligence of what is exactly one system as compared to the other. But in a conference like this, it is important for you to understand that what does the robot help you to achieve more as compared to conventional surgery. So part of my whole Relive video will be able to show you that. It's essentially divided into 3 parts. One part is planning, which is more of a feature of an image-based system, which you already just saw. So the interface changes, but an image-based system helps you to actually plan your surgery even before you enter the operating room. So that's a big advantage. Number 2 for any robotic system is the stage where after registration, you have to know what is your gap. And then once you know the gaps, you try to balance that particular knee. And every system does it a little differently. And I'll show you how Mako does. And third part is the execution piece, where once you balance your knee, you have to execute a cuts. So here you have a mill-based system, you have a burr-based system, you have an automated system, you have a semi-active system. And the system that I'm going to show you is called Mako, which is from Stryker. One of the big advantages or the pluses of Mako is it has 18 years of evolution in terms of its history. More than 400 peer-reviewed publications. So a lot of the robotic literature that you see is from the Mako system. So Remember that it is an image-based system and it is a semi-active system which has the ability to connect a saw or a burr, or for that matter, for a total hip, it's the reamer. So you can start playing the video. Yeah, I've started. Okay, so So as I show you the video, if you have any doubts or if the panel wants to ask any questions, we can stop the video and then we can take those questions. So this is a very simple run-of-the-mill bilateral osteoarthritis of the knee. And for the purpose of this particular presentation, we are doing the right side. As I told you, the three features. The first feature is the preoperative planning. So here, because we are using an image-based system, you have a full CT scan where you can do all sorts of combinations. So what I normally do right now is I start with an unrestricted kinematic plan. So here you can see that I'm giving around 4.5 ARIS in my tibia so that my tibial cut is 7 and 7. Similarly, on the femur, you want to cut equal amount of bone. So on the femur, the target is 6.5. So I have to give around 4 degrees valgus and bring it down to 6.5. So this is in principle with the kinematic alignment strategy. Here you can see that I'm giving internal rotation in my femur. So at the end of your pre-planning, you should have 7 millimeter cuts on your tibia, 6.5 on the distal femur, and 6.5 on the posterior femur. So this is how I start every single case. There are multiple changes that can happen during the procedure. Once this is done, you look at sizing. So here you can see on the femur, you have a good mediolateral fit. Number two, you can see because I've internally rotated my femur, you can see I've matched the trochlea pretty well. The third thing that I look for in terms of the femur is the posterior condylar offset, both on the medial side as well as the lateral side. If you have your femur at 0 to TEA, your lateral side never matches. Only when you give internal rotation, it matches. All my cases, I do a CR. So here you can see my average slope is around 6 to 7 millimeters. And you can see here the combined flexion is above 10, which is not acceptable for most systems. So here I have the option of increasing the size of the femur and then decreasing my flexion. So that much amount of flexibility you can have. And now I've brought down the combined thickness parameters to around 9 degrees. So here, this is my final plan. 7, 7 on the tibia, 6.5s on my femur. My femur is matching well and my tibia is matching well. Once this is done, I usually do a mid-vastus or a sub-vastus approach. In any robotic system, the next step is usually we have to put the femoral array as well as the tibial array. So here you can see that I'm doing a CR. I've removed my ACL. There's a big debate in Personalized Arthroplasty Society how much release should be done on the medial side. So some surgeons are very finicky and they are not touching the medial side because they want that particular sleeve to be there as much as possible, meaning they don't do any deep MCL release. But in Indian patients with the amount of deformity we see, it is required. So here you can see that I've already done my tibial array, and then now I've gone intra-incisional on both sides because sometimes you can see some amount of wound healing issues on the tibial side, which is because it is subcutaneous. So I do intra-incisional both on the femur as well as the tibia. It is important that these are fixed properly. You can see I'm just doing my final positioning so that the arrays are collinear as well as at the same time they have to be communicating with the infrared camera, which is on the opposite side. Once this is done, they have to be tightened because you cannot risk the arrays moving during the procedure. So here, the hip center is first registered, the medial lateral malleolus, Because this is a CT-based system, it is already calculated. You're only reaffirming what the system already knows. So here, there were some questions regarding osteophytes. So any registration, this is a CT-based system, so it is using a sharp probe. So on the side where you have native bone, naked bone, so directly take on it. Wherever you have osteophytes and wherever you have cartilage, you have to pierce through the cartilage. You have to miss the osteophytes and take the native bone whenever you're registering. Once this is done, you get a value, and this value is important. Here you can see that I've got around 0.3. Anything less than 0.5 allows you to move forward. So here, because Mako has evolved so much, there is so much information now I can get even before I capture my gaps. So here you can see that I have zero flexion. I can bend my knee up till 137 degrees. So this is the minimum that you have to give this patient even after the procedure is done. So here you can see the resting varus is around 4.5. So I start capturing all this data for every single patient of mine. And now we start doing something called laxity patterns. So you can stress the knee both on valgus and varus and see how much it is opening laterally and medially. Because it is important for you to know how much is this knee is opening, how much is it correcting, is it over correcting. Here you can see it's almost correcting to 0.5 varus. So actually this is quite a well-balanced knee, and not much coronal adjustment needs to be done in this particular patient. So once I know all these figures, how much laxity I have in both extension and flexion, now I move to the next step of the procedure where we remove the osteophytes. Remember, the final gap capture needs to be done only after removal of the osteophytes, because when you're stressing the gaps and you're capturing the gaps, if you have osteophytes stenting on your ligaments, they will give you an error value. It will show you some amount of false tightness, which is not correct. So try to remove as much as you can. We've developed techniques where you can even remove osteophytes from the femur also, which probably in such simple cases you didn't need to show here. So what I'm used to, and I think is very consistent in my hands, is simultaneous capture. So here you can see that I've put an osteotome on the lateral side while I'm stressing it to 2.5, because this is the value I got during my initial assessment. Now I give a valgus force. So here you can see that this particular knee is opening to around 2.5 on either side, and then I've captured the gap here. So this is extension, lateral, medial, 2.5 as well as 3 millimeters. Flexion is slightly more easier because you can use two osteotomes at the same time. Here you can see, as expected, the lateral was more lax, around 3.5, medial was around 0.5. So this is the screen where you start balancing the knee. Here the philosophies differ. If you are a pure kinematic guy, you don't touch the femur. If you are a functional guy, you will try to balance this knee, either moving femur or tibia. So that is the basic difference between functional alignment and kinematic alignment. So here I'm moving my tibia because I'm able to balance all the numbers simultaneously. So I have brought it down to around 1 millimeter. Now all that I have is some amount of medial tightness because I've raised my tibia. Now because I'm touching my femur, I've started rotating it. I have moved out of pure kinematic alignment. Now I've moved into functional alignment. So this is the way I have done, and I usually like some amount of lateral laxity in flexion. So I've left that gap to around 2 millimeters, because for your PCL to function well and for your rollback, that is important. This part of the procedure, it is quite straightforward. You can see that the green line is the haptic boundary. The saw actually locks into that particular boundary, and then no movement happens. The other feature about this is the saw blade and the knee actually lock in the haptic. So here you don't need the knee to be very sturdy. If the knee moves, the saw blade also moves along with it, locked into the haptic. So that is one big advantage. Second thing you can see here, because I'm doing a CR knee, you can see I have a PCL footprint here, which is very well protected by the haptic boundary here. One disadvantage of a saw is you can skive. So especially on the sclerotic areas where you have very thick bone, it is important that you take 1 or 2 swipes of the saw again and again so that you can remove that sclerotic area of bone. So here the cuts usually happen in 3 to 4 minutes. There are two types of saw, the attachments that we use, the straight saw attachment as well as the right angle ones. So this part of the procedure, once the knee is balanced, is pretty straightforward. So now I've changed to the right angle attachment, where you can see I do my distal cut as well as the posterior cut. So once this is done, rest of the procedure is pretty simple. We have to do the trialing. Before I go into the trialing, it is important that I open the posterior side and look for any little osteophytes that are left, or the residual meniscus that is there. As it was pointed out, if you have some amount of residual osteophytes left on the femur, it is important that you underbalance that side. For example, on the medial side, if you have some amount of osteophytes left. So now there is research happening on quantifying the volume and the size of the osteophyte and trying to correlate that with how much gap opening can happen. So here you can see I'm showing you that the footprint has been secured quite well, the PCL footprint. So here you can put your trials in the tibia as well as the femur. Once you put on the femur, we go through the same assessment that I did before, where I went through the range of motion, I went through lateral laxity, medial laxity. So I'm trying to put the femur back into its right position. So here you can see that we've started. I have some amount of hyperextension. If you could notice here, it was -2. So this knee became little lax as compared to what I preferred. So I've changed it to 11mm insert here. And then once I've put 11mm insert, you can see I have around 5 degrees of flexion, which is very ideal for a CR knee. For a PS, you can go a little higher up. And you can see my medial lateral laxities are around 1 millimeter. Usually on the medial side, because this is a single radius design, you want it very snug. Even if there is no movement, you can accept it. But on the lateral side, you should need at least 1 or 2 millimeters of lateral laxity, because that is how a natural knee functions. Once this is done, now I've taken the knee into flexion, and you can see around 0 laxity on the medial side and probably around 1 millimeter on the lateral side. Now I'm making it go through the full range of motion, and you can see there is absolutely no lift off of the tibial poly. This is important because as a CR insert, if you have lift off, then there's too much of PCL tension and you'll have posterior wear. Here I'm trying to demonstrate how the tibia actually internally rotates as you flex the knee. And this can be shown very nicely if you balance the PCL well in our Mako system. So here you can see, as I'm flexing, you can see that these two lines which are in line, and as you flex, you can see that it starts medially rotating. So this is actually when the femur rolls back, the tibia actually internally rotates. That's how the knee actually hyperflexes. So here you can see, usually you need around 10 degrees of internal rotation. So cementing and all, I think it is pretty simple. So here is the final assessment. You can see that I've achieved every single target that I wanted to. So here I'm almost going up to 132, and you can see there's absolutely no lift off. And the final varus is around 2.5 here. The video of actually, you can actually see how rollback also happens in this particular system. So you can actually capture it before and after, and then that gives you a good outcome. So one thing robot gives you is a consistent result in every single patient, irrespective of how the pathology behaves. If you have your boundaries and if you have your targets, you should be able to achieve what you want 9 on 10 in every single case. Thank you.
Any questions from the audience? It was quite a comprehensive demonstration, Suhas sir. Very well done. Any questions that you guys have? Yeah, please.
How reliable are the FFD measurement in the final? Like, for example, you have changed from a 9 poly to 11 poly.
Yeah.
So if I'm not wrong, the CT of Mako and for that matter even CUVIS, they just take the CT of the proximal femur, the knee and the ankle.
Yes.
So it doesn't account the bow of...
Yeah, so two things are important here. It's actually calculated from the head of the femur in the sagittal, and then it comes down to the center of the knee and then the ankle. your target should be different for a CR versus a PS. This has been my experience. In a CR knee, because the PCL is there, even when you normally do surgery, when you remove the ACL and then you go on to PCL, after you remove it, you'll see some amount of hyperextension coming into the knee. So your targets for a CR should be around 0 to 3 or maybe 4 degrees of flexion for a CR knee. For a PS, we've done so many of these when I was in Sunshine. Usually 5 to 8 is what the target should be. Because if you don't see that 8 number, till then you will see some amount of hyperextension in your knee. But the way the system actually calculates makes it look hyperextended because it's not in the same plane. It's coming from the head of the femur down.
And that's why I think I wouldn't say it's just image based. So even in Velys, when we're doing Velys cases also, the one value that we will more rely clinically and not just look at the number on the screen would be the sagittal values. So you can have an absolutely neutral knee. Velys can also tell you you're 15 degrees FFT, right? And it can work the other way around also. So that is why it is always good to take a clinical decision. I think second point, which was shown in the case, is if there is a slight weak link for any robotic system currently, in what data we input to the thing is about how you capture the gaps. So that is the part which is important in the learning curve part, is how much stress should you apply? Because as you've noticed, except for probably Velys, no other system as of now is not having a particular digital tensioner telling this is the force you have to apply. But in our experience, we have actually found inflection gap, just like how Dr. Suhas has shown the 2 osteotome technique and how you crank it up. And we have done CR cases with Velys. The amount of gap that it estimates with the tensioner is same as what we are assessing manually also. So as you do cases in different systems, the first thing that you have to figure out is how appropriate is the stress you're putting. If you estimate a bigger gap, you will cut lesser bone, you will be prone to tightness. If you estimate too less, you may end up cutting more bone to establish a thing, and you'll end up going one size up on your.
And the easiest way to know it is once you've developed a consistent way of capturing gaps, you end up and see, are you ending up with the same poly or a higher poly? If you're ending up with a higher poly, then you're giving a little too much stress and you're ending up cutting more bone.
Then the collateral.
Yes. So you can make that correlation because everybody has different way or different strength. The hip starts rotating. All companies are working on digital tensioners. I think Skywalker, probably the Omnibot has the best tensioner. So every particular robot has advantages and disadvantages. So I think once people start getting digital tensioners, I think there'll be more consistency in how gaps are captured.
So because you are primarily a CR surgeon, it so happens that for our osteoporotic knees, the PCL versus off. So you have any tips for
So
that?
2 things you should do. One advantage anyway with any robotic system is you don't dislocate your tibia. Most of the time it happens at that particular point. When you see that line of demarcation, I usually do a second or a third attempt around it so that I don't weaken that area. Number 3, before even I dislocate, I ask my assistant to sublux my knee and I use an osteotome and then go around the PCL footprint so that you're able to deliver it. And then the 4th thing is you should use a PCL sparing retractor. Because if you use a spike, the Homan, it directly goes in and it pulls out. And then for it to happen after you balance the knee, then you're chasing your tail. Then you'll have to again take a distal cut and put a bigger poly.
And the rotation of tibia.
Yes.
Do you use like the free floating tibia technique for rotation?
Yes. So free floating is very important, especially for a CR surgeon because the internal rotation happens on the tibia. So when we make the mark, usually I mark it after I free float and I do it in flexion. And then when you see, when you start preparing the tibia, that line actually correlates pretty well with your Akagi line, or maybe few degrees of internal rotation happens.
Is your alignment philosophy the same for conventional and robotics? And do
No,
you
I
always
think-
use a single radius implant?
The implant is the same, but the philosophy changes. I think the most dangerous path to take is trying to do conventional surgery and hitting non-mechanical targets. I think that is something we should not try to do. even though if we are trying to do mechanical alignment, remember that you're already 3 degrees off, plus minus. And if you're trying to hit 3, it's quite possible that you're either 6 degrees or you could have gone into valgus. So if you're doing conventional surgery and you don't have the necessary jigs or the shims, it is safe to just do mechanical alignment that has stood the test of time. Nobody questions its validity even today. But if you have the shims, the necessary shims and the jigs to do it, a lot of Asian surgeons, Japanese surgeons, and some in India do pure kinematic alignment, because that is the only thing where it is done using measurements. The only alignment strategy that you can do with conventional instrumentation, special instruments, is KA. For everybody else, I think you should just stick to mechanical.
Yeah, a wonderful presentation, Dr. Suhas. I think it's clear there, most of it, especially the rotation part. I have one doubt, like you said, the functional corrective deformity at the end of the surgery is 3 degree valgus, 2 to 3 degree valgus. Means you achieved your goal. Now the many papers are saying that sometimes in a Mako, or you're trying to get your balance pre-op at the time of balancing it is correcting. And you're like, when you're loading the knee or taking a scanogram, it is showing the little under correction. Like you may hit 0, or as you said, if you're aiming for mechanical alignment, it is off the mechanical alignment, it is giving a functional alignment. What is your experience on that?
So the difference is in few degrees, but yes, because what we do is non-weight bearing. The measurements that you do during surgery is non-weight bearing.
Yeah, we are not loading that knee.
Yes. So, and then single stance, double stance is also different. So what you get on a single stance in a plain radiograph scanogram versus a double stance is also different. And what you're achieving intraop is also, there's a big difference between kinetics and kinematics, right? So there, I think not much research has been done in terms of what you have to
In
achieve.
your experience, I think, should we aim for that, or?
So I think if you leave equal gaps with absolutely no laxity, then the difference might be less. But then if you leave some amount of lateral laxity then you might see some difference. But what is more important is the opposite side is important.
Yeah.
For example, if you leave lateral laxity and your medial side is absolutely snug, then there is no progression of that lateral laxity over time. But if your medial wobbles as well as lateral wobbles, and then the whole thing starts laxing. So my targets are very simple: 1 degree of lateral laxity in extension, up to 3 degrees of lateral laxity in flexion. People have gone up to 6, but I think that's a little on the higher side. Medially, I'm absolutely snug.
This one we've tried to correlate with weight-bearing scanograms. So in 85% of situations, when you give a varus stress on table, the value that it shows correlates with the scanogram weight-bearing deformity which is there. And second thing is that I would be definitely concerned, exactly as you said, the value will change anytime we have a HKA more than 3 degrees, which can perpetuate lateral laxity. When they go into dynamic stance, the deformity will appear more than what we finally achieved correction. So if we may correct it down to 3, when they put weight, it may go up to 6.
My conjunction of asking that is because I think we discussed in long back also, your knee ankle axis. End of the day, it's going to load on the ankle. Are we taking a hindfoot knee ankle X-ray? You may see the difference. I think Dr. Suhas has objectively said that when you see the other side, the native side, if you're able to match the native ankle, I think we can go way forward in that.
That's something that we are actually looking at now, is to see what influence the alignment strategy has on
On the
hindfoot
ankle,
alignment. And that's what we're looking, whether restricted kinematic or doing mechanical or functional alignment is changing the ankle alignment. Our expectation is that the more we restore the native alignment, it should not, in that case, change the ankle alignment. But then again, it also plays a big role, especially some patients who have some amount of rigidity in their ankle by the time, or existing ankle arthritis, they will still persist to have a malaligned hindfoot despite doing any change at the knee. So I think supple deformities will actually cause a functional difference.
Till we know how that progresses, I think it's important that you do a balance assessment, like how I showed you, where you know your your FFD, you know the amount of flexion, you know how much the lateral is opening, how much the medial is opening before you've done anything, right? So if you try to restore it as close as possible to that, in hindsight, you would have restored that particular knee's kinematics. Okay, thank you so much for all the interaction.
Thank you all the panelists for this discussion. I think let's move on to the talks before we do the inaugural and break for lunch. So I would like to invite Dr. Lokesh Kumar to present his topic on how do I do difficult valgus knees with robotic TKR.
Good afternoon, everybody. At the outset, I would like to thank Dr. Balaraaju Naidu, sir, for giving me this opportunity. So today we'll discuss how I do difficult valgus robotic TKR.
Dr. Jaganmohan sir to join the stage as moderator and Dr. Krishna to join the stage.
Good afternoon, sirs. So at birth, there is always a constitutional varus which resolves by around 3 years. And from 3 years till 12 years, it is valgus. And normal HK axis is around 1.5 degrees valgus to 3 degrees varus. And if you see the valgus deformities of the knee, they constitute around 8 to 10% of the normal knees which we do. So coming to the etiology of the valgus knees, they are almost congenital or it can be post-traumatic, and it can be persistence of genu valgum from childhood because of the secondary rickets or osteodystrophy and persisting into the adult also. Rheumatoid arthritis is one of the major causes which we see in our Indian population. Metabolic causes can be rickets, renal osteodystrophy, and epiphyseal dysplasias. Coming to the classification, valgus TKR, we have two major classifications of Krakow as well as Ranawat. Both are have not taken into consideration the extra articular deformities and the flexion and hyperextension deformities. So these classifications, Krakow constitutes the stage type 1 is about 80% of the cases where the deformity is less than 10 degrees and it's partially correctable, passively correctable, whereas type 2 is 15% of the cases we see and it's 10 to 20 degrees of valgus and MCL is elongated but functional. Type 3 is very rare, almost 5% of the cases, but in Indian population they constitute a significant number and it's not correctable with varus stress. MCL is attenuated. Ranawat classification, again, almost the same thing which tells, but it again doesn't take into consideration the hyperextension deformities and the extraarticular deformities. So one of the critical point in valgus TKRs is to know whether the deformity is correctable or is fixed. Because if the deformity is fixed, that means that the medial structures are stretched and the lateral structures are tight. If the deformity is correctable, that means that you can get away with very minimal soft tissue releases. So the challenges that we see in doing a valgus is what approach, whether you have to take a lateral parapatellar, medial parapatellar approach, and the bony anatomy differs. Sometimes there is a lateral femoral hypoplasia. In most of the cases, it can be distal as well as posterior femoral hypoplasia, external rotated tibia, and tibial defect, which is usually contained and it's central, unlike the varus where the defect is peripheral. And so the things to look and for document is to make to know what is the etiology of the valgus, to know the degree of MCL integrity and hyperextension deformities, flexion deformities, rotational deformities. So Klebisch in 1990 said that lateral for valgus knees, lateral parapatellar approach is the best approach. Actually, it's the best approach because it gives us the 100% visualization of the posterolateral corner of the knee, which we need to take into consideration. But again, the literature says that in mild valgus deformities, both medial parapatellar as well as lateral parapatellar, they have significant, almost the same results. But in severe type 3 valgus, you may have to take a lateral parapatellar approach. So now the difficulties that you face when we do a conventional TKR is because of the lateral bowing of the femur, we may have to take an entry point medially. Okay. And the femoral hypoplasia is also one of the thing. The femoral hypoplasia can be in the distal femur and it can be the posterior femur also. And when you calculate the valgus correction angle in varus knees, we take at 3 to 5 degrees, 5 to 7 degrees. But when it's come to valgus, we are always in a dilemma whether we to take a 5 degrees, whether to take it 3 degrees and all. So in normal conventional scenario, it is actually to be individualized for each case. But if you take a robotic technology, with the help of robotic technology, these problems will be solved with the help of a robot. So medial cut, lateral cut in a conventional TKR should be almost from 0 to 3, whereas medial cut should be less than 8, should go up to 8, up to 10 max, but above 10 it should not go. And if you take the posterior condyle axis as the reference and do the rotation of the femur in a conventional TKR, then you will land up in internal rotating the tibia. So always we tend to take epicondylar axis for the rotation of the femur. So one of the other challenges, one of the other critical challenges is how to balance, how to do a soft tissue releases in valgus knees. So superficial stabilizers are IT band and lateral gastrocnemius, whereas deep are LCL and popliteus. So multiple theories have come up about how to do releases in valgus knees. One simple point is if the structure is attached to the femoral epicondyle, that contributes to the flexion stability. And if the structure is attached away from the femoral epicondyle, that contributes to extension stability. So ITB contributes to extension stability, whereas LCL and popliteus, they contribute to flexion stability. So if you are tight in flexion, then you may have to release LCL and popliteus. If you're tight in extension, then you have to go for the ITB release. So Ranawat says that first you have to do a ITB release, then go for the popliteus, LCL, and last the posterior capsule. But multiple these things have come up. It all depends from the case to case in a conventional scenario. So these all things will be all things of releases, everything will be solved by using a robotic technology. So now patellar maltracking is one of the another complication of a valgus knees where because we tend to internal rotate the tibia, the patella may maltrack. So the grades of patellar maltracking can be the 1A, which is near normal. Near normal means the medial facet of the patella will touch the medial facet of the femur, but there is a less this was a around 50 years old gentleman with coming to our OPD with the pain in the knee and the valgus deformity. Okay, so I use the CORI technology. So after collection of the femur knee centers, hip center calculation, femoral flexion and extension ranges, we paint the tibia, we mark the tibia, we give the femoral axis definition. See here, the femoral axis definition, we have given it as 0. Okay, so we have taken the PIXEE as 0. So based on this, again the soft tissue structures or soft tissue laxity and all, we will rotate the tibia. Now this is the thing which we can see. You can see that there is a flexion of 4 degrees in the when you have initial implant planning stage. The flexion of 4 degrees is there, and the valgus is around 4 degrees valgus. And this is the stress range which we got stress range, and this is the next. This is the pre-operative plan screen. And this is the heart and crux of the CORI Robo, where it is showing that in extension you are tight at 4.4 with 4 degrees you are tight 4 points. I mean, and in flexion you are tight by around 0.7. Okay, so now we have to balance this knee. And that will solve most of our problems. Okay, in valgus knees, in CORI Robo, because medial side is the normal side, we tend to balance the normal side. So we balance the medial side. So this is what after the planning and all, we have given 1 degrees valgus to the femur, and we have increased the femoral cut. We have increased the tibia cut, and so almost after this balance, still we are tight with 2 points. In extension, but we have balance on the medial side. Both the medial side is 0.8, 0.7, which is almost balanced. So now after the all the cuts and everything is done, so we have got the full range, and you can see this the stress radiograph. No, sorry, post of radio stress views of the robo, which says that it's almost balanced with only 1 mm laxity in both the medial and femur. In this case, actually, we had to do some ITB release because it was tight in extension. We had to do some ITB release, but it was very minimal, and we got away with the things. So there's a post-op gap assessment which we get in CORI Robo C. We planned for 1 degree valgus, we got 2 degrees valgus, and the preoperative range flexion was around 4 to 6 degrees. Now we got around 10 degrees. It is showing 10 degrees, but intra-op, as the panel discussed before, clinical judgment is very important. So intra-op it was neutral. So this is the post-op radiograph that we can see. Thank you. Thanks a lot.
Excellent talk. Any questions, sir, from the audience on valgus knee robotic? So normally when you are doing a severe valgus knee, you will keep on standby about constrained implant like high post.
Yes.
In robotic also you keep them?
Yes, sir.
Like a high post to control the medial lateral.
Yes, sir.
Yeah, you use it.
Yes, sir. Sir, actually, robotic, we can't trust robo that it would be 100%. It's just like a GPS of a car. It may take you to the wrong location also. We have to trust your conventional skills as well as then you have to trust the robo, and then based on that we have to take a call.
Yeah, normally I use Velys robo. We take posterior condyle reference. In valgus knee, lateral condyle is hypoplasia. Posterior femoral condyle is hypoplasia. Normally we take in conventional transepicondylar or white side line, or from the tibia we take. We never take in valgus posterior condyle as a reference.
Yes, sir.
Otherwise you will internal rotate the femur.
Yes.
So in robo, what parameters you take? You take a posterior condyle reference here, or?
No, sir. In robo, we don't take the rotations will be based on the balancing of the medial and lateral.
Check alignment. When you start the procedure in robo, you have to take either transepicondylar or white side or posterior condyle reference, especially in Velys CORI side.
No, sir. In CORI, we don't need to take that. In CORI, we need to balance the normal side. Means if it's a varus knee, you need to balance the lateral side. If it's a valgus knee, you need to balance the medial side. So whatever the gaps that you are seeing in the orange and purple, in valgus knee, you need to balance the orange side. That means that you have to make it till 0.8 or 0.1. For that, you need to rotate the femur. So to achieve that, how much rotations you are doing, that would be that you can put it at. So you don't need to take any particular axis in this. In CORI Robo, you don't need to take that.
In gross valgus, Klebisch describes the lateral condyle osteotomy.
Klebisch approach.
Osteotomy in gross cases. So does the robo solve without osteotomy?
Osteotomy of what, sir? Lateral epicondyle?
Lateral epicondyle.
Okay.
No, because if it is gross valgus,
gross valgus, sir, you should be...
the section is going more above the epicondyle level.
Yeah.
That times he advises lateral epicondyle osteotomy sliding down posteriorly and inferiorly.
Yeah,
So,
if it is a gross valgus
Valgus.
deformity, you should be very careful about common perineal nerve palsy and keep reserved with constrained implants, stemmed implants, and release the LCL. Popliteus has tight inflection, popliteus will be released. Tight in extension, iliotibial band is released, LCL will be released. Then you had to go for a constrained implant. So not like a medial epicondyle or sliding osteotomy. I think lateral epicondyle won't work. And if you are doing a first time as a Klebisch approach, you will be confused. If you do a Klebisch approach, unless you do 3-4 times and you have some senior author with you, otherwise don't try first case as a Klebisch approach. You will be disoriented when you go for a lateral, everything will be different.
That upon the lateral epicondylar osteotomy, robo is not going to solve that. It has a limitations. Probably we have to accept 3-degree valgus or HK, how much we are going to accept. Sometimes we have to pin medial and open up the lateral or close the medial. So probably it's a 3-degree in tibia, which we can accept, or 2-degree in femur. Even in spite of all those things, if you don't have that opening, I think there's a lost option. Yeah, but we can understand where we are.
Yes, sir. Thank you, sir. Next, I invite Dr. Hari Prakash on how I do a difficult virus robotic TKR. I think the commonest is the robotic TKR. I think commonest soup served in the dinner and lunch is the tomato soup. Same as robotic TKR's virus is the commonest one. I think Dr. Hari Prakash, sir, you choose an easy topic.
Yes, sir. Because I'm scared you are the panel member and you would ask a lot of questions. So I thought I would choose an easy topic. But still, I'll try to justify whatever I have chosen. And I hope you will like it, sir. Thank you so much. My name is Dr. Hari Prakash. I'm a consultant orthopedic and joint replacement surgeon at KIMS Hospital, Hyderabad. So virus, as Dr. Jagan sir has just told, it's the most common thing. Why? Because we all know the force is more on the medial side. It's about 60%. So virus is the most common thing that we regularly see of all the deformities. So there is a classification by Theopent and Parvizi about the virus. There are different types. Type 1A is the intra-articular diaphyseal, which can be either reduced or it's fixed. And type M is the metaphyseal. And there is a type D, which is diaphyseal, which is more than 5 centimeters away from the joint line. In the type D, we have a DT, diaphyseal tibial level, and also DF, diaphyseal femur, and also DTF, wherein you can have varus both in the tibial and also femoral level. So what is the grading of varus? Usually it's about grade A or type 1, it is about 0 to 10 degrees. Grade B is about 10 to 20 degrees. Grade C is about more than 20 degrees. As the grading of varus increases, we usually see some bony changes also that can happen on the X-rays. So before going to know what exactly we do in terms of correcting the tight varus, we have to know the two basic methods of approach that we do for a total knee replacement. That is a gap balancing and a measured resection. What we do in gap balancing, in both the playing, in both the these things, we want to achieve good balance. But what we do in gap balance is we first cut the tibia, and based on the tibial cut, you have to put your femoral component. So the femoral rotation is decided based on your tibial cut. There are some very few companies which are doing it. And but the problem with this gap balancing is your tibial cut has to be perfectly accurate. And we try to match the tibial cut for the transepicondylar axis. That's your balance of your flexion gap. And what do you do in measured resection? We follow the axis, bony landmarks, the transepicondylar axis, the posterior condylar axis, all these, to get the measured resection right. So here, whether you do the tibia first or femur first, it doesn't matter. And the rotation of the tibia is mainly decided by this transepicondylar axis. So before knowing how to release on the medial side, we have to know the medial anatomy. So the anatomy, most important structures are the dynamic stabilizers, semimembranosus and pes anserinus, and medial gastrocnemius. The static ones are the superficial and deep MCL, posterior oblique ligament, and also the PCL. So first, before deciding whether we should do it or not, we should examine the patient after anesthesia, whether the varus is fixed or reducible, whether it is passively correctable or not, and if it is associated with any other flexion contracture. So, and we also look at the pre-op radiographs, both AP and lateral standing views, to see how much of the varus is there, and also for the osteophytes, both on the femur and also tibial side. Then we come to the stages of release. So there are multiple methods. There is no exact consensus on how much to release. Historically, we have been releasing the deep MCL and superficial and pes anserine, depending upon how much you want to correct your gap. So how we do it? So first, step one, it is basically about the conventional. If you have to correct the severe varus, we need to know what are the things that we need to release. And when it comes to robotic, we can adjust it in the bone cuts. So in the step one, we release the deep MCL up to the mid-coronal plane. Then we go ahead and remove the osteophytes of the distal femur, the posterior femur, and also the proximal tibia. And then we do the resection of the extension gap. There is distal femur cut and also proximal tibia cut. And then we check the extension gap. If the spacer is going well inside completely, you don't have to do any further release. If the spacer is going well on the lateral side and it's tight on the medial side, then we start releasing one by one. So for step two, we do the posterior oblique ligament. Usually, it also helps in correcting the FFD if there is any. And then again, we have to reassess the balance. So after each release, you have to reassess the balance. That's the most important thing. And for the step 3, then we'll go ahead and size the tibia, and then we do the medial reduction osteotomy. And after that, if it is still not balanced, we might have to, I'm a CR surgeon, so we prefer to do the CRDs. And if it is not balanced even after the step 3, then we go ahead and release the PCL and go for a PS type of a knee. And then again, reassess the balance. And even after that, if you're not able to balance it, then we have to release the final structures, which is the semi-membranosus, and which is like the last resort of the varus knee. And then again, reassess the balance. If it is not done after even that, then there is a technique wherein they put a laminar spreader on the medial side, they spread the medial gap, and they do the pie crusting. It is a little riskier. There have been reports which has damaged the MCL as well. And the step 6, complete MCL release as both superficial and deep, and also complete PES release. Then it is very, the medial side is completely gone. It is better to look for a constrained prosthesis. So how robotic has helped me in balancing better without releasing too much of a soft tissue. This is a case which we have done, which is having about 19 degrees of varus. That is a significant amount of varus. So we have released only the anterior triangle, and we have removed the osteophytes and up to the mid-coronal plane. After that, we balance it through the bony cuts. So how we do it? What are the bony cuts that affect the varus? We have to know that. So we can place the tibia in a bit of 2 to 3 degrees of varus. We can put the femur also in about 2 degrees of varus, and we can external rotate the femoral component to get the medial gap. So all these things will give you more medial space. So this way, without even releasing much of the soft tissues, when only by releasing up to the mid-coronal plane, by playing with the body cuts, we can get a good alignment. With this, this is the pre-op, and the post-op, you can see we have got a good alignment with the all gaps equal on both flexion and extension, about 11 mm. We have used 11 mm poly, and overall varus, we have put it in about 5 degrees. I believe most of us believe, especially if the patient is having severe varus, we can put it in some amount of varus for them to have a good functional outcome. To get that alignment, what we have done here, we have external rotated our femur by about 5. So when we external rotation, do the external rotation of the femur, there is a chance of notching. So we have anteriorized the femur, and flexion also, we have put it in 2 mm, and varus about 4 in the tibia. So these options we cannot get in conventional. That is where my robo has helped me in getting solving the severe varus by adjusting on the bone cuts. So there is a beautiful paper from South Korea. This is published last year. It says effects of severe varus deformity on soft tissue balancing in total knee arthroplasty. They say patients with a HKA varus of more than 12.4 degrees were more likely to have a poorly balanced gap. It is very difficult to achieve a good gap if you have a significant varus. So they're trying to accept the trapezoidal gap, wherein the medial is a little tight, a lateral is a little loose. And they say the patients are doing well with that kind of a knee. To conclude, extensive MCL release may be associated with mid-flexion instability. That is another problem when you do an extensive soft tissue release on the medial side, the mid-flexion instability. So medial instability after TKA may be the causative factor for post-operative knee pain and poor functional outcomes. Thank you.
Great and smooth talk, sir. Any questions on varus knee? Yes.
So this acceptable lateral laxity is different for each surgeons. So some people say they don't accept any kind of lateral laxity in extensions, and they're okay with up to 3 to 4 mm of laxity in the flexion. But in obese patients, I think it's always a bad idea, because we have seen enough patients who followed up, who we have accepted even 1 or 2 mm of laxity in robots. And then obviously the dynamic scanograms at 6 weeks, they show up to 6 degrees of varus. And over probably 2 or 3 years, the lateral opens up a lot, because not all of them get out of the obesity. So lateral laxity in extension in obese people, I think
When you say obese, how much is the BMI you're talking about?
So
Sir?
usually these are all stem tibia, so probably somewhere around 35, 40.
Okay.
So all of them we usually put a
You have stemmed the tibia and still you had a dynamic laxity on the lateral side.
Yes, yes.
It's in within 6 weeks.
Yes.
Okay.
So I mean, what we get in the robo and like we were discussing, initially we usually accept around 2 to 3 degree of varus, and we accept it finally. But when we have a protocol of getting scanograms at 6 weeks, so that minimum 1 or 2 mm in the robo might show us a lot on dynamic scanograms.
Of course. Agree.
Yeah. I think what you told correctly. Flexion, we accept about a 0.5 mm laxity. But
extension?
In fact, extension, no. But in fact, some laxity in flexion will do better, especially on lateral laxity, 0.5 mm.
That's for the better kind.
But in super obese, they're mostly hyperextension of the knees. In super obese patients, they're generally lax. So we normally conventionally will try to put a bit tight poly and make a little bit tighter. Once they mobilize, it become loose.
Sir, how do you assess intra-op? How much is your laxity on the lateral side, both in extension and flexion?
Robotic or non-robotic?
Anyway.
Anyway, yeah. Normally, we assess the flexion, extension should be equal, perfect. But in reality, it's a bit difficult. But in flexion, we accept, we don't do it, we don't bother much. But flexion, in extension, it should be equal. Sir.
Yes.
So we have to adjust with that.
Yeah, in robotics, anyways, we are seeing the gaps. We know it, whether
But
it is lax or.
Normally we rotate the 3 degree of femur. In varus, you rotate up to 5 degree or 6 degree of varus. Rotation to open the more medial gap.
So in cases like these of severe varus, what is your maximum acceptable limits of femur rotation or also tibia? Maybe for
if it is a conventional thing, normally if it's a kinematic alignment, yes, varus tibial cut is acceptable. In conventional, they said never cut the tibia in varus. Never cut. So you always accept a neutral or a little bit valgus tibia for the conventional mechanical alignment. If you are going for a normal conventional things, we accept maximum is 6 degree of rotations, not more than that.
Your opinion?
And what you said correctly about notching, if you do more, it will notch. So whether it is notch or not, we cut the anterior chamfer first, and then we'll see whether notching or not. Just you anteriorize the component. But if you anteriorize, the posterior condylar offset will come down. It compromises the flexion. Yes.
In CUVIS, I think there's a difference between single curvature radius and multi-radii femoral components.
Yes.
So in CUVIS, if you try to avoid notching by flexing the component, then gaps change, both flexion and extension.
Extension, yes.
But in a single curvature radius femur, if you flex the component to avoid notching, the gaps don't change. Means either flexion extension don't change. But in CUVIS, if you flex the component, extension will increase and flexion will decrease. And I think the realization of lateral laxity is more in robotic. I think before we used to accept what it is. And the difficulty of addressing lateral laxity will be in a small components, either 1, 2, where we released everything. We can't do measure that resection of the medial tibia. Yeah. I think that's where we have to accept later. The medial epicondylostomy might play there.
Especially in severe varus.
Severe.
Thank you.
Thank you, sir. My request, Dr. Sai Fanichandra, how I do a difficult FFD robotic TKR.
Very good afternoon, panelists. Thank you, Balaraaju Naidu and ONUS Hospitals for giving me this opportunity. So my topic is relatively uncommon thing in isolation, but it's TKR in FFD. So I am Dr. Sai Fanichandra, robotic replacement surgeon at KIMS Hospitals, Minister Road. So like I told, isolated FFD is pretty much rare unless it is associated with some inflammatory arthropathies or some septic knees which are neglected. In isolation, it is rare. So most commonly it is seen in association with varus or valgus deformities. The femoral, tibial, and intercondylar osteophytes, they cause stenting of the posterior capsule. That is the main pathology and which blocks the full extension. So Griffin et al. Have reported that FFD in varus is 67% association and valgus it is in 31% association and neutral with FFD is 26%. So what are the deformities which we can anticipate in any arthritic knees? Coronal plane, sagittal plane, and rotational deformities. Coronal plane are varus and valgus, sagittal is FFD and hyperextension, rotational in combination with any of these things. So there's a Lombardi classification, grade 1 is less than 10, 10 to 30 is grade 2, grade 3 is more than 30 degrees. So what are the problems we anticipate here? So one is a tight posterior capsule, as we have all seen. Apart from that, it is the intercondylar notch osteophytes, which prevent full extension, and posterior osteophytes. Next is the secondary contracture because of this posterior capsule, contracting the posterior oblique ligament, the semimembranosus if it is a varus knee, and popliteofibular ligament if it is a valgus knee. Along with that, there is a persistent extensor lag. Because of the chronic positioning of the knee in flexion, the quadriceps gets wasted. This wasted quadriceps, once we correct it, won't come back to its original power. It takes time for it to come. So this extensor lag puts the knee back into FFD again. So rehab is pretty much important here. So here I would like to show this image which collected from that CT. Here we can see this is the actual extent of the capsule where the osteophytes are tenting it above from the femur side and the tibia side. So this is the actual osteophytes and this is the actual femur what we can see. Apart from this, we can have the gastrocnemius contracture. So this is the extent of capsule which can come out as a flexion gap opening once we take the cuts, right? So how do we go about? There are so many papers on this as to show how to do it. And these are all conventional. So out of these, the most common ones after picking up all these things, the common ones are first is to removal of the osteophytes. Next is +2 distal femur cut and component size to be increased. Upsize the component size if the flexion gap is more when compared to the extension gap. So the key step is to removal of the osteophytes. If we can look into this image carefully, there are the posterior osteophytes which tent the capsule and prevent the knee from coming into extension. So now we have taken the cuts, the femur and tibia. But as you can see, if incomplete removal of osteophytes also tents the capsule partially and prevents the spacer from going in. So once all those are removed from the posterior side, only then the capsule stretches out and we can have a proper extension gap. So the key is to remove osteophytes, balance the extension gap first. Next. So in a conventional way, we take the standard tibial cut first. Next, the standard distal femoral cut or +2 depending on the gap. So now flexion and extension is gap. But if you can see here, medially there is still some tightness in extension and it is flexion. The spacer block is not going in completely. So the key is to remove the osteophytes. So we just release the capsule posteriorly and then you will see the spacer going in easily. So that will correct the extension gap and the flexion gap as well. So now that we have balanced the extension gap, what happens to flexion gap? Now that we have already released everything, the capsule becomes lax posteriorly. So we will have an asymmetric gap here now. So we have landed ourselves in trouble. So in a conventional way, how to go about is only one way is to increase the component. So we go one size up so that it will come down. Then we can decrease the flexion gap. But here is where the robotics come in, right? So we can play around by flexing the component, by decreasing the slope of the tibia. And if you say in a conventional, we just upsize the femur, medial-laterally we can mismatch or we can overhang either medially or laterally. So this is the summary of we could do in a conventional knee, right? So removal of osteophytes, standard cuts, and assess the gaps. So even a conventional way, this is how we can get away with the gross FFD's knee. So now comes the actual part. What is the role of robo here? So we can do flexing of the component, rotation of the component, shifting of the component, size selection, even before we can go in, tibial slopes can be changed, distal femur cut can be increased depending on the values seen on the J planar, and gap check done even before the cuts are taken. So all this can be done in a virtual surgery on the system. So these are the options which we can have at hand. And this is what I think Kishore was telling, by the way. So this is the rotation. If you can see how it affects the flexion. Now, if you can see the measurements over there, it is coming from 9.62 and it is affecting both. So that 1 degree of flexion has given me around 8 mm of opening. Just 1 degree of flexion. Likewise, the rotation part as well. If you can see into the rotation part also, by rotating it also, we can change the flexion and extension, the medial and the lateral openings. So either we can fix it laterally or fix it medial or fix it in the center. The center of rotation will decide which way we want it. Next, tibial slope can be altered here. And varus and valgus, if it is an associated or combination deformities. So even if we see here, if we change the component into varus or valgus, we can see that the distal medial and distal lateral values keep changing. So this helps us in planning precisely if it is associated deformity, how to go about and how to plan in these cases. So just a simple case which has an isolated FFD. So the robotic part, everything we have already seen a beautiful demonstration by Balaraaju. Now this is just a quick thing into the captured values. So this is a neutral knee after all the trackers are placed and mapping is done. So we have got a 15 degrees FFD over there. There is no varus. So it's a coronally well aligned knee. So, and after planning, we have got 1 degree of flexion in the plan with the knee, femur and 4 tibia. So, and there is only 3 degrees slope in the tibia. We have come with 8.9 distal femur and 6.3 distal tibial cut, distal femoral cut, medial and lateral respectively. So next, once it is corrected and values are captured, we could correct it to 9 degrees flexion. So we still have 9 degrees flexion to cover. So now we start playing around here, right? So first we balance the extension in the sense we did an external rotation and we cut 2 mm above, 2 mm proximally. So this has given us a proper extension gap. Now the flexion is still tight. So how do we go about there? So now that we have done that, so we have done an external rotation of 4 degrees. Since that external rotation will probably notch anteriorly, so we shifted it 1 mm up, right? Next, since the flexion gap is loose, if you could see the maximum captured values here, they are 15 and 11. So I need to bring that 15 down and keep the 11 intact or maybe decrease that as well. So here we have done an external rotation and the chances are to increase the flexion gap. So that's why you have taken a proximal tibial cut, which is shifted anteriorly by proximally by 2 millimeters. So that has given you a perfectly balanced knee, right? So this is how it is done in flexion and extension. So at the end, we have got a final alignment in that direction. So the conclusions are isolated FFD are relatively rare again. They are combined with varus or valgus. So the robotic helps in micromanaging the distal femur cuts precisely. We can even move 1 mm up or 2 mm up. Flexion and extension of the component to balance the gaps, rotation of the components in case of combination. And these gaps can be balanced prior and refined intraoperatively based on the tissue tension or laxity, which we see. Thank you.
Thank you, sir. It's nicely demonstrated on FFD. As you mentioned, FFD, it goes with varus. Both are sisters. Yes. Like Hari Prakash and you both go together.
Yes, sir.
So I think talks are also together, both FFD and varus thing. Any questions, sir? Alwalit, sir? Any from audience? Raja Ramesh? Sir, here you are reversing the slope to get it back, or normally 5 to 6 degree or 3 or 6 degree of slope will be there,
sir,
of the table slope. Few of the your demonstration shows reversing the table slope.
Sir, it's not reversal, sir, actually. The 3 degrees is already inbuilt into the component, number one. And whatever we are taking is the axis from the hip to the ankle in a corner plane. So that is the axis on which it will decide if it is in, slope is reversed or not. But if you take a short film X-ray, only then you will see it is reversed. But when you take a standing alignment X-rays from top to bottom, you will see that it is perfectly aligned. The short films are the ones which make it feel that it is then reversed.
In severe FFDs,
so,
Yes, you release the gastrocnemius also in your.
Yes, sir.
Yes.
Even in robotics also, if once we find it, we will have to release the osteophytes anyway. Keeping that in mind, the balancing is done in flexion as well. So I would be releasing an osteophyte and giving some laxity. So keeping that in mind, some tightness, we will leave it there as we are progressing along. And once that osteophyte is removed, that gap will open up anyway and come to where I intend it to come to.
Have you noticed any vascular injuries in severe FFDs once you correct suddenly? Any spasm or popliteal arteries?
Not in up to moderate cases, nothing, sir. If it is really severe deformities, then we may have to go for those things. But per se, not until now, God forbid.
Thank you.
Any difficulty in gap capturing in robot when severe FFD?
Yes, sir.
Spite
It is
of-
there because, you know, the medial and lateral laxities, calculating if it is a stiff knee is really difficult actually. If there are so many osteophytes tending.
Because robots have a certain limit where
Yes.
it has to be extended to capture the gap. So I think it's unless.
So that's what, even in that case, I showed you, sir, if it is only the 9 degrees, which I could get it. But clinically, if you see 9 degrees is not much, you will feel as if it is straight. But since we are putting number to everything there, we have to make sure that it is straight. So, and then only do it. But having said that, that posteromedial part, the posterolateral part tensioning, it's not, it varies. I may do it in one way, Hari can do it in another way. So my power and his power are not same. So like you said, there is a fallacy in that case where we cannot say which is the ideal tension to do.
So that so in the severe FFDs where we find in Mako especially, it has to be at a certain degree to capture the gaps in extension. So I think Mako already gives a pre-resection, mid-resection flow.
Yes,
So
sir.
SBJ has come with an enhanced mid-resection flow to make sure that we pre-balance a little, cut a little, and then make sure that it's extended.
Yes,
to
your
capture the
paper
gaps.
on
Yeah,
that is
an
yep.
admin section. So I think that is helpful using robot in severe cases. I think that is helpful in the balance.
But the problem here is you have to, it is predetermined. We cannot change it in midway. Like in your case, in Mako, probably we can do that. But I am really not sure. I have no experience with Mako.
Tried in other CUVIS also.
Okay.
But you have to cut little and then pre-balance, underbalance first. And then again, we have to capture the gaps.
Okay.
Take 1-2 mm cuts and so that we can reach the posterior osteophyte. Or
Okay.
we can reach the posterior tibia.
Oh, in CUVIS, you will already dock the revo. How can you go back and revisit the cuts again?
That's what I'm thinking. It can be done. We haven't tried
Can
it.
be done, yeah.
So we are doing many things where a lot of Indians, other states are not doing with CUVIS and Mako.
Right.
I think it
So
can
because here, once we cut, we have to dock the robo.
Yeah.
We take out, you cut 1 or 2 mm again. We may or may not place it in the same position
I
again.
understand. I
So
think
that will change the spatial orientation.
Mako definitely is possible. CUVIS we haven't tried.
Yes, maybe it can come out in the future, but for now, the spatial orientation given it, the initial cut should be the one for the later one also.
Thank you, sir.
Thank you so much, sir.
Small talk by Dr. Jahangir Pasha from Annapa. Now inauguration.
Yeah.
Ravi?
The titles are.
So inauguration, yeah. Jahangir, sir, you came all the way from Kadapa. Please wait for some more time. Yes, sir. Yes, sir. Sir, it's Kadapa is a separate country, sir. From where it's state, not country.
Yeah. Thanks to all the doctors who have supported.
Now we pause for a momentous occasion, the inauguration ceremony. It is our privilege to invite our distinguished dignitaries to light the ceremonial lamp and address the gathering by our respected chairman, Dr. Rama Naidu, sir.
Sir, now I request Ramanaidu sir, Jaganmohan Reddy sir, Srinivasan sir, and Alwal Reddy sir, please come on to the dais, sir. Dr. Sunil sir, sir, please, Raja Ramesh sir.
Ravi Teja, sir, please. Dr. Karthik, sir. Sir, now may I request Dr. Raja Ramesh, sir, Dr. Sunil, sir, and Dr. Srinivasan, sir, to come onto the dais and speak few words. Sir, yes, sir. Alwal Reddy, sir. Sir, Alwal Reddy, sir, please. Yes. I congratulate Dr. Balaraaju Naidu for organizing very effectively this CME on robotics. And the content is, he has covered so much, all about robotics, and probably he has worked for the past 6 months or so for organizing this. Otherwise, it is very difficult to organize this so nicely. I once again congratulate him, and I wish him all success, and he should grow from one step to a further higher and higher. Thank you.
At the outset, I congratulate Dr. Balaraaju Naidu and his team also, because it's not an easy job to organize so many live surgeries, and that to bring all the robots available in Hyderabad onto one stage. I think he is giving a great knowledge for the juniors, and it's a great scientific program. I think he is taking us at least 20 years ahead. That's what going to happen in the future. So he's showing the future to all the juniors. It's a great experience for me, and I hope the juniors will catch on with the robotic culture in the future, and but better service to the patients, and better results with TKRs. Thank you for giving me this such opportunity.
Sunil sir, I request one word, sir. Rajaramesh sir, come.
Thank you, Dr. Balaraaju Naidu. After wise words of wisdom from senior teachers here, I would like to congratulate Dr. Balaraaju and his team for this fantastic academic event. Though I may not be related to this, but I find the program is packed up with all of the best surgeons around with the best technology and everything. So congratulations once again. All the best.
I request Jagan sir to speak.
Sir, it's a great course. Congratulations to Balaraaju Naidu and team for arranging robotic TKR in one day. So bringing all the robots, as morning Alwaled sir is telling, the new technology is coming. I think probably the next few decades, you will get percutaneous knee replacement, like injecting a small gel into the knee joint. It will take off all the articular surface, and inflatable knee implant will be injected, and it opens and catches the femur and tibia and insert. Probably that is the next workshop by Dr. Balaraaju Naidu, I think. Thank you.
I request Rajaramesh sir, please.
Hearty congratulations, Balaraaju. Really wonderful, excellent work. Actually, one small thing away from this robotic, the passion about what the work. So most of the scene have seen the Naidu before 2 years. How the transformation? really, he's very much passionate towards his work. So really, hearty congratulations to you and your team. Thank you. Thanks.
Once again, thank you very much, senior doctors and my professor, beloved Professor Srinivasan sir. I grown up under Dr. Srinivasan sir. All the way came from long distance, and Alwal Reddy sir. All this, and special thanks to TOSA and TCOS who supported for this excellent robotic conference. And special thanks to Kunal from Mumbai, and Anej, Kunal and Rohit and Suprit from Delhi, Mumbai, Bangalore. All the delegates came from different parts of the country. Special thanks to everyone. And we will make next year event very big event. Thank you once again, all the faculty, and special thanks to our organizing team, Dr. Ravi Teja, Dr. Karthik, and Dr. Madhusudan.
Next session will continue. Sir, next session we will continue. Now I invite Dr. Jahangir Basha sir to come on to the dais.
Please, sir.
Kuna? Great.
ఇదేనా సార్
నాది ఇది
డిస్ప్లేలో ఉందా
ఇది రావాలి కదా Good afternoon. Well, respected seniors and friends, welcome to ONUS ROBOCON 2.0 2024. My name is Dr. Jahangir. I am from Kadapa. Okay, I use Velys Robo for this total knee replacement. Why use Velys is it's more accurate and reliable imageless enabling technique, work with any type of ailment. And in this scenario, I want to tell you about how I do the procedure. I prefer tibia first. Okay, substantially decreases my soft tissue dissection. And the indications, contraindications, same as the traditional method. Even fixed deformities also we can do. So planning, there should be some regional and systemic assessment always. And I prefer kinematic alignment and passive specific assessment and correction. How do I do? I prefer standard medial approach, meticulous osteophyte removal, ACL, PCL. I prefer mostly the PS models. And I usually go with the tibia first, assessing the HKA, and then get acute balance graph. Then use a tensioner and attain new acute graph, not always, in most of the times, and resect accordingly. If any other minor resections needed, please don't hesitate. Always go through. Okay, recut and then get the stable knee, then final implantation. Now, why tibia first? Because in tibia, we have 4 degrees of freedom, varus, valgus, then flexion, extension. But in femur, we have 10 degrees of freedom, varus, valgus, proximal, distal, then external, internal rotation, anterioration, posterior, and flexion and extension. And each of these have influence on the gap balancing. Now, more about the tibial cut. I usually prefer 4 to 5 degrees of tibial cut because our this robo usually overestimates the slope. And coming to the HKA axis, if the valgus is more than 3 degrees, then I maintain the valgus in tibial cut to 1 degree. If it is 3 degrees to 1 degree, I maintain to 0 degrees of valgus. If it is coming to varus, if it is more than 6 degrees, I will try to bring it to 3 degrees in tibial cut. Then if it is 6 degrees to 3 degrees, then I maintain it 2 degrees. And if it is 3 degrees to 1 degree, I try to bring it to 1 degree. And these values are not always, it may change intraoperatively. Now, gap balancing after tibial cut. After tibial cut, I used to put a tensioner sometimes, but in case of osteoporotic bone, I won't use a tensioner. And after passing a tensioner, I will get a range of movement from 0 degrees to 90 degrees. And then I get a new accugraph, and then I proceed to the femoral cuts. Now, balancing targets. I usually it is an inverse type of kinematics. Here, what I do is I maintain a little tightness on the medial side when compared to that of the lateral side. And if I want to keep lax, I keep the femoral gap little lax when compared to that of the extension gap. And that also up to 2 degrees only, not more than that. Now, or I try for a mechanical type of alignment. Okay, where all the gaps are same, or it is a kinematic also. So what are the boundary limits? According to FDA, femur up to 6 degrees of valgus is acceptable and 3 degrees of varus. Tibia 3 degrees of valgus and 6 degrees of varus. And HKE finally should be 3 degrees of valgus or 6 degrees. But few studies shows that up to 6 degrees of valgus is also acceptable in HKE. Now, this is a case of varus knee. I'm just planning, going to tell about the planning of the surgery. Varus knee, where the varus was 15 degrees. Now, this is a video showing how we plan accordingly. So, this is a graph showing this deformity. It is tight medially and lax laterally. And this is the picture before the removal of the osteophytes. Okay. So this is the picture we got after removal of the osteophyte. So after removal of osteophyte, the medial side is a little bit lax. So always look for the osteophytes and remove them before going the next plan. So as I already told you, I will prefer going the tibia first. And here the deformity is more than 15 degrees, 13 degrees or 6 degrees. According to the plan, I will maintain the varus cut up to 3 degrees. So I am increasing the varus cut of the tibia to 3 degrees. Then I got this 9.5 and 10 mm and the extension, and 0.5 mm is the difference, which I am very happy with that. And then with minimal cuts, we are going to correct the deformity. So most of the time with minimal 1 or 2 bone cuts also, we can get the correction of the deformity. If it is a gross deformity, then we have to fight a little bit. So, and I prefer in Indian population a minimal cuts only, not like 10 like that. Up to 9, I will accept. Otherwise, I have to come down that also, not more than that. This is a picture which we got after the final cuts. Now we will check the acutigraph also. See, acutigraph, I already told, medial and lateral, I try to have more little tightness medial when compared to the lateral side. And in flexion extension, flexion should be more lax when compared to that of the extension. So this is the final picture. So another case is valgus knee. Okay, it is a flexible deformity, not rigid one. So and this is the planning. I prefer transependular axis in this condition. As I already told, if it is more than 3 degrees of valgus, I will try to bring the tibial cut to 1 degree of valgus, not more than that. And then I will go to the distal proximal tibia and I will try to decrease that. And I already told I prefer the slope of 4 degrees because our robo used to overestimate the slope. And now I will go to the femur side, which have more freedom of correction than the tibia. So now I increase the valgus. Now I am going to decrease the external rotation. With these cuts, you can manage a mechanical type of equal balanced cut, or even you go for kinematic type of alignment, the functional alignment. So now you see the final result. It is nicely balanced and achieved what we want according to the inverse kinematics. So this is the final result. Thank you.
Next, I would like to invite Dr. Praful Kilaru for management of periprosthetic distal femur fractures.
At the start, thank you for the organizers for giving me the opportunity. So I'll be just moving away from the normal field of what is the ideal TKR and a robotic. So what happens when a trauma occurs in a following a robo? So my talk is basically distal femur fractures, periprosthetic. So why it is more important is as the TKR's trend are going to increase, you're going to have these fractures which are going to come by. And mainly the distal femur is the commonest area to have these fractures and how to deal with this. Main causative factors for this is main is notch index, anterior femoral notching, which has been negated by our robo CT scan my imaging part, but still they can have some notch. And osteopenia, as most of the TKRs will be having. And as per the studies, many people are coming to say that cruciate sacrificing or cruciate retaining has less incidence of periplastics, but they still know there are no RCTs. As you can see the figure about the notching, as the notch part increases from grade 1 to grade 4, your chances of periplastic fracture also increases by 3 folds. What happens mainly, what are the challenges with this periplastic? Most of the periplastic fractures of the femur are definitive by surgery. Osteoporosity, as we all know it, and the limited bone stop because of the previous natural bone is gone, and a surgical scar which is proponent for healing issues. How do you classify this? I go with previous yesterday was basically Lewis rollback classification, but the classification system also has been developed into many other things. Mainly what I follow is novel classification system. Just type 1 is extra-articular, type 2 is mainly partial extra-articular with little limited bone stock in the femoral component. Type 3 is complete fracture of the femoral component bone stock area. And the recent classification is a SU classification. It's a similar to the what is novel classification system. Basically, it sees the primary fracture line where it is originating. As on that basis, it increases. Type 1, it is when it is proximal to the femoral component, you can go for osteosynthesis. As it go prolonged to type 2 to type 3, it is more goes for the revision. In a basic algorithm, what I generally follow is you see as we all see the process is stability. But another part which we are going to concentrate is how much is your hold you're going to get it in the distal component, mainly your screws or the cross screws, either through the intramedullary nail or by extramedullary implant. That is more important than what is a bone stock. What are your fixation options? Locking plate and intramedullary. Both have a minimal invasive, but I generally go with plating. Why? Because this is a more of like a periarticular fracture. For me, the rigidity is more important and gives a better angular and rotational stability and low rates of malunion. And MIPO is a preferable metal because it is a more biological fixation and less blood loss, and you're negating your previous surgical scar as well. Procedure, as we know, we just, as you can see in this pic, it's a type 1 fracture of the SU classification. Here we did a plating through minimal invasive. In a brief, I think the video is, yeah. So it's a small animated video, which I'm just showing our MIPO procedure for this. We do a minimal invasive percutaneous screw fixations for the distal and proximal fracture, proximal the reduction. This is a lag screw application which you see in the proximal segment as well as in a distal segment. Now you got your positional screws in, reduction is maintained, and you just have to do a MIPO where you put a neutralization LCP plate, thereby controlling your both angular and torsional stability in the periprosthetic area. So you're going to give your working length as much as possible in these fractures. That's it. So we have done a study when I was in Sunshine about the periprosthetic fractures. Our number at that time was 48. We see a lot of good positive figures about it. Most of the fractures have gone into union, and most of the outcome based also is more than 50 as per Knee Society score. But every surgery has its own complications. We have seen some failures in our surgery as well. Mainly, we contribute that to early weight bearing and due to porosity. So in a conclusion, management of periprosthetic fractures type 1 is mainly permits stable fixation by LCP plates. Biology plays a vital role. MIPO is as less invasive as nailing, so you can choose both of them. But the recent trend they are saying about the anterior notch index plays a vital role in your periprosthetic management. When your anterior notch index is below 3, I think it's better to go for replacement and always aim for rigid fixation. Thank you.
Yeah, great talk, Professor. Next, I would like to call upon Dr. Kishore sir for planning and workflow of Mako Robotic TKR.
Coming. Yeah, that is what I want to become. So at least AI has realizing my dreams of becoming thin and smart. Yeah, so this is Kishore Karmuri. I'm a robotic joint replacement surgeon at Sunshine. I'm a proctor for CUVIS and Mako. So actually the surgery, live surgery has been done in the morning. So it's just a recap of what you have seen in the morning, just to register. It's a revision of what was done in the morning. So the agenda would be the workflow and pre-op planning, CT. I think any CT-based robot would be planned in such a way. The array, checkpoint, I think bone registration, and this is common for all robotic thing. So let's go through that. So CT-based planning and the dynamic joint balancing and acute-stop haptic technology, that is the core features of Mako knee. And this is a workflow. A preoperative CT scan is a must for all the patients. Next, array placement, landmarks. There's reinforcing the plan onto the robot again. Initial assessment, implant adjustment, bone prep trialing, and final preparation of the tibia. So this is the workflow which happens. So this is how a CT scan is taken. The CT scan, we concentrate here on the hip center and the knee center and the ankle so that the mechanical axis can be calculated, from where we deviate with all the other alignment strategies from mechanical, kinematic, functional, listed kinematic, anatomic, whatever you name. I think that is important. That axis is important to understand. And this is how we take in knee, the proximal femur, the knee and the ankle. This is the landmarks. This is the striker. MPS will go through these plans. So they take and they make sure that it's the hip is in the center. They identify the epicondyles. They identify the knee center, and at the same time ankle center also to draw this thing. I think if you are planning a surgery, I think you better check these their plan also, whether they have kept the proper landmarks, because that can give difference in gaps and execution also. So again, this is a basic plane where MPS shows us. If you see here, the 7 is a proximal tibia. This is excluding the cartilage. So it's essentially 9 mm we are cutting on the tibia. So this is what the basic plan the MPS gives us. This is 8 mm on the posteromedial, distal, and 8 mm on the posteromedial. 8, whichever comes first, either lateral or medial. So they have a rule of 887. This is what the MPS gives us the plan. Either in Mako and CUVIS sometimes. So it's the basic plan they give, and here the sizing is also given 3, 4, 9. So in a axial plane, we know whether there's a medial lateral is good or not. This is the coronal and this is the sagittal plane. So we see the notching, how much is the flexion, how much is slope, everything what they kept. This is a starting point for all the things. So now they have a different KA start point is a different thing, but it's a basic thing which we look at. And the robot also gives us signals when if it's cutting more on the medial or if it's airballing or notching, it tells us. So that's where we can make sure that we are not doing anything wrong, or if it slips out of our mind, it will remind us. As I said, this is excluding cartilage, the bone cuts. And this is what 8 mm, what I said, 8, 7, and 8. The sagittal plane here, for a PS in Mako, the acceptable is 7. In a CS, it is 10 degrees. The flexion of the whole component includes the flexion of the femoral component, the slope. So in a PS, it is 7, and CS, it is 10, and CR, it is 12, because we increase the slope in CR. And as OR layout, here we have the robotic, because it's semi-autonomous, we have to hold the saw. So the robot will be on the operating surgeon side, and the camera and the screen will be the other side. So most important things are these pins, because we have 3.2 and 4 mm pins, both for tibia and femur. And the very important thing is it just should touch the second cortex. It should not pierce, it might be a stress riser. We haven't seen any fractures, not fractures, probably 1 in 8,000 or 2 into 8,000 knees that we have seen fractures. Most of the people have the doubt if you have pins that might leave a stress riser. So the pin placement is also a little different, extra incision, intra incision. Now we moved into intra incision. So we're keeping on to the medial surface of the femoral condyle. And this is how we put it, and make sure it doesn't come in line with the chamfer cut, or if you're preparing a box into the box. So that should be kept little away proximally. And this is the tibial pins, intra incision, extra incisional. If it is intra incisional, we have to use a hip array, so that we need not give a stab incisions in the tibial shaft. So this is very important, because there are some scenarios where we have to convert the robot into conventional, because these are not tightened properly. So this is the picture which shows that we haven't tightened it properly, but yeah, we have to tighten it properly so that we can execute it. If that moves, the gap moves, and if it shakes, the robot stops. Especially in CUVIS, it's so sensitive, even if the patient breathes, the CUVIS robot stops. In Mako, a little better. So these are checkpoints. We also stopped using checkpoint because it needs a stable and bone point, or a checkpoint where we can always come back to it. So some surgeons still use it. This is a femoral checkpoint, the tibial checkpoint. And as I said, bone registration is just reinforcement of the patient plan on again into the robot. So they have 40 points, 10 sets of 4 points each, 14 femur and 14 tibia. So here the distance to the bone should be equal to or less than 0.5. And once you have done it, see these yellow and red spots. Yellow shows it's 0.5 to 1.5 and red greater than 1.5. So once these are all popped out, it should be popped. And once they are popped out, then we can go for the joint balancing. So as I said in the previous, there was a mid-resection flow in severe cases where we initial bone prep, then feel the ligaments, again final plan adjustment has to be done where the knee can't be extended completely or the severe deformity. But in regular cases, pre-resection is important, the implant adjustment and bone preparation. The osteophytes mostly have to be removed after bone registration. With simple osteophyte, generally in some cases we remove before registration, but it's ideal to remove the osteophytes after registration. And again, this is the assessment, native deformity, corrective deformity. I'll show in the slide. See. So these are the things we all capture. What's the native deformity? What is the corrected deformity? What's the varus, give valgus and see how much is correcting. And extension medial laxity, extension lateral laxity, flexion laxity. This is how we capture the values. This is 1.5 mm lax, 2 mm lax and 2 and 2.5 mm lax. So there's a loose joint here. And how much is the varus? 2.5 varus. So this all can be captured here to understand the joint, what it is. This is a native deformity, is in hyperextension, 6-degree varus here. So, and after correction, after gap capturing, depending upon what kind of alignment you want, there is a functional, mechanical, kinematic, restricted kinematic, whatever you want, you adjust the gap accordingly. Generally, most of the times we are following with, now we changed from mechanical start point to kinematic start point, but generally we do functional alignment where we accept 3-degree varus in the tibia and 2-degree varus in the femur. So the lateral laxity is well addressed, so the medial tightness is addressed. Yeah. So here again, giving whatever the components, whether it's in varus by pinning medial, or if you want to open lateral by pinning lateral. So this is the medial and lateral laxity are addressed here, extension laxity. So we generally make sure that extension is balanced well. We don't, probably 0.5 mm is lateral what we accept, but extension we are balancing well. But in flexion, we are giving it to 1.5 to 2 mm lateral laxity so that probably we are recreating in a CR knee, a medial pivot knee. That's what we are trying there. There's a flexion again. As I said, we capture these gaps at 90 degrees, probably. Mostly we try to capture at 90 degrees. And this is the initial assessment. After all capturing gaps and corrected deformity. So for here in this case, all gaps are loose, just raising tibia by 4 clicks or 2 mm, the joint is balanced. As I said, this is the maximum limits which we try, other than we want to create a medial pivot, extension medial laxity and lateral or flexional medial and lateral. So bone preparation, as I said, this is an acute stop haptic technology. It's, I think, patent of Stryker. Where this is the haptic boundary, the saw doesn't cross this boundary, but if it does, it stops. So we can cut accurately. This is a sagittal saw attachment for distal and the posterior chamfer. This is a angle saw for a distal and posterior chamfer. This is a straight for other cuts. We have 2 sizes blades. One is small and standard and smaller one. For less than 2 and 2, we use a smaller blade. So as I said, we can, MPS helps us through forward to the cuts, or we can just press the trigger twice to go to the next level. Here also the robot tells us if it's blue line means it's proud, and when you cut it, it'll become white. If you're cutting more, then it shows 0.75, more than that, it turns red. So we'll know that we are cutting more. The robot tells us that. So there's an advantage of robot. So trailing, after final trailing, again, after trailing with before bone preparation, we can just keep the trial and releases after what is necessary. We can see what is the flexion and extension laxity. So this is in this case, we have a net 2.5 RS and 1 degree flexion, and the extension is well balanced here. Same goes with the flexion after trials. And after trials, we go for cementation or preparation cementation. So after that, confirm the sizes of tibia and femur and all 9 commandments which we follow at Sunshine, and cementation and closure. So these are the multiple cases we have done here, severe cases. Yeah, thank you. So I also invite all, I'm taking this opportunity to invite you to visit my center. I work in SBJ, but I recently started Center Ananta. It's a transitional rehabilitation pain management center. So thank you.
Yeah, thank you, sir. Thank you so much for your inspiring words.
Yeah, next we invite Relive Mako UKR by Dr. Adarsh Annapa, sir. Sir, please welcome, sir.
Yeah.
Yeah, this is also fine. Please keep this. We'll just keep them. That's fine. Okay. Yeah. Good evening, everyone. I'd like to thank Dr. Balaraaju for inviting me here today. So I'll be speaking on, I'll just show you my real-life surgery of partial knee replacement with the striker Mako robot. We call it as robot-assisted partial knee arthroplasty, RAPCA, like RAPCHIC. We call it RAPCA. So this is the planar workflow. Earlier, the whole case used to be done with the burr, but now we have a saw plus burr thing. Do you have a audio as well? Is it a recorded one? No. The video audio. Yeah. Right. So I'll just take it. Right. Let me mute it. I'll just speak over it better. Okay. So the selection criteria is the same for a robotic or whether it's a conventional case. You need to have, as far as possible, try to get your Oxford X-rays, Oxford series, where you have a varus stress and a valgus stress. Varus stress should give you completely reduced joint space in the medial side, and valgus stress should give you no reduction in the lateral joint space. You can get skyline views as well, just to make sure that there's no patellofemoral arthritis. Okay. So going forward, as Kishore just mentioned very beautifully, this is a Mako. It is a CT-based robo. So you get the opportunity to plan beforehand. So you have all this information before you even go in for the surgery. So you have 3D model. You can plan the sizing and everything. Okay, so I'm just going to switch on the audio here because I'll just show you how we plan this. Was on a 3D view. Cannot see for something is actually critical. This is a CD-based program, so the product specialist has done a segmentation of the CD slices and made a 3D model. And he has done a tentative plan to the model of the part. So now let's see the size 3 is matching. Let's scroll through. Keep scrolling, keep scrolling, keep scrolling. So you can see it's matching the cortex. Okay, so now you look at the sagittal view, you can see that it's matching a slope as much as possible. And it's important that you keep it proud by 3 mm. You don't want to go too deep when you're taking your tibial cut. Otherwise, you end up in the soft metaphyseal bone, which will end up in medial condyle fractures. Okay. Then you go to the femur planning. We first like to look at the 3D model, and then we look at the transverse coronal, sagittal, and the 3D views. I like to look at the transverse view to make sure it is just nicely matching that curvature of the condyle. It's nicely matching that curvature there. Okay, and if you see the sagittal view, I like to make sure that the implant is, the magenta line is bisecting the implant. That means the part which is protruding outside the magenta line is probably where the cartilage was before it was worn out. So that's why we like to match that. So it's very similar to the TKR. You have the camera from the other side. You have a product specialist. And you have the Mako coming in from the ipsilateral side of the surgeon. I usually like to use this leg holder, but you can get away without it also. You have to have a correctable varus when you're doing a uni, and make sure you're not in fixed, too much of high fixed flexion or recurvatum. I took slightly bigger incision here so that it's better to record. It's slightly medial. I always start any uni case by checking my 3 criteria: medial bone-on-bone arthritis. Okay, and lateral pristine cartilage. This is medial bone-on-bone arthritis, lateral pristine cartilage, and an intact ACL, a functional intact ACL. Even if it's a bit frayed, it's okay as long as it's a functional ACL. You can check with the ACL hook, or you can even do an anterior ROS to check. So I usually take my extra incisional pins, so in the femur and the tibia as well. These are 3.2 mm pins in the Mako. And these are called the arrays. I think you've already gone through all these surgeries, so I'm not going to go into depth about what is an array and everything. These are the checkpoints that we put in. As Kishore is mentioning, the checkpoints have to be in a strong cortical bone, so they don't move during the surgery. You have to make sure that it's in a good cortical bone. So usually the femur, I put it on the epicondyle area, and the tibia is near the tibial tuberosity. So the center of the hip is taken. So these are information that we need to feed into the robo, so it knows where the actual axis is, the mechanical axis. So the center of the hip and the center of the ankle, it is given by the medial and lateral malleoli. Okay, this is with the green probe, which is the blunt probe. Then you feed to the robo where the checkpoints are. And now you start your fine registration. So the important point of any robot, whether it's an image-based or image-less, is you have to do registration. Basically, what you're doing is you're feeding the robo information about the real-time bone. So in the CT-based, you already have a CT scan. So you're just taking multiple points to match and map over to that CT scan. If it's matching less than 0.5 mm of accuracy, it lets you go ahead. In the non-image based, the image-less, that is a non-CT based ones, you have to paint the whole bone, like the Velys and in the CORI. So you take multiple points on each bone, the femur, as well as the tibia. Here, you can notice compared to the Mako TKR, the points are all restricted to the medial side because you don't have to expose the lateral side at all. So once that's done, you have to make sure that the accuracy is less than 0.5. You can see over here. You can see my cursor, yeah, right? So that's that. And then you have to do a verification step where you burst all these bubbles to make sure that the robo is very accurate. It's just another foolproof step. Okay. Then you go to the tibia. Again, 40 points on the tibia, and you take your 6 verification bubbles. And once that's done, your registration part is over. So now the robo knows exactly where your bone is in real time. So as you move your leg, it will move along in real time. You can see that. Okay. So the next point is you assess the ligament laxity. Now the next point is the balancing part. This is a fixed bearing uni, unlike the Oxford. So it's very important you take out your osteophytes after registration because it's a CT based. CT scan is done with the osteophytes intact. Now once that's done, you take out your osteophytes and then you check your gaps. So first we see how much flexion we have, how much of varus you get, 9 degrees over here in this case. And an important thing is you're not trying to correct down to neutral. Don't try to overcorrect your knee. In the uni, you're just resurfacing the worn out bone. You're just trying to bring the MCL to its original tautness before the wear out happened. So you just have to take a glimpse of what your original varus was. We take a screenshot and then we do a correction of the varus at each post capture. You take 4 post captures, one at 10 degrees of flexion. You see how much it's opening up and you take a capture of that. Okay. Then you go to 45 degrees of flexion and then you do the same thing. So you're not trying to overcrank it. You're just trying to bring it to the normal tautness of the MCL. Then you take it at 90 degrees. And my technique is I like to put the thigh on my abdomen and use my right arm to give the cranking up on the leg. And of course, you take one at 120 degrees. The reason you take 4 post captures here and only 2 captures in the TKR, we take only flexion and extension as shown by Kishore. The TKR is a triathlon implant, which is a single radius implant. So you just need to take 1 in flexion, 1 in extension. But this is not a single radius. You need to take through the arc of motion. So now that you've done your post captures, you get a graph like this. Now, this is the crux of any robotic uni. You have to get proper balancing. The uni is all about just sculpting. You have to be very, very precise with your balance. So this is the bar is the tightness or the looseness at each post capture that we took. This is 10 degrees. This is 45 degrees, this is 90 degrees, and this is 120. Everything above the line is loose. Everything below the line is tight. So we aim for 1 to 1.5 mm loose on every post capture. And we do this by moving your implants around. So if you notice, I'm in an ideal position in my extension that my 10 degrees flexion is quite good, but I'm tight in the other post captures. That means in 45 degrees and 90 degrees, I'm too tight. So how do I loosen up that flexion gap? Anybody take a guess? What would you do here? You work on the femur, right? You anteriorize the femur, so it opens up your flexion gap. So let me show you how we do that. See what I've done here. Because this is fine and I just want to loosen up my flexion gaps, I go to the sagittal view and I start anteriorizing my femur. Is it playing? Yeah. Yeah. See what happens when I anteriorize the femur? The flexion gap starts to open up. The 45 degrees and 90 degrees starts to open up. And then now my 4 bars are above the line, which is what I wanted. And I think I'm quite happy with this. So as long as they're above the line and aiming for around 1 to 1.5 loose in each bar, we're absolutely happy with that balancing. So the balancing part of this surgery is done. Next point is because this is a fixed bearing, you have to make sure that you're not edge loading. You need to have a properly centrally tracking implant. Again, this can also be taken care of by adjusting the implant. So these red dots are the center of the tibia at each post capture on the femur. So you can see that they're slightly more lateral. This is medial, this is lateral. So the tibia is kind of tracking a little laterally on the femur. So what do? I either lateralize my femur a bit so that these red dots go onto this black line. So I go to the lateralization and I put my probe on the bone to make sure that I'm not overhanging into the notch. That's my probe in real time will be sitting on the bone. And as long as I'm within that probe, I'm okay. And now you see it's a nice central tracking tibia. So now I'm going to avoid edge loading by doing this step. This is called implant tracking step. Next, you do something called as ACL check. Okay. So what I do is I take the probe. You can see what I'm doing here. I'm putting the probe on the medial most fiber of the ACL and making sure that my implant is not cutting off the ACL fiber. So again, this is another important step to avoid damage to the ACL. And the final thing is something called as cartilage mapping. CT scan doesn't know where the cartilage is. It only knows where the bone is. So I put my probe on the intact cartilage just in front of the implant, take 2-3 points, and it forms a yellow line in the sagittal view. You make sure that your implant is within that yellow line. You don't want to be proud to the cartilage. If your implant is proud to the cartilage, your patella will jump over it. So you don't want that to happen. You want a smooth transition. So you make sure your implant is within your yellow line. So I'm absolutely happy over here. And I'll take one more glance at the graph to make sure everything is within normal limits. And then I start executing my cuts. Okay, so the robo comes in. We do something called so initially you put in a saw. The first 2 cuts are done by the saw. As I mentioned, this is a planar workflow. Now this is the only workflow we get. So this gives you less strain on your thenar muscles. Earlier we were doing the whole case with the burr. I don't know how the TKR guys do the whole case with the burr. So even in the uni with the burr, it was quite painful. So now we take the proximal tibia and the posterior femoral cut with the saw. Okay, and I'll rush through. And the posterior femur is also done with the saw. And then you get the burr in. You just have to change your handpiece to the burr. Again, you're within your boundaries. So it doesn't allow you to go outside your boundaries. So you finish off your distal femur. It also gives you option to do your peg holes with the robo. It directly guides you into the peg holes. And then you have your your lateral ridge of the tibia. This is also burred out. Once that's done, you have a beautiful bed for your implants. You put in your nicely conformed implants, the tibia and then the femur. You slide in an 8 mm poly. You see that nice transition between the cartilage and the implant. You slide in your trial poly. And then you have an option to also recheck after you put your implants in whether you've matched exactly what you wanted. So you again take it through your arc of motion, 10 degrees, 45, 90, and 120, and see whether you're matching what you had planned in the virtual planning. See, the orange bars are the with implants in, and the blue are the virtual plans. So you can see whether you're matching or not. You're within 2 mm close to what we had planned. The final bed, do your wash, put in your final implants with cement, and hammer in your implants. And then you take your final check again. Also, you can do the orange is with the trials, and green is with the final implants. And then you have a nicely tracking joint. I'll just show you. Take out the check. Make sure you take out your checkpoints. That's most important. We have a mob count. We have a checkpoint count as well. And just show you what the X-ray looks like. There you go. So the beauty of robotic partial knees, you know what every X-ray is going to look like. They always look identical every single time. And you'll have a very nicely functioning knee. Thank you.
I think that's a great talk by Dr. Adarsh. I think since morning, everyone is so exhausted with a lot of robotics and different companies, techniques, and alignments. Next, I would like to call upon Dr. Kiran Kumar Reddy to give a talk on how to lead a stress-free life.
So before giving his lecture, I would like to thank our cardiologist. It is a routine orthopedic surgery with robotic surgeries. Everybody feels that, robotics is a marketing or it is a patient-friendly implant or what is that? So how exactly surgeons are facing the stress? So he's our young dynamic cardiologist and he's our co-founder for ONUS Heart Institute. Thank you so much. I have love and affection, lot of love and affection towards Kiran Kumar Reddy. Very young and dynamic, and it is top-notch technology, AI-based cardiologist in Hyderabad. Thank you so much, Kiran, for coming here all the way.
Good afternoon, everyone. Thank you, ROBOCON organizing committee, for giving this topic. Basically, I don't know. Cardiology is full of stress, but Balaraaju has selected me to lecture on this. So how surgeons, I provide the insights, which is available data with us. So introduction, see, this is the hierarchy of needs for everyone. So everybody needs, everybody life needs some basic things like physiological needs, safety needs, belongings and love needs, esteem and self actualization. So then coming to the stress or burnt out rates is more among even doctors. It ranges from 30 to 38% in surgeons. So a comprehensive study of AC, American College of Surgeons, showed 40% surgeons experience burnt out, 30% experience depression, and 28% have a mental quality of score greater than half of an SD below the population now. So what is meant by burnt out experienced by the surgeons? It is a syndrome of emotional exhaustion, feelings of depersonalization, and lack of personal accomplishment, especially in relation to one's professional activity. So what is the data showing? You can see percentage satisfied with work-life balance and percentage of burnt out. We can see where highest burnt out is seen in emergency medicine. This is data from one study, and you can see orthopedic surgeries are also experiencing significant burnt out. So what are the reasons? There may be professional stressors, emotional burden, and physical demands and work-life imbalance. So these are the main things. So basically limited control over the provision of medical services in settings and long working hours, enormous workloads, imbalance between career and family, feeling isolated or loss of time to connect with your colleagues, financial issues, grief and guilt about patient death because daily dealing with complex cases scenarios, the inefficient or hostile workplace environment. So then coming to the intraoperative stressors are very much like if you see emergency cases, you can get and surgical complications, unexpected bleeding problems, high-risk cases and equipment malfunction during the procedure and administrative operation theater management problems. You can treatment problems like incompetent staff or distractions during the surgery, need some personal factors. So a lot of stressors will be there while handling a surgery for the surgeons. There may be psychological and regulatory and occupational medicinal risk also will be there, like intensity and complex of the work, work schedule constraints and weekly workloads, difficult work schedules, and emotional requirements, tension with the public handling, and being face to face with the suffering of the others we are daily doing, lack of autonomy at your workplace, and deterioration in social interaction at work, lack of support from colleagues or from higher ups, and even conflict values between yours and the organization, and the job and work insecurity. So the studies showed commonly reported risk factors associated with burnt out among surgeons, like increased risk with the younger age and increased risk with the conflict between your personal life and work. And it is seen in more females and decreased risk with the happy personality of marriage life and decrease with incentive-based pay. There are some factors. So these are all the factors which can be lead to burnt out among surgeons, like long work hours, high responsibility, lack of work-life balance, emotional burden, administrative burden in personal clinics or own setups, lack of supportive staff, financial pressures, patient expectations is a biggest thing, and medical legal issues from our patients, which are continuously creating problems, continuous learning process. We need to update with our knowledge regularly, and interpersonal conflicts in your institute or departments, and workplace violence, mental health stigma. People feel that taking support within your community, they feel like stigma, and a lot of coping mechanisms. So Indian scenario, you can see all these things like high patient load, difficulty in educating your patients, lack of understanding capabilities of your patient and attenders, sometimes rude behavior of the patient attenders, inadequate medical facilities and support, sometimes medical legal issues, government departmental pressures, patient over expectation from doctors, financial issues from the patient side, human resource problems in your hospital, lack of adequate staff, meeting corporate hospital demands and expectations. Initial phases of careers will pose you a lot of burnt out, less family and social life, declining doctor-patient trust and relationship, particularly VIP patient attention and problems, and a lot of issues during death declaration and this thing. So how to identify your stress when you are this thing? They're like emotional. You may experience anxiety, sadness, or lack of drive, irritability, hypersensitivity, and lack of emotion. Sometimes physical, like trouble sleeping, musculoskeletal disorders, lot of pains, headaches, vertigo, and gastrointestinal problems. And then cognitive, decreased focus and cognitive fatigue, memory and attention problems and concentration problems, and behavioral issues like aggressive behavior or reduced empathy, withdrawal to society, or addictive behaviors, and motivational, like reduced motivation and morale and erosion of values associated with it. These are the signs and symptoms when you can identify your stress you're experiencing. And what is the consequences of this? This will be like both personal and professional, like depression, anxiety, suicide, broken relationship within the family, friends or colleagues, addiction to drugs or alcohol, marital dysfunction and divorce and early retirement. And professional, you may be disengaged, poor judgment in patient care decision making, hostility towards patients, medical errors, adverse patient events, diminished commitment and dedication to optimal patient care, and difficult relationship with co-workers. So there are a lot of sequences both in your personal and professional life because of stress and burnt out. So there are some biological markers you can for the acute stress, like serum cortisol levels and heart rate, peak heart rate and mean heart rate levels, and even heart rate variability, where there may be changes with your increased sympathetic activity because of your stress. And tools used to measure burnt out, there are a lot of tools like available linear analog scale assessment of quality of life, particularly which is most validated is MBI scale, Maslach burnt out inventory scale, and another one is physician well-being index. So this is the Maslach burnt out inventory where you can grade from 0 to 6. So there are emotional exhaustion criteria and personal accomplishment criteria and depersonalization criteria. So you can grade from 0 to 6, and you can see the scores like low grade to moderate to high grade. So we can see, calculate your oneself. Also, you can identify what are the stress levels in your jobs. So what are the professional solutions for the stress-free life? So you can identify your personal and professional values and priorities. So which is most important, which is reflecting on personal values and priorities. Strive to achieve your work-life balance always. Rank what the personal and professional values and priorities in order of your importance. So identify where they may be incompatible and determine how conflict should be managed between your professional and personal life. And enhance area of work that are personally meaningful, and reflect on areas of work that are most meaningful period, that is patient care, education, administration, and research, which is important, and reshape practice to increase focus in areas of personal meaning and decide on the value of further training for stress reduction. Then individual strategies for adopting coping, like you can recognize stress and emotional burnt out and adopt your own coping strategies, cultivate and maintain healthy personal relationship and spiritual practices, seek help whenever it is needed, maintain appropriate nutrition and physical fitness. So these are some measures you can consider at an individual and organization level, from workload, job demands, efficiency, and resources, like shortened shifts, method of compensation, and quality of your supportive staff, flexibility over your timings, work hour distribution, policies regarding your cross coverage when you are in vacation or sick leaves, social events, team building, and retreats. All are important to cope up with your stress during your profession. And what are the personal solutions for stress management? So you have to identify your personal and professional values and priorities. So reflect on those and try to achieve balance between those, and make a list of everything and prioritize according to your order which is important. And enhance areas of work that are most personally meaningful to you, particularly patient care or education or medical education, and reshape your practice. Improve your skills in specific area wherever it is needed to reduce the complications during your work, and identify opportunities, and periodically reassess what you enjoy most about your work, and identify and nurture personal wellness strategies for importance to you, like protect and nurture your relationships, nurture religion and spirituality practices, develop hobbies and use vacations, ensure adequate sleep, exercise, and nutrition, which are very important, and define and protect time for personal reflection at least a month. So these are the personal wellness strategies which are very important one should cultivate, like cultivating relationships, personal reflection activities, spiritual practices, self-care like exercise, adequate sleep and nutrition, hobbies and personal interests, which are most important to reduce your day-to-day trips. So mindfulness, physical activity, healthy lifestyle, and quality time is very important for yourselves. So most important is peer support, mindfulness and self-care, improving your communication skills, teamwork which is most important, and resilience training and advocacy of change. So these are the most important things. So work-life integration strategies are important. You can see here the 168-hour week schedule, which is unchangeable for you, but how you can differently confine you to yourself, work, and others in different scenarios, like normal, or when you are on vacation, or when you are at major hospital service. So set your boundaries, flexible schedules, and plan your vacations and celebrate your successes. So work-life integration is most needed. So these are the improving physician work-life integration at organization, provide flexible and work schedules, provide part-time work options, mentorship and role modeling is needed, team-based care and workforce redesign is important. Create an organizational culture. And from individual level, establish firewalls that prevent professional life from spilling into your personal life. Hire out personal task coaches. And concept of good enough is better rather than feeling like where you want to be perfection. So manage your stress with your decision making and teamwork and technical skills. So conclusion, take care of yourself first to take care of the others. This is most important. So stress in surgeons faces high stress due to long working hours, and physical impact may cause mental and physical strain, and emotional impact is also in the form of anxiety and depression. So everybody should learn their own stress management techniques like mindfulness, regular exercise, rest, or spirituality, or hobbies, and go for vacations. And organizational role, hospitals should promote wellness programs and fair scheduling of their work hours and assess the mental health resources. Thank you very much for your patient listening and giving time for me.
Thank you, Kiran Kumar sir, for this amazing speech. I would like to thank the moderators also for helping us with these sessions. Next, I would like to call upon Dr. Kunal Aneja to talk on the workflow on CUVIS. I'd like to invite moderators of this session, Dr. Arun, Dr. Sai Virla, and Dr. Arun Reddy. Dr. Adarsh, if you can join the stage as moderator.
Good afternoon, everyone. Thank you for the invitation, organizers. We'll take you through the workflow of the CUVIS Robo. We have seen a live surgery in the morning. We know there are three parts of the system: main console, robotic arm, and the planner. So this is the surgery process. A CT scan is taken, a patient-based CT model is created, system preparation is done, the pre-planning is done before the patient comes to the OR, registration is done, gap check, and finally the implant insertion. So I'll take you through the J planner. How do we plan the surgery? For planning, the CT scan is done and uploaded. The DICOM images are uploaded after the bone segmentation. We plan the femur, then the tibia, and then we confirm the process. After logging into the system and the CT is being uploaded, the steps are seen on the left side of the screen. There are 4 screens that you see. The bone segmentation is done with the auto method by the computer. There's an option of doing a manual segmentation. This is done in those cases in which there is an implant in situ, like a bipolar prosthesis, in which we can select the bone manually for the segmentation part, both the femur as well as the tibia. Once the segmentation is complete, we start with the marking of the femur. The 4 images seen are the coronal, sagittal, axial, and a 3D reconstructed image. Femoral head is the first marking done for the femoral axis. So the mechanical axis of femur is decided based on 2 parts, that is the femoral head center and the condylar center. Subsequently, the medial epicondyle and the lateral epicondyles are marked. Medial posterior condyle and the lateral posterior condyle are marked again on the femur. And finally, the distal condyles, both the medial and lateral, are marked to mark the complete femur axis. Subsequently, the implant positioning is checked in 3 planes: flexion, extension, varus valgus, rotation, and they can be maneuvered based on the size, position, rotation we want. After deciding the final implant positioning, we move on to the tibial part. For the tibia, we select the medial, the lateral. They are done through the registration. We go on to the registration, which is the verification of the actual patient bone on the CT scan. So we complete the femur registration first: medial, lateral, proximal, that is the supracondylar region, anteromedial, anterolateral, posteromedial, and posterolateral. Once the femur registration and the implant positioning is decided, we move on to the tibia axis. The tibia mechanical axis we know is the center of the tibia, proximal center, which is marked, ankle center, center of the talus, the tibial tuberosity, the PCL condylar fossa for the axis of the rotation of the tibia, medial condylar center, and the lateral condylar center. This completes the tibial axis. And finally, we get a virtual tibial implant positioning. We decide the posterior slope, internal, external rotation, as well as the varus valgus of the tibia based on this. These can be maneuvered and the sizing can be changed based on how the implant is fitting onto the CT-based model. Finally, the tibial registration points are verified so that we can verify the actual model based on the 3D CT. For the tibia registration point, the medial, the lateral, the anterior, tibial tuberosity, proximal medial, and the proximal lateral parts are marked. This completes the tibial registration and we get a plan. This is the summary that we get. This can be further saved and uploaded onto the robo on the day of the surgery. We get such a plan which can be given and shared to the patient as a pre-plan before we execute the procedure. So the overall workflow, we have completed the CT scan, we have done the surgical planning. We move on to the registration part. The part of registration, bony registration we saw in the morning in the live surgery. It involves preparation, installation, registration, resection, and finally completion of the gap checks. So based on the side of the knee, we have different layouts in the OR. The robo comes in from the same side as the surgeon, while the console is on the opposite side. There's a sterile diagnosis of the 3 markers, marker, tool, and the cutter of the robotic arm. We know the femoral and the tibial markers, the arrays are placed, the robotic marker and the registration probe, they have to be registered before the surgery is started. This is a burr-based system with a cutting tool assembly, and there are fixation clamps instead of Steinman pins, which can be used for fixation. The drill guides and the shank screws are used in the femur and tibia to help in the fixation of the arrays. The disposables are the marker balls and the cutting burr, which is 6.2 mm in diameter. There's a disposable drape, which is used for the robotic arm. The bone marker installation, we have seen, it's similar to the Mako. It can be placed inside the incision or outside the incision. Usually we have moved towards a metaphyseal pin on the femur side and extra incisional pin on the tibial side. After placing the pins, the tibia is supported on a tibial leg holder, which helps in maneuvering the knee and fixing it, stabilizing it in flexion. And this completes the bone marker installation. We move on to the bone registration, in which the OTS camera should recognize the bone markers. There are 2 things that should be marked. Femur and tibia both should be recognized during all ranges of motion. The femur registration begins with marking the initial points on the distal femur. We register the shape of the femur based on these points. Medial point, lateral point, there are 40 points on the femur. Medial epicondyle, lateral epicondyle. We move on to the tibial registration points. These are the same points that were registered on the CT planning. Proximal, medial, proximal, lateral, anterior tibial tuberosity, and moving on to the proximal medial tibial plateau and the lateral tibial plateau. Then the bubbles, like they were burst in the Mako pre-planning, they're done same here. The tibia registration is completed, and this marks the confirmation of the registration part. This gives us the positioning of the implant in all 3 planes for both the femur and the tibia. We do a gap check. This gives us the gap balance. Screen like this would be visible, in which we can shift the femur anterior, posterior, rotate it or flex it, depending on the gap balance we want to achieve. The gap check can tell us the valgus or varus of the overall HK axis, as well as the flexion extension being achieved. And we can maneuver the gap check based on the implant positioning. So we have 3 options. Resection can be done a full surface resection, extension surface resection, or guide hole resection. We saw the full surface resection in the live surgery in the morning. The robotic workspace has to be conformed to the, so that it picks up the arrays of all 3 femur, tibia, as well as the probe. And finally, the robot is fixed to the bone with the help of a clamp. We can adjust the angle of the probes so that it is picked up without any difficulty. This is a diagram showing a 6 mm Steinman pin placed intra-articularly in the femoral side and extra-articularly on the tibial side. Finally, the execution is proceeded with. The robot is registered. We can restore it if we have issues with registration during the robotic registration. This is a fixing of the robo with the femur and with the help of a clamp, and the burring being executed. First is the femoral distal femur cut that is done, then the anterior chamfer, anterior, posterior chamfer, posterior, and finally the box cut. We saw the trajectory of the burr during execution. We have a cutting position monitoring to look for the changes in the bone movement during execution of the procedure. Same thing with the tibia. We move with the medial tibial plateau, then the lateral tibial plateau, different trajectory of the burr movement in both the cases. We can control the speed of the burr from 15 to 40. And finally, we get outer margin being preserved, which protects the soft tissue sleeve around the tibia. This can be removed with the help of a nibbler. And we can confirm the surgical result and the final range of motion achieved. This is the final surface after cutting and preparation of the femur and tibia. We can verify the cuts and see the final flexion, extension, varus valgus, and rotation of both the components. This completes the process, and we finally proceed with the implant insertion. Thank you.
Well, great talk. I can ask a question. Because this is a fully automated robot, how important is it that it has to be maintained at complete still? I mean, should be no movement at all at the robo level.
Yeah.
How important is that? And how do you make sure that that remains absolutely still?
Yeah, so there's a, like we saw in all three planes, there is a provision for the robo to stop if it detects any movement. Definitely, there has to be no movement of the bone. So like we were discussing, if the patient is even snoring or he's sneezing or there's an inadvertent movement under spinal anesthesia, it stops. So it's essential, and there is no, it's not fixed with the robo, like in the Mako, it is fixed with the bone and the arm are not matched together. So the bone has to be still for the arm to be safe.
Right. So you can maintain that with the leg holder, I guess.
Yes.
That makes it much more stable.
Yes. Yes.
So just to summarize, because I think you've all seen many great talks and surgeries since morning, there are three basic categorizations of robotics in joint replacement. One is according to what is the cutting tool. One is according to whether it's imaged or imageless. And one is according to the autonomicity of the robot. So if you see the cutting tool, it can either be saw-based or burr-based. Then you have either imageless or CT-based. And then the third categorization is if it's either handheld, semi-automated, or fully automated. So if you just take the 5 major robots that you have, the CUVIS is an image-based, burr-based, fully automated robot. Okay. Then you have, it's the same as the MISSO also, it's almost identical. Yes. Then you have the Mako, which is image-based, saw-based, semi-automated robot. Okay. Then you have the Velys, which is imageless, saw-based, semi-automated robot. And then the CORI, which is a handheld robot, which is again imageless, burr-based, handheld robot. Then you have what Sudhir Reddy sir will be showing is an augmented reality, the PIXEE. So that's a completely different category altogether. Just as a summary in a nutshell, just to know that the differences between the two, I mean, between the 4 or 5 of them. But the common step between all of these is registration. The most important part of any robotic surgery is you feed data into the robo, into the system, and then only you can get an accurate result.
Just to add to that, there is also something called as an open source robos. And so they can all these robots can still be classified into open source and closed source. Closed source is where with the CUVIS, you can only do Meril, you can only implant Meril processes. Whereas with open source, you can implant any processes. If the concerned company has an MOU with the robo, if they give all the anterior posterior dimensions, medial lateral dimensions, what's the cut and all, you can implant any processes. That's called as an open source robos. And coming to the question that you have asked, how can you cheat the robo? So the very important concern everybody is having with the Meril is, this is an automated robo. It might cut the posterior neurovascular structures. That's most of the times there's a question. It's a fear, right? So you can also cheat the robo, especially in this. How? Only while doing your registration itself, you cheat the robo saying that your tibia is anterior. So you restrict the posterior border of the tibia. The robo thinks that my posterior border of the tibia is only till this point. So it comes to that point and stops the burring. So now in front of the tibia that you have, your 75% of the tibia is cut because robo thinks that's the posterior border. Now with the help of the saw, you just finish the cut. So you're not even allowing the robo to go posterior than it has to. So you can also cheat the robo. Yeah.
So fantastic talk, Kunal. I'd like to invite Dr. Ashok Raju sir for his talk on a very important talk. Has robotics influenced our conventional TKR or not? So robotics is here, but has it also influenced our conventional surgeries? It's a very good point and good topic. Welcome, Rashekar sir.
Good afternoon, everybody.
We'll just finish it off faster. There's no time. We are already running late. So the robotic arm assisted TKR is gaining wider acceptance among surgeons and patients also. So this adds to our problems. And also we have to accept the technology into how we can incorporate robotic techniques into conventional TKR. So when it comes to robotic TKR, they are boasting of with accurate implant sizing, better implant positioning, but controversial influence, a small incision, reduced operating time, no post-operative pain, and enhanced visualization. So these are the points on which actually everybody sells a robotic surgery. But the current evidence does not show that it is translating into any advantage in the long-term follow-up. But still, what it makes difference for us as a conventional TKR surgeon. So with robotic TKR, we started changing the positioning of the implant and giving more importance to the alignment. So we started accepting varus valgus alignment in the conventional TKR. So we are giving more importance to the gap balancing and alignment. So when it comes to the HTO, in younger generation, we are preferring robotic UKR. So when it comes to the robotic techniques, there is one technique which can be incorporated into a conventional TKR. So when there is a difficult knee with large osteophytes, medial osteophytes, and severe varus deformity, where sometimes after doing all the cuts, you land up in a lax knee. So in that case, a robotic technique has been published by Suhas and others, where they do a mid-resection technique only. They resect medial side femoral condyle, only 50% of the condyle of the expected condyle to be resected. So how to do that in a conventional TKR? So when we are accepting robotic technique into a conventional TKR, so we have to only technique which we can apply in a conventional TKR is gap balancing technique. Measured resection, we cannot apply this technique. So while you are doing a gap balancing technique in a conventional TKR, you have a large osteophyte. So your medial side is still tight, and you place gap balancer, but it is how do you identify it is medial side is tight? So your alignment will go into the varus, and lateral side is lax. So if it is balanced, you will continue with the cuts. But when it is not balanced, the next step what you will do is you will go for additional medial tibial resection and osteotomy of the proximal tibia, medial reduction osteotomy. Even then, if it is not balanced, then you have to go for posterior medial osteophytes, which is not possible to take out without making any posterior tibial cuts, medial condyle cut. So in that is a publication what they have made using robotic TKR. In robotic TKR, they don't cut complete medial femoral condyle. Suppose if your robot assisted arm is saying that you are cutting medial side 8 mm cut, posterior femoral condyle, but you will not take 8 mm posterior femoral cut. You take only 50% of that. You take 4 mm cut. For that, you move the femoral component posteriorly and then take a cut. After that, you take out the osteophytes from behind posterior tibial femoral osteophytes and then balance it again. So for doing that, in a gap balancing technique in conventional TKR, you have to use the same technique. So once you have balanced your knee in flexion, you put a anteroposterior cutting zig, and then you see if it is tight. So you mark where is your actual cut, and another provisional mark you have to make. In the image, you see that it is black line. So you only take the 50% of the cut of the actually what you are seeing there. All this is eyeballing. You don't take any measurements. So later on, you don't see this video how we will make. So 50% of the final posterior tibial medial condyle is cut. So after making that 50% of the medial femoral condyle cut, you get access to the posterior femoral condyle where you can take out large osteophytes, which cannot be assessed regularly. So same technique is used in robotic TKR, but there they are using robotic. Here we are doing it without robot, using a conventional technique. Okay, thank you.
Yeah, thank you, sir. I request Dr. Ponnanna KM to come onto the dais and share his topic on planning and workflow of Pixie TKR. Dr. Ponnanna is one of the first surgeons in India to perform this surgery at MS Ramaya.
I'll remove it. Nikal do.
Dr. Ponnanna, while they're setting up, you want to just give us a brief about what is this Pixie? Is it robotics or is it augmented or virtual reality? Maybe a couple of points on that till they set up.
Good afternoon, everyone. First of all, I would like to thank the ONUS Hospital for inviting us for this wonderful conference. So, as we all know that TKR has evolved over a period of time now. So we came from conventional, we went into computer navigation, then robotics came in, now something different which is common is augmented reality. So in this particular system, when we use the Pixie one, there are many augmented reality systems, but the one I'm exposed to was the Pixie. I can't control it. I'm not able to see it here. So yeah, so basically in PIXEE we have okay. So I'll just continue. I'll start on with the talk. So as we all know, total knee replacement is widely a performed surgical procedure, and we have AR, augmented reality, we have mixed reality, and we have which is definitely promising in this field now. So latest advantages, as we know, PSI, robotics, augmented reality. And coming to the introduction, what exactly is augmented reality? It was invented way back in 1968 by an American computer scientist. So it is nothing but integration of digital information with users' environment in real time. And what is virtual reality? Virtual reality is something primarily uses an headset to create an image, which gives you a 3D experience. And then the mixed reality, which comes with the AR plus the VR. And coming to this PIXEE, so basically this company is based in France, and they are the ones who got augmented reality into incorporated augmented reality into joint replacement. So it is the first assisted orthopedic surgery solution using AR to support the TKR and surgical navigation solution using a tracking tool. So they have a tracking tool which is scan coded, and it's like a scanner. You just scan it and gives you the alignment and tells you the cuts. You can take the proximal cuts, you can take the distal femoral cuts, And also you can keep the implant in varus, you can keep the implant in valgus, you can keep it in posterior slope, you can keep the femur inflection. So these are the few things which you can do with using this augmented reality. Of course, it doesn't function like a fully robo. It doesn't give you the rotational alignment. It doesn't give you the exact component sizing yet. But in future, there are few more modifications. There are few more improved versions which are coming on, which is going to give you the gap check, depth resection, then tissue tension, and also the rotation of the component, which is very important. So I feel the depth resection is already there. It's going to tell you the exact depth to resect in the proximal medial, proximal lateral tibia, proximal distal, and the proximal medial femoral condyle. So, so navigation software is installed in that smart glass, what we have, and it's a reduced size minimal instrumentation set. And the entire set can be taken into a small box and you can autoclave it. So you can carry it like a suitcase and go around. It's not like the big navigation system as we had the Brain Lab and everything where you can't move it around so easily. This you can just carry it and go. And these are the connected glasses precisely calculate the 3D coordinates of the instruments. So these are the QR codes which is put into the bone, into the cutting jig. And the navigation information is displayed in the surgeon's field of vision, which interacts with application through the glass axillometers. So they're the axillometers which is incorporated into your glasses and they give you the values. And surgical planning, we don't have any pre-op plan. It's all done intraoperatively. So we usually get a scanogram done. You can normally calculate the varus, how much degrees the varus. You can have the proximal medial, proximal tibial MPTA. You can calculate the LDFA. That's for your reference. But we don't have to do a CT scan or we don't have to get a 3D model to get the scan for the pre-planning. And you can always get your weight-bearing AP lateral X-rays. And there are a few steps what we follow. So initially the surgeon might feel a little difficult to get adjusted to the glasses, but these glasses are very thin, sleek, very user-friendly. And 1 or 2 cases, you'll get used to it. So you'll be seeing the entire thing in the glass, which is displayed in front of you. So you can see it in one eye and one eye, you don't have to use the other one. So that becomes a little confusing in the beginning, but as you do more cases, you get used to it. So first thing is to launch the system, to start off with the surgery. So the cutting planes are oriented with respect to the patient's mechanical axis calculated according to the anatomical landmarks acquired with a pointer. So there are a few steps what we follow. First thing is scan the QR code to launch the knee system. And next is there is an instrument check. Then you do a side selection. So either it is you're doing the right knee or the left knee. So it is very important. So the particular thing you just select and you just have to nod your head and it selects automatically. And in the femoral side, we have few points. Insertion of the bone reference, positioning of the pointer in the articulated arm. Then we do the hip center acquisition. Like we get to mark the hip center, which gives us the axis. And we do 10 points of static points to get the proper hip center. Then we calculate the mechanical axis. Then we start the navigation. We validate the values. Then only we start the cut. And we do the distal femoral cut. And once we also do the distal femoral cut, we again validate the cut to make sure that we have taken the cut what we have pre-planned. And coming to the tibial side, we do the same thing. We also insert a bone reference there. We do the pointer to mark the lateral and the medial myelite to get the ankle center. So we have the hip center, we have the ankle center, then we have the mechanical axis check. The next we do the navigation, that is insertion of the guiding tool along the bone reference mast, which is important. And then we perform the proximal tibial cut and we proximal cut, control and validate. So this is how we get the values, like right leg tibia navigation. We have the varus, we have set the posterior slope to 5 degrees, and you can see the blue line, which is in line with the mechanical axis. And we have the femur as well. We have kept in 0 degree varus and we have kept 1 degree flexion. And this is how it is. All the things are incorporated into the surgical field itself, and we don't have to use any extra tracking pins outside the skin, outside the wound. So it's all within the wound. And this is how it looks. This is for the tibia. We have the bone reference, we have the cutting jig, and they have a wonderful universal cutting jig. So the proximal tibia and the distal tibia, it's provided in the set itself. And this is a small video. Actually, the video is quite long. I'm just going to play it. You can see it on YouTube. It is on YouTube as well. So this is the AR glasses. That is the set. That is the this thing what you can see. And Sorry. Yes. Yeah. Is there a way I can forward the video?
Yeah, you can also do there's a bar at the bottom. Move your cursor. Move your cursor.
I'm not able to see this here. Yeah. So this is how we wear the glasses. Then after that, we adjust the glass frame. So this is how we select the site. We just nod the head and once you can see the display, there is a start thing where you just, and you go to the proximal side. Again, you select which side you want to, proximal tibia, distal femur. So this is the guiding tool assembly. So we we first put the guiding tool assembly into the into the proximal jig, and coming to the femoral part. So first thing is install the pointer reference with its center hole in the center of the axis. It should be 90° to the mechanical axis, and it should be along the right sides line. And we fix it with 2 pins. And over on top of this, we put the pins, 2 oblique pins to secure it. And then we put the pointer into the positioner, the leg hole, which is connected to this is all autoclave ones. And this is the pointer when we do the static 10 points to get the center of the hip marked. So once we get this 10 statics point and we get the center of the hip marked. So once that is done, we go to the next step. So that is the mechanical axis, which is being displayed now. And then to this, we insert the guiding tool assembly. And we lock the assembly in position. And we try to adjust the varus and flexion. Usually we keep it in 0° varus and we try to keep some flexion, 1 or 2° flexion. And we can perform the proximal distal femoral cut. Sorry, something happened. So, presentation. Yeah. Presentation is going to be down. Yeah. Sorry for that. Yeah. So we adjust the values what we intend to cut, and after that we perform the cut. We have this stylus where we can adjust the exact amount of cut we're planning to perform. So then we secure the cutting jig with the pins and we validate the cut, and then we remove the knee stylus and remove the pins from the bone reference. And this is the cutting guide, and we do the cut. So we insert the oblique pins next, and we just perform the proximal tibial distal femoral cut. So once the cut is done, we can cut control. We can validate the cut again, whether we have cut the exact value what we have chosen. So this gives that if you have set it in 3-degree varus, 3-degree flexion, and after the cut, it shows the same values. And again, we validate the cut. Then we go to the tibial part, which is pretty much the same. We put the bone reference mark first, and we pin it in the center of the tibial axis, between the medial and the lateral tibial spines. In the center, we put it. And then we mark the ankle, the medial and the lateral malleoli. So that gives us the hips, the ankle center, and it gives us the mechanical axis of the tibia. So along this bone reference mark, we insert the cutting guide, and we again do the same procedure. It's the same steps. So coming to the advantages, what are the advantages of this? So basically, it's got a good accuracy, sub-millimetric precision, and we can quantify the cuts.
Yeah, try to wrap it up in a minute or two. Okay.
Yes. So can quantify the cuts. We can quantify no extra tracker pins are needed, and easy to handle glasses, cost effective compared to a robo. Definitely a good option if you don't have access to a robo. If you want to plan a coronal alignment, you can use this, and easily movable and carried around. And definitely it has got some good post-operative function. This is one of the cases what we have done. So we have a good aligned knee, and this is one of the bilaterals what I had done. And there are also, you can see there are a lot of newer versions coming up. So as I told you, there's an helmet adapter actually, which is very good, which can go into the striker's helmet. So entire glasses is within the helmet, and you have the sterile surgical field. And there are also a lot of research papers which have come up, and this all shows promising results using a augmented reality. And this is one of the patients which says on PIXEE knee plus system, which says that it is accurate and effective to perform TKR using this system. And there's another one says that accurate alignment of total knee arthroplasty with low rate of component malposition in the coronal plane. Thank you.
Great talk, Dr. Punana. So I now will take this to the next level. I'd like to invite Dr. Sudhir Reddy Garu. Sir will give a real-life demonstration of the same PIXEE TKR. Now that we got the concepts and the basics from Dr. Punana, he'll show us how to do it in the operation theatre.
I was told it was 15 minutes, so prepared accordingly. This is probably going to be a lot of repetition of what Dr. Punana said. Okay, because I didn't realize the surgical part was being shown. Okay, again, as Dr. Punana said, it's a technology where the real world is augmented with virtual information by the use of smart glasses. And the first company that has come to market is Pixie Medical, and the system is called Knee Plus. It's a stereotactic system, just like any other robot or anything. So augmented reality glasses you'll be wearing on the head, and there will be tools with markers, which will give you the access of the femur, tibia, both in coronal and sagittal section. So sagittal plane. So you will know the varus valgus angulation. You will know the slopes. So you will know the orientation. You may not know it doesn't give you transverse plane as yet. So you won't know the rotation of the femur. Okay, that you still have to use a conventional instrument. But as I'm told, that's on the way as well. As Dr. Punana said, probably the thickness, the depth also, it doesn't give as of now, but it's apparently already come. Okay, and the claimed angular accuracy is about less than 1 degree. So like any other computer-assisted orthopedic surgery, the aim is to achieve desired alignment accurately, whether it's a 0-0 mechanical axis or whether you want to go for on a functional axis or any other axis, whichever way you want to put it, it will just tell you the correct measurements. Okay. So the evolution, of course, we had conventional, we had navigation, which was good but very complex. Then robotic, there are a lot of adoption problems with robot because of capital expenditure, space, and all those things. And then this is another new one which will probably solve some of the problems. So as you showed, this comes in a small box which you can carry. There is a glasses which you wear, and there is a box. That's it. These are the tools. Okay, and the glasses are worn by like this. Your assistant will put them on. So the vision is the field is to your upper right hand corner. You can change it to left hand if you want, but it doesn't obstruct your surgical field. You can still look at the surgical field straight away, and when you look up here, you will see the field. And the same thing will be, the same field is replicated in the laptop. So your assistants or anybody who is watching can see it on the laptop. So, and this is how it will show you. So we'll go ahead with the video. So exposure is just a routine exposure. Once it is exposed for the femur, I start with the femur. So put the femoral pin first in the center, just like you would put a intramedullary rod, and then stabilize the bone reference with 1 or 2 pins. Sometimes 1 pin may be enough. Just one small, simple pin, and it may be stable. Small oblique pin. It doesn't show the bar. Okay. So your assistant will fix the connector so that you can fix the pointer there. So now between these 2 points, you have to identify the center of rotation. This is, I'm just saying that, the vision, your surgical field vision is not really getting affected. And your steps, you can control with your head by moving left or right. So this is what you see on your laptop. So this is recorded with a mobile phone. So the picture on the laptop may not be very clear, but in general, it's a very clear picture. So as you lift, you can activate the system. So it is asking you to scan the QR code. QR code is on the back of this. So you just look at it and it gets activated. It gets activated and you get the next, it will ask you whether the instruments, these are the instruments you're going to say. It is not coordinated very well, but it will show you whether these are the instruments, because if you have multiple sets, they may have multiple instruments. So you have to say yes, you have to choose right. So I'm tilting my head to right. So it takes you to the next step where it tells you what is the workflow of the system, surgical steps. These are standard steps. I've already set them. You can change them. So you say start and then you choose whichever side you are choosing. Then it is asking you to choose to identify 10 static points to identify the center of the hip. So again, it's quite a simple procedure. So whenever you look at the field, you should be able to see both the QR floats and they should light up. If they don't light up, then you may have to change the orientation or distance, or you may have to move the knee. It will tell you on the top, it will prompt you what you have to do. So you have to see that both the QR flags light up and then you keep moving. As you keep moving, it will keep picking up the rest of the points. Okay, so like that, you just pick up the 10 points. So it just went forward, recorded forward. But once it picks up the 10 points, it identifies the center of the hip and it draws the axis. You can see that axis on the blue line, okay, depending on from where you see. So this is just a cutting block with orientation mechanism mounted on it. So you mount this on the bone reference. So once you mount this, you should be able to see both the flags clearly and both should light up. So can you switch it off? Can you mute that, please?
Switch off the system audio.
Yeah. So once both the flags light up, it will tell you what is the orientation. So you turn the knobs. You just turn the knobs on the orientation mechanism. It will take you wherever you want. You want to keep 0 degree varus. You want to keep 3 degree flexion. So here I'm putting 0 degrees of varus, 0 degrees of flexion, and you accept that. So you tilt your head to right. So again, it gone back to 1. So get it back to 0, and you accept. You have to choose the right menu. So tilt your head to right. So it will validate. So you told it what you want, and then you use the depth stylus to measure whatever depth, whichever implant you're using. The best part of this system is you're not a prisoner to any one implant. You can use any implant, okay? Whatever implant. So whatever implant you're using, use the depth. and then fix that cutting block to the femur. So remove everything. So cut the distal femur. And you want to check whether you cut it correctly or not. So I deliberately put this because many times you get it correct perfectly all right, but many times you may have levered your arm, so it may not come very well. So when you put your control QR code flag, it will tell you what is the actual angulation that has got. It says 1 degree valgus and 2 degree flexion. You can correct it again. So I wanted to correct it. So you can go back and try and adjust the cut a little bit. So next time I measure it again, it says 0, 0, 0. Oh, right. How do I move forward? It doesn't show the bar here.
Slide or in the video?
Okay. So that's it's different here. It started here. So it just gone back to the beginning here.
You want to go to the next slide or somewhere forward in the video?
No, in the video itself.
I'll just show it. Let's make it easier for you. Slideshow. Now you can just move forward here.
Right. So as I said, we recut it again, and we got 0 and 1 degree flexion. So we're going to tibia now. Tibia again, one simple pin at the center where you would put an intramedullary rod. Okay, and then stabilize the bone reference with another oblique pin. Okay, and then it will ask you, So it will ask you, it will tell here at the bottom what it is asking, lateral malleolus. So you take the pointer and choose the lateral malleolus. Identify the lateral malleolus. So then it will ask you for the medial malleolus. So it will calculate the mechanical axis, and you will be able to see the mechanical axis on your field as well. And again, now mount the cutting block. Again, you can adjust. It shows 1 degree varus, 7 degree posterior slope. Adjust it, and go ahead with the cutting. So remove everything. Make the tibial cut, and then I measured it. It is 0 degree varus and 6 degree posterior plate. You accept it. So that is done. So it will give you the distal femoral cut and proximal tibial cut as of now, the varus valgus angulation and posterior slope. It doesn't give you rotation, but then rotational, I'm okay with conventional instruments. Okay, going back to. So I think we're first people to do in Telugu states. We started in about a year ago. We started about 350 to 400 cases so far. And every case we take scanogram. And first 50 cases, we actually wanted to test whether actually we're getting what we plan to get. And once we gained confidence, we were able to tell patients that yes, it gives a little bit more accuracy, but I'm not sure about the long-term result. It does take another 7 to 10 minutes or more. Initially, it used to take about 20 minutes, but it's very, very quick to learn. There's not too much. And we looked at blood loss and pain score also. There's no difference, So these are some of our cases. Okay. So advantages, this is a fairly simple system, very simple system, fairly accurate. There's no footprint. It doesn't occupy a lot of space. You don't require any additional staff. It's a portable device. You can just put it in a bag and carry anywhere you want. And it allows you any implant. Whatever implant you want to use, you can use it. So surgeon decides, not the machine. And it's quite less expensive compared to robotics. And there are no percutaneous pins. So you may be able to reduce the complications that are associated with percutaneous pins. And it's completely under surgeon control. You can change it at any step. You can, if you want to go back, you can go back and change it. There's low risk of abandonment. Sometimes I hear in robot, many times people have to leave in between, but in here, we never had to abandon any case. And there's no preoperative CT or MRI. You can just decide just before the surgery and go ahead with the surgery. I also want to say what it doesn't do, it does not going to change much. Okay, so we've used a lot of them. We know the results lot. It doesn't make it 100% success. It only increases a little bit orientation better. It does add another 5. It doesn't make it surgery any faster. And it doesn't reduce incision size. It doesn't reduce infection, pain, or blood loss. Okay, and patients don't recover faster. Okay, I'll tell you why. These are the results. And we've seen all. So why do we use it? So we've seen navigation. We've seen how navigation was sold. 17-year results on Australian Arthroplasty registry. No difference with conventional. This is again after 2015. Navigation systems changed, so better navigation systems. So they looked at it again. Again, no difference in outcomes. IDI again, no difference. Robotics, 8-year results, no difference when adjusted for every in Australian Arthroplasty registry. So innovation and technology, of course, should always be welcomed, encouraged, and attempted as long as it doesn't do any harm to the patient. Okay, and it should be thoroughly validated, and you should look at, unbiased literature. Don't get carried away thinking that it is going to revolutionize, and you have to buy a robot to be able to survive. Not necessary. Okay, you should read arthroplasty registers, which will give you what is actually happening in the true world on the ground, the true results rather than claimed results. And of course, put patient's interest first, not the technology's interest. Thank you.
So I'll just go ahead. So I'll give you one ideal case scenario where I have personally used the PIXEE system after observing in Landmark Hospital. So I recently presented the same case in TCOS meet also. So there is an elderly female with a KNL in situ for the past 20 years. And now the patient wants to get a TKR done. The patient cannot afford Adarsh because it's costly because of the robo system and all. So then I requested the Meril people. So they have directly brought the PIXEE system. It's a portable. It was brought from Bombay. I use this system because I don't want to remove the KNL because there's no point in removing the KNL. I cannot use an intramedullary rod in the conventional this thing. So I've used the PIXEE system to have a nice perpendicular distal femur cuts and proximal tibia cuts. And then I went on doing a successful TKR. Wonderful. So that's one ideal scenario where you can use a PIXEE. So coming to the next point, like how Dr. Sudhir sir has told, that as of now, there are no significant differences in all the registry data if you compare the registry data. But now, we have now entered into an era of artificial intelligence, right? So even if you see there's artificial intelligence already embedded into our robotic systems. For example, I'll tell you how. So in the CUVIS, you have taken the pre-op CT scans, you have told the system where is the lateral epicondyle, where is the medial epicondyle. And again, in the intraoperatively, you're giving its lateral epicondyle data and medial epicondyle data using the intraoperative QR codes and all those things. But we all know, the robo also knows that the pre-op CT scan lateral epicondyle is not equivalent to intraoperative lateral epicondyle. There is a significant difference between that. But how does a robo know? Because there's so much of data fed into it, it knows what exactly, even though it's here and there, it knows. Similarly, now in the present 2024 scenario, we are entering a lot of data into the system. Like what? With this alignment, what is the functional outcome? With this alignment, what is the functional outcome? It's 3rd month, 6th month, 9th month, and 12th month. So maybe after a decade, who knows? If you just give the pre-op CT scan, the artificial intelligence might tell you the alignment that it wants to put into the patient and what would be his functional outcome, right? So we should also not give a blind deaf ear to the technology that is advancing. I think artificial intelligence maybe in the next decade might revolutionize. So a great demonstration.
I think we're entering the realm of science fiction or like Minority Report kind of stuff. Only one disadvantage I would see is if you're checking out the nurse, people can see what you're looking with your glasses. Exactly. So I would like to invite Dr. Supreet to speak on direct anterior approach to the hip with the Mako robot.
Thank you for your patience. I think I'm the guy who's starting and getting the ball rolling for the hips. Thank you, Adarsh. Thank you, Arun. And thank you, ONUS Hospital, for this opportunity. I'm going to be quick. My first question would be exposure to DAA. How many people have seen a direct anterior approach? So that's quite a few. But I have two videos. One's for the direct anterior approach, and one is Mako using Mako direct anterior approach. At the end of the presentation, I'll have a QR code, which should hopefully help everyone. You can have a look at it and have a DA video on your phone to have access on at all times. So my disclosures, I have my own practice. I'm a consultant to these three companies, but I was trained as a posterior hip replacement surgeon. So I've learned anterior approaches during my fellowship while I was in Australia. These three were my bosses. Sol taught me everything about superpath hip replacement. David taught me everything about anterior approaches, and Yasser taught me all that I know about Mako and Rosa that I was using. This is not a new surgical technique. It's been around since 1883, then carried forward by the Judet brothers in, during the Second World War and later on for the French soldiers. And then it went on to Mata. Mata started using this, using the table. Then I met somebody called Stefan Krautzer, and this is a table that I use in my practice. It's not necessary. I just have access to it, so I use it for all my cases. Benefits of anterior approach, less muscle damage. All are level 1 studies, by the way. All the proms are better in the short run, nothing in the long run. There is no difference in posterior, anterior, anterolateral in the long run, but in the short run, definitely. Dislocation rates. I've done about 250 hips. I've just had one dislocation. So I'm pretty happy with the direct anteriors that I'm doing. And it's a little lower dislocation rate compared to the traditional rates that we've had. This is the video. I am not going to play it because of the paucity of time. I have 10 minutes on the clock right now, but it's at 8 minutes, I believe. So I'm going to
I think you've bribed them not to move the clock.
That's good. It works for me. But I'm not going to play this video. This video is available at the end of my presentation. There's a QR code, so you can take a picture of it and you'll be able to have access to that video. So I'm going to skip this video, but this video is about anterior approaches and how you can do the anterior approach. So we're going to skip this. Benefits of Mako. Mako gives you real-time data, and that's the beauty of Mako. It doesn't matter what approach, what surgery. I think the beauty of Mako drives through in the hip and in unis. I love it for both of these surgeries. I do all my unis using a Mako, and I do some of my hips using the Mako as well. It's customizable. It's patient-friendly. I don't need to increase the size of my incisions, and that's what I really enjoy. Planning for Mako is the same that we've discussed. So you have a preoperative CT according to the Mako protocol. You do your acetabular shell planning. You have your inclination inversion that you look at. You have different views to plan it and the depths to plan it. And then you have the stem planning. This is fairly standard and routine, so nothing to go into the depths of it. And once you've done that, you basically get details on how different the limb lengths are and the offset is. So once we are aware of these, the surgery becomes quite routine. This is my theater setup. Like I said, I use this table. So I use the anterior table that I have. It's from IoT. I'm on the right side of your screen. On the left side, I generally have an assistant standing, and the Mako is on the right side. The only disadvantage of using the Mako for anterior approach is it's got a very big footprint. So for it to come and go, it requires a large theater. I think that's probably the only thing that really bothers me when I do a Mako hip anteriorly. So this is the Mako total hip. I hope it comes out well out here. Yeah, it looks all right. So that's supine position. That's the X-ray of the patient. The patient had about 17 mm of shortening. So we had to cover that up using the Mako hip. My incision is a straight incision. It's about 6 to 8 centimeters long in all my cases. Go through the skin about 2 to 3 centimeters lateral to the ASIS. And I cut the fascia and reach the fascia over the TFL muscle. So basically score the fascia with the cautery and then use scissors to get inside, open up the fascia, handle the TFL muscle, apply Ali's clamp, 2 clamps, and pull the TFL muscle laterally. Once you've pulled the muscle laterally, you put a Hohmann retractor on the top of the femoral neck. And once you've done that, take out some time, and you can see in the picture in screen that I'm putting my pelvic checkpoints. So there are 3 points that you put on the opposite pelvic. Sometimes I put it on the same pelvis. Then I put in checkpoints on the femur. This is on the greater trochanter. I have access to it, so I put it on the greater trochanter. And one that is put on the distal femur as a stationary ECG lead. Once you've done that, you register, you go onto the Mako, and the Mako gives you guidance on how you can take your neck cut. I take the express workflow, so I don't do the enhanced version of it. I go onto the same line, make a neck cut, do an osteotomy, and once you've done that, it's just a matter of taking the head out. In this particular case, the head was quite a big chunk, so this is what I do generally. I put a corkscrew into the head, get inside, and pull it out, but it wasn't coming up, it's too big, so I used patella holding clamps and just yanked the whole head out. Once you've done with that, with a little bit of struggle, release the soft tissue. It's time to start planning for your acetabulum. And this is the beauty of the Mako. Every time you get perfect acetabular component positioning, and it's just a single ream system. So it's just one shot and you're through. This is my modification of Chanley's retractor that I use for my anterior approach. Just put it inside under the muscle and under the capsule. Once you've done that, it's about bone registration again, same concept as your knees. You have to mark on, you have to have checkpoints on your pelvis, and then you get onto the acetabular surface where you look at the intra-articular markers. So the intra-articular markers, which will start showing up now, are going to be 15 points on the anterior and posterior horn of the acetabulum. So you basically mark these points. Once you've done marking these points, then it's extra-articular markers. You do extra-articular mark pinning, which takes about 1 or 2 minutes. This is my struggle during the anteriors. Extra-articularly on the anterior wall, it is quite difficult to access those. So I have to push the skin across, and I generally have to repeat this 1 or 2 times even today. So once you've done that, the robot will tell you, like in this case, it's told me that I'm off in the posterior horn by a little bit. So I have to re-verify my markers. So I have to mark one on the pelvis and then redo the points. And once I've done those points again, it'll give me a green to start reaming. Reaming's already been pre-planned at about 40 degrees of inclination and about 20 degrees of antiversion. You introduce the robotic arm into your wound. Sometimes it's a bit of a struggle because it's a single ream system. This was quite a big cup, so it took a little bit of struggle, but just went in. And once that's in, the robot itself starts aligning according to the landmarks you've set and according to the parameters you've set. So once the robot starts aligning, you'll see a picture-in-picture screen now where you have to look at the screen and you basically are just reaming off the green color. So you ream until the green color is off. Red color signifies that you're about 1 to 2 millimeters deeper, and white is you're less than 1 millimeter deeper. Once you've done that, you get your bone, you get all the parameters you want, and you start smashing your cup in. So I introduce the cup in manually, then attach it to the robotic arm. Once you've made that attachment, you're in the right space. It's time to smash the cup in, which is the fun bit. So a couple of smashes in, the robotic arm, the Mako tells you how deep or proud you are, and you have to keep hammering it in. Generally takes about 5 to 7 taps and you're in the ballpark. Once you've done that, get rid of the impactor, have a look at your cup positioning and verify it. So you have rings in your cup. You go onto one ring, either the innermost, middle, or the outer one, and select 5 points on the cup, and it'll show you the inclination and the version of your implant. In this particular case, I hit 42 and 20, and I could live with that all day. So we did that, clean the cup, put a flat liner. That's half your hip replacement done there. Once that is done, I generally protect it with a gauze, and I start preparing for my femur. So now that's the most important part in the anterior approach. You have two things to do when you make your femoral preparation. You have your medial release and your posterior capsular release. Because this is quite a quick video, the details of those releases are not clearly mentioned, but I feel like anterior approaches are done better when you do these approaches, when you do these releases well. So the idea is to have your femoral releases done perfectly. So it's a part of the other video that you have a QR code linked to. I put a medial spike around the lesser trochanter and a superior spike. And this was the part of the superior release that I did. And then I reposition my spike on top of my greater trochanter. Once that is done, you'll see in the picture-in-picture screen, the leg is going to start going down now. It'll go down and adduct. And that will leave you exposure of the femur, which is pretty good. And you start smashing your femoral component in. So basically, just size up from 0. In this particular case, I think it was 4 or 5. And I just keep doing it one after the other. The anti-version is something that you can decide along with the Mako, but I don't take that route when I'm doing anteriors. I think it's just a time-consuming process. I do the express route, and I put in, as long as I'm in to the size that was predetermined, I think I would have gotten plus or minus 5 degrees on my anti-version, so I can live with that variation. So once you've decided and reamed up to the size that you want, you look at the stability of your stem, do a trial reduction, and then you put your final components in. Oh, already. Did you pay him, Adarsh?
It's okay. I think you can go ahead and.
Thanks, buddy.
This, yeah.
So you put the final stem in, and once you put the final stem in, it's all about putting in the final head. It was a 36 size ceramic head. I smashed the stem in, and then I put the head, and it's time for reduction. Reduction is just the opposite maneuver. So you abduct the leg to neutral, extend it out to 0 degrees, give traction and reduce it. So just rotate it inside. It's a pretty simple maneuver. You will see it now. So that's the head going in. Once that's in, the leg will start coming up. And I just have a head pusher, keep it on the head, give it a little bit of traction, and boom, the head's in. I was a bit short on this case. I use a 127-degree stem. This is the immediate post-op of the patient. It's about 6 hours after surgery at night. I think I can live with that. It's pretty reasonable in terms of the outcome. Patients generally get discharged the next day of surgery in my practice. Use a Mako, the biggest advantage is cup positioning. So it's inclination version. It also gives you a fair idea on your stem positioning, but also the lengthening that you can do or the shortening that you have to do. The other advantage being this new concept that's introduced, that's the virtual range of motion. So it'll tell you what the impingement, at what angles your impingement will be. So that's pretty good information, because when you use this information by just taking 2 standing and sitting X-rays in lateral position, you will be pretty good with your cup versions, in standing and sitting position. And then that's what we want. Happy to answer all your questions, but I think Mako enhances the DA, doesn't make it very difficult. So I think that's something that can be incorporated to your practice as well. So this is basically the QR code. So if you're interested in taking the picture, I request the panel to keep this photo on for the next 30 seconds so that the delegates can take the picture. Thank you again, guys. I'm happy to take any questions on.
So excellent presentation, Dr. Supreet. So even if you want to do the direct anterior approach without a robo, so I've been trained in Italy by Dr. Peter and Ali. I don't use any special tables like the one Dr. Supreet uses. It's on a simple regular table. You can still perform DAS. They are actually, if you assist few surgeries and observe few surgeries, actually a kind of easy surgery to replicate. The best thing with DA is your acetabular cup position will be perfect. I think Dr. Supreet also agrees with me, because in the anterior approach, you can see the acetabulum exactly right in front of you, the entire 360 degrees. So there is no point of you going wrong in acetabular cup position. That is one thing. The second thing is, in a posterior approach, you always want to err to put your cup a little antiverted. Whereas with the Supreet, with the anti-version, generally when we are doing the posterior approach, we might want to err on anti-version, little bit more anteverted. But in the case of direct anterior approach, it's not that. You either want to keep it pure anatomical, or maybe you want to err a little bit retroverted than keeping it anterior. That's the one thing that you have to. Do you agree on that?
There's always cheats. Anterior approach give you a privilege of using X-ray in all your cases. So once you've got that access, I think you can position your cup any way you want. So that's one of the cheats that we have. Plus we've got lip liners, so it's pretty safe. As long as you're in the ballpark, I think it's pretty good too.
Yeah, and the other difficulty, especially if somebody wants to try DAA, the difficulty will always be not with the acetabulum. It will only be with the femur implant positioning, because you need to release medially and posteriorly, especially if the external rotators also can be approached in this. If you just external rotate it, you can also release the posterior short external rotators in this approach. You have to external rotate it so well that the neck is directly anterior. It has to face the roof. Only then you can broach the femur. Otherwise, there are many chances that you can actually do intraoperative femur fractures. They are more common in DAA if you are not well versed with the DAA. Okay. Anything else that you want to add, Dr. Supreet?
In old cases of fracture neck of femur where there is superior migration of the GT, how will you release it?
It's the same. And I've done shortening correction of up to 2 inches. It's the same. It's just more extensive. And you can always release a little bit of TFL from your ASIS. It will give you more length. So you always have those cheats available, but those are not your first cases. What you want to start off with is valgus necks. Valgus necks don't exist in India that frequently. We always have varus necks, and we've got wider pelvises, the ones that look like Mickey Mouse. Those are not good cases, even if they're older. You may think that you'll be able to get away with those cases initially if it's a female. They're not easy, and that will make your experience very unpleasant. So look for valgus hips with AVN, generally low muscle mass, lean people, and then move on to maybe say a varus neck. Neck of femurs, people would assume is easy, but practice is if you've got a physiologically active patient, go for a dual mobility. Dual mobilities are not easy to reduce if they are tensioned correctly anteriorly, and bipolars are not easy at all because the size of the head is 40 to 450 mm, which is very difficult, So those are not the cases that you start off with. So AVNs, valgus, less muscle mass are the ones to start off with, and then you can progress on. We are currently doing a few revisions also anteriorly, and cup revisions are very easy. Stem revisions are not easy. So I feel like the jury is out there in revisions, but primary, I think you can do all cases.
That's an interesting point made by Dr. Supreet. Many surgeons think that let's start DAA with fracture neck of femur. No. Always your first DAs should be with total hip replacements. Only if you're well versed with total hip replacements, you can go towards neck of femur. Always doing a neck of femur DAA is tough. Those should not be your first cases.
It was a motor vehicle accident, but it is still a dislocation in my practice. So all my complications are, no, all your complications count. Oh yeah, I do everything anteriorly. I'm a 100% anterior surgeon. I don't do anything posterior anymore. It's all 100%. So I've had wound complications. So what happens is because of the varus necks, you have the groin crease. And if you saw my incision's vertical. I don't do the bikini incision unless somebody demands it. So I do a straight incision. And when you've got a varus neck, the proximal part of your incision does tend to cross the groin crease. If you cross it at that angle itself, it won't heal. So you have to cheat there as well. But you'll have to pay me to get all those tips, so you're not going to get all of those tips. But you basically change the direction of your incision superiorly. So this is what I've learned by doing a lot of varus hips. In Australia, we didn't have a lot of varus hip. We had a lot of valgus hips, as you know. So it was very easy to do those. And I was talking with my friends a couple of days back as well. So now my time after doing these 250 hips is come down to a reasonable amount of time. I'm doing them in 40, 45 minutes now. When I started, my first case was about 3.5 hours. And it is a struggle. So you have to be supervised. You have to take it slow. You need the right instruments. You can't do it without the right instruments. I mean, you can, but you want to look good. You want to be slick. So I think there's a learning curve to it. And Meril's supporting people a lot. We've trained, a lot of surgeons on anterior hips as well. So if the opportunity arises, happy to train you guys as well.
Yeah.
So So even if you saw out here, this was about a 2 centimeter lengthening that we had to do. It was about 18 mm, so 1.5 centimeters. So when I have to do that release as well, so first release is pubofemoral release, that's the medial release. Second release is the superior release, which is superior capsule, which is released completely. Then I tend to nick on the external rotators. So I release in those cases only external oblique muscle. So once you've done that, then the fourth release is your TFL release at your ASIS. Once you've done those 4 releases, still a challenge, but you can still get the lengthening. So again, it is possible, but not your first cases. No, I haven't done anything to the Gmax ever. Never. Posteriorly, it's behind. So you don't see it actually. It's way back. So I don't get to see the Gmax.
Oh.
So I have put in one cable in one of my cases that was a fracture. So that was a fracture neck of femur. And I was doing an uncemented stem into it. And I put in a stem, which I think was a little too big. And I fractured the calca. It is very easy to do, to be very honest. So you internal rotate the leg. So the patient's lying supine, internal rotate the leg, pull the vastus away. You get access to the LT, the area above it and the area below it. Pass a cable passer, pass the cable, move to the rotation to be neutral, put the cable in. It's a 5-minute job. It's very easy to do. It's not difficult at all. You don't have to dissect anything for it. Cables are easy to do.
Oh, yeah, that's an interesting question. So what will you do if you want to do a DHS? The patient is in supine, right? You can go laterally, right? The same thing here also. For example, something has happened intraoperatively and you want to approach the proximal third of the femur. You can still take a lateral incision, or you can also do the same incision or elongate the incision or a separate incision, do lateral approach. That's we all do the DHS. You can approach the proximal.
If you remember the incision and if you've taken a scan of the QR code, just go through the video and you'll see that the incision is oblique. In case of any issues, you can just extend it down. It'll be the extension of your posterior approach. So it's just the same straight line. Then elevate the vastus, do whatever you want to the femur. And at the top, you just have to curve around, the pelvis. So it's very much accessible, but it's never happened, fortunately. But if it does, I think there are ways out. So it's.
Excuse me. Just want to add few points in view of my experience with this DIA. Thing is, it is always a challenge to do these cases in a basic setup where you don't have the proper instrumentation, as you were telling. And I want to make a note of the instrument that Dr. Supreet was using. It was the offset broaches that he was using to deal with these things, because sometimes we're all stuck where we have a lot of belly fat there. So, and there are certain modification of these approaches also. I do take the distal extent of the incision a little lateral towards the trochanter sometimes. And probably if there is no table like that, I would probably take adjustment of the table hinge to come near my hip so that I can flex and extend at the hinge of the table. That is one thing. And one more thing is I do use a hook to lift the femur up towards the roof if there is a difficulty in getting my femur up and because of the soft tissues.
You're basically doing a cheap replication of the HANA table, right?
Kind of.
So HANA does the same thing. Yeah. It's just, it'll be in your hands. You can do it the way you want to. Table's not essential. It just makes our lives easy. I was trained on a table, so I do 95% of my cases are on table. I have my own table. So it's easy. But when you travel, you do it off table as well. You don't need anything special, I think, but except the offset broach handles, which are essential, especially in Indians, because we tend to have belly fat. It becomes a little bit of a challenge.
So Dr. Supreet will take any other questions later. Now we request Dr. Ashok Raju sir to give his talk on Relive Robotic TKR.
Yeah, good evening, everybody. First of all, I would like to thank Balraj and the organizing committee for giving me this chance. Okay. Yeah, it's coming up. Somebody asked if there will be a dislocation or not. I think the principles of doing a total hip remain the same, whether you do anteriorly, posteriorly, or laterally. So don't go by the concept that if you do DA, there will be no dislocation. It's a misconception. I had a posterior dislocation. I had an anterior dislocation with the DA. Okay, it's a learning curve. Yeah. So because we are trained in one way, we tend to try to replicate the same way in DA, then you are in trouble. So you should know the basic principles, what to use in DA and how to use the same principles in posterior approach. The principles remain the same. So that you should be, that is the message you should take. I don't know why this is not playing. Play, yeah, I'm playing. Should I do this again? Give me a moment. Settings most probably. Yeah.
It's already connected. Just
And the most important thing is that don't go by robo alone. Now you don't have a robo which is as intelligent as you. You're more knowledgeable than a robo. So use your knowledge with and the robo to increase your accuracy. That is what, yeah. No, I need to show them the X-rays. Yeah, I think now with the robo, these X-rays are a must. I started taking X-rays in supine. I take X-rays in standing as well as lateral views. If you see this, yeah, on standing and sitting, these are the sacral slopes which I can feed into the robo. Yeah, I go through the posterior approach. Those are the markings that is the trochanter. So if I go through the skin incision over there, a little half on the trochanter side, half on the acetabular or a pelvic side, that is your incision, and you go through that. You then put a Chanley's as your regular posterior approach, and then you identify the bursa over it. Then you cut through the bursa, and then identify the gluteus medius. Go underneath the gluteus medius to identify the piriformis and the short external rotators. That part of it is the tendon of the glute max. You cut off the short external rotators from the trochanter. As a whole, as a single sleeve, I generally do that. That is the nick over the piriformis area. And then we dislocate the hip. And once we dislocate, that helps in releasing the capsule better and makes your hip little less tighter. So then we relocate it. And that is when we put our pelvic arrays. This is very important in a lateral view. It's easy to put these arrays when you are in supine, but in a lateral view, if you're not oriented, they might be out of the iliac wing. Be a little careful about it. Put these arrays, take some time and put them and see the stability of the pins. Once you have put the arrays, that is the monitor over there, the camera over there, which will capture the pelvic discs or the arrays. Then you put the checkpoint on the femur, that is the checkpoint. And then this is the femoral cortical screw. This femoral cortical, there are two workflows. One is enhanced, one is express. So I'm doing an enhanced flow where I can see the femur broaching also in this case. We cross-check it, then we measure the limb length. Then this is the array, femoral array, which we put and reconfirm or register our checkpoints over here. Once we have done the checkpoints, now I do the femur first. So I identify the points on the femur, that is over the saddle of the neck. Then we have 1 point over the lesser trochanter. And the third point is on the tip of the trochanter. These registrations will change on what approach you use. The points change. Then you start registering your femur. There are around 6 points at every part of the femur. That is how you try to register. So generally we count as 1, 2, or either you say capture, capture, capture. That is how it goes. And then you start doing a little forward it because it's a little long. It's going to take a little longer time. That is how you're going to register the femur. And that is the final point of registering the femur. Now you cross-check your points by bursting these bubbles. If they are green, that means all these small points are green and yellow. That means my registration is good. And then you break these bubbles as you do. And then you confirm it by breaking this small blue colored bubbles. Then because of the enhanced flow, you can identify where you want to make the neck cut. So that is how I'm marking my neck cut with a cautery and the probe over there, what I'm using over there. Once I have marked there, then I do my neck cut. This is like a regular cut, what you do through a posterior approach. Once it is done, then I would see, if you look at it, through the CT scans, I come to know that my stem version would be around 16 degrees. Kindly look at this value. This is prior to broaching. So how do I confirm it is 16? So I do my broaching. So this is the box cut, what you use. Then you find the canal and then you start broaching in the desire what you want. Most of the time it is parallel to the posterior part of your femoral neck. Once you broach and you think you have got, you determine the size preoperatively, but it can change one stem up and down. So we thought 4 over there, but finally I ended up putting a 5 broach over there. Now this is the neck, what I put on it. And then I can have, they have divots on it. I would again check them with the probe. And if you look at it, yes, there are 3 divots over there. And then once I check on that, I get the value of how much I have broached. So now my broach version, if you look at this, is around 20 degrees. Yes, the CT scan was showing 16, but end of my broach, it has come to 20 degrees. That is how it is going to help you out. So I've taken the standing and sitting X-rays, and you can either do a pelvic tilt measurement or a sacral slope. It's easy to measure the sacral slope. So it is 15 on sitting and sacral slope on standing is 47. So it's a kind of a flexible pelvis and spine. So I'm sure I will not have any trouble. But the advantage is, if you look at this, this is a virtual range of movement, what you can do through. So I'm going through 120 degrees of flexion and 20 degrees of internal rotation. So I don't see a red mark over there. You should see, if you see a red mark over here, that means there is impingement there. So in this case, I don't have an impingement. The same way, I can also do an extension of 20 degrees and 20 degrees of external rotation. And again, I do not have an impingement in this place. So I'm happy with keeping my cup at 20 and 20 degrees of version. And I know that my broach is around 20 degrees and femoral version is around 20 degrees. With that, I have no impingement anywhere. So I can go ahead with the acetabulum. So the whole reason of doing the femur first is to know the version of the femur so that you can, if possible, correct on the acetabular side. This is the acetabular exposure. You remove the labrum and the pulvinar, and then you put the pelvic checkpoint. That is the pelvic checkpoint which you put over the anterior part of the, or the iliac wing of just above the acetabulum. That is how we cross-check it on the acetabular side. Now you register your pelvic arrays again to identify where your acetabulum would be on the robo. Give me another 5-10 minutes here. Then you do intra-articular checkpoints. That is the blue color. You have 15 checkpoints. You go in a zigzag fashion so that you cover most of the acetabulum inside. And then you have the markers, posterior horn and the anti-horn. And then you have 15 points on the extra-articular part of the acetabulum. So you put your probe from here. If you can see my probe over here, I'm trying to register the extra-articular part of the acetabulum. Once I have done that, yeah, these are the 15 points. Now I cross-check again, and you can see that I have a lot of green and yellow line, yellow dots, which suggests that my registration is good. I'm at the correct point, and I again burst these blue bubbles to reconfirm my accuracy with this. Now you get your robo, and then put your reamer inside. Once you put your reamer inside, you have already determined your size. If you have not, yeah, you can go serially also, but a single ream is good with a Mako. So you do a single ream. If you can look, I've kept the major advantage is while reaming, you don't have to keep it at 40-20. You can rotate to a certain extent, but it will ream what the green color shows. It will not go beyond that point. Now, if you see all those values, I'm 4 millimeters still not reamed the superior part. I have not reamed 4 millimeters medially and 2 millimeters posteriorly still remaining. And then that's how the green color fades away as I do it. And I'm 0, 0, and I'm out. That is a single ream. That's the beauty of doing a reaming with this. Once I've done, this is the single ream, what you can see, the acetabular exposure. And then I get my cup inside, and then my people help me with this. Now it is important to get your cup in a good alignment, and then you lock the robo in that. And then you start hitting it. If you look at it very carefully, I'm 8 millimeters proud. Here it is. That means I'm still not bottomed in. Now I'm 4 millimeters inside. Means I've gone 4 millimeters, but 4 millimeters short. This is how you're going to know whether your cup is bottomed in or not. So it's 3 millimeters proud. That is how you're going to hammer. This also gives you, and finally, if you look at it, I'm 1 millimeter proud. Yes, I've actually kept it at 40, and my version is 23. I changed to 22 prior because I wanted my cup to be a little parallel to the tal. So I've adjusted my values while doing this, which I have not shown. Now, if you look at it, my cup is almost parallel to tal in this case. Now I'm inside tal and parallel to the tal. Now I keep my poly inside and bang it and lock the poly inside the cup. I get back and do a trial. This is so I wanted you to show you this. If you look at these values over here, this is the stem 5, 127 stem, angle stem, and 0 head. If I use it, I am 11 millimeters longer and than the opposite, and 16 millimeters in the combined offset. So I chose to use a -5 head. So my opposite side, it is 7 millimeters longer, and the combined offset has come down to 11. This is how it is going to help you in determining what head I should use. So finally, we took a minus head, and then we put it on the neck. We clean up the neck, see that there is nothing on the neck or the trunnion, and then we bang the head into it. And we lock it in. Yeah, and then we try to reduce Once we reduce the hip, then we check the stability of the hip, both in flexion, extension, and then it is done. Finally, we close the capsule and then we close the short external rotators. This is the Ranawat technique, what I use to close the, and finally we close the ITB and the skin. And I don't know why this is for a longer time. And this is the post-op X-ray of the same patient. If you look at, sorry, 1 minute. And if you look at it, I think we have, yes, there, if I draw lines, yes, it is a little longer than the opposite side. And definitely there's a collapse, so it will be definitely a little shorter. But I've got my angles correct. I've got, even if you look at the offsets, I think it is looking good. That is how Mako helps, or the robo helps. Thank you.
Excellent presentation, sir, as usual. The next, I request Dr. Karthik Repakla, sir, to present his topic on management of infection in revision TKR.
Good afternoon, everyone. Thank you to Balaraaju for this opportunity. So, infection, I will be talking about in the knee replacement. So, this is the most dreaded complication. Sometimes the mortality and morbidity is more than the malignancy. So, this is one of the most complication feared by the replacement surgeon more than the patient. And the life expectancy is increasing, which is increasing the prosthetic survival, which is leading to the increased chances of the hematogenous infections also. So and the number of joints being replaced is on the rise, which leads to the cumulative increase in the number of the infections. So this is the pathogenesis. We are all already well versed with this. And I will be skipping the basic things which are out of scope for this thing. So we'll discuss 1-2 points about this microbial film. So it takes 4 weeks for the microbial film to be formed after the primary knee replacement. So, and presence of the foreign body is one of the major factor which reduces the host defenses by 10,000-fold the minimal dose for the microbe organisms to infect the host. And this is the definition of the prosthetic joint infection according to the MSIS meeting in 2013 by the ICM. And the one criteria which is the sinus tract communicating or the pathogen from the joint isolated. And the 5 minor criteria, any 3 of them, if positive, without the need for the major criteria, is also the criteria to establish the diagnosis. These are all the regular risk factors, and the main thing is the diabetes. Even if a patient who is non-diabetic, if the glucose levels are more than 200 mg per dl in the perioperative period, it is a risk factor for the prosthetic joint infection. And the second one is the rheumatoid arthritis. Patients are on the DMARDs, which reduces their immunity, and this is the most important factor. And this should be usually discontinued 2 weeks. So we cannot do the walk-in surgery for the rheumatoid patients. They need to discontinue the DMARDs 2 weeks and plan the surgery. And these are all the risk factors usually. And corticosteroid injections, which are usually given, is one of the risk factors. And it has only a moderate effect, not the strong effect. Smoking and alcohol are the major. And this is the definition. Less than 4 weeks is the acute, more than 4 weeks. And main acute is the poly exchange, the mode of treatment. For a chronic PJI, there is no role for the poly exchange. It should be the complete removal of the prosthesis. So the only way the chronic PJ is the sign is by clinical science is only if there is a sinus tract. Otherwise, it is only the indirect evidence or the radiological evidence. Clinically, we cannot establish it unless there is a sinus tract. These are all the radiographs. Sequential radiographs are the necessary. And you can see this X-ray. Compared to the John, you can see the medial condyle. There is the increase in the osteolysis extent. So we can confirm that there is the ongoing infection in the joint. And the CTs, we can see that there is a radiolucency around the tibial keel and radiolucency anterior and posterior to the tibial base plate. And MRI, it gives a good soft tissue resolution compared to the CT. And bone scintigraphy, it is usually not so because why? Because the bone scintigraphy will show increased uptake up to the first 2 years. Only the post 2 years PJI can be well diagnosed on the bone scintigraphy. And these are all the laboratory studies. CRP is usually done. And synovial fluid analysis, nowadays, with the help of the PCR, it has become a rapid tool to diagnose in the OPD basis. Whenever the synovial fluid is analyzed, this alpha defensin, when this is tested, even in the intraoperative period, we can confirm if the poly exchange is planned within 10 minutes. So with the PCR, there is 2 companies are offering the PCR test for synovial fluid in Hyderabad, and the report will be given within 24 hours to place the patient on the post-operative antibiotic to guide the treatment based on the. And this is the sonification where the implants are subjected to sonification and the microbial film is destroyed so that the isolation of the organism chances increases when they are subjected to the PCR test. Intraoperative tissue sample is the standard protocol and histopathological is the standard protocol to diagnose the PJ. So these are all the treatment options. The first option is antibiotic suppression, which is rarely used only when the other options are not viable. And the debridement and prosthesis retention and the resection and arthroplasty, knee arthrodesis, 1 or 2 stage exchange, which is commonly practiced thing. And the last resort is the amputation. So this is the antibiotic suppression, which is only used when process removal is not at all feasible. Probably in some cases like a tumor process is done and there is less chance of the patient survival. In such cases, the antibiotic suppression has a role. And this is a commonly used joint debridement and process retention. It's very limited to the early post-operative period where we will debride and sometimes we will exchange the poly. And which one of the contraindication is the Staph aureus infection for this type of treatment. So this is the resection arthroplasty, where usually done in the hips in the elderly patients. We'll remove the implants and do the girdle stone arthroplasty. In knee, it has very limited role. And this is the knee arthrodesis, where when the repeated revision surgeries are failed, knee arthrodesis is the mainly the viable option. And usually it's preferred in the young age and when there are the functional demands are more. Are very poor soft tissue coverage is there. So these are the, unlike the K-nails or the Charnley clamps, nowadays the modular implants are available. These are the silver coated Mitars implant, which is now available in our place, which can be used for the knee arthrodesis. The advantage is the patient can be mobilized immediately after the knee arthrodesis. This is the exchange arthroplasty, which is the main role of the treatment nowadays. And it is done 1 stage or 2 stages. Actually, fairly the survival, the recovery rate of success is fairly same for both of the thing if done in the proper way. These are all the reconstruction principle. The main principle is the proper establishment of the joint line and the bone to fix should be approached and the knee, all limb alignment should be maintained. The remaining points we cover. I just want to show you this video. Does it play? So this is a technique of the double draping, which comes very handy while doing the infected cases. The same supine table under the tourniquet. I'll just show you some of the things in this. The same supine position under the tourniquet. We place the first set of the drapes. Okay, we'll cover the patient's entire body, and these first set of drapes are placed. So after placing this first set of the drapes, the impervious U drape is placed. Along with that, IOBAN is placed over that. So once the IOBAN is placed, then so this is the neo drape that is placed. Then the second set of drapes are placed after changing the gloves. After changing the gloves. So after the IOBAN is placed, the second set of gloves are placed. So then we drape the leg again, and the second neo drape is placed over the first set of the drape. So this is the second set of drapes being placed. So by this, once the debridement is done and everything is done, once we want to remove, we can have a sterile field. Instead of re-scrubbing the patient, reapplying the drapes, we can just remove the second set of drapes. We can just remove the second set of drapes, revealing the sterile drapes. So on the revision exposures, the standard medial parapatellar arthrotomy is done. If the extensive release is needed, quadriceps turn down or a rectus snip. The studies reveals rectus snip has the better advantage, and sometimes tubercular osteotomy is also done whenever there is a severe FFD. And this is the double scalpel technique for the scar excision, which is very, very advantageous to remove the scar. And these are the skin expanders when you expect the skin closure difficulty after the process implantation. This can be done, or flap cover. So this patient, all the synovial fluid analysis parameter, infection parameters, everything were normal. I have shown you the X-ray. On the sequential X-ray, there was a medial condyle osteolysis. On opening, this is the scenario, and the implant is very loose. So the next thing is the synovial recess should be opened, and the muscle adhesion should be released from the femoral condyles. So the femoral preparation, it's mainly the epicondylar axis that you can rely on in the revision surgeries. Once the femoral condyles are removed, in 2 stages, the spacers are placed, antibiotic spacers. The articulating spacers are now available so that we can mobilize the patient. There are documented evidence with the patients being happy with the spacers for up to 6-7 years without undergoing the stage 2. And this is the stimulant which we commonly use for the antibiotic mixing protocol for the different antibiotics based on the sensitivity. Some of these antibiotics takes 45 minutes setting time. So these have to be prepared well before. and we should have all the armamentarium ready to do the second stage. And this is the patient which I have shown previously. He had the very thin medial condyle, only the cortical shell was red. So, and there was a very severe scar tissue in the previous slides. You can see here, there is a severe scar tissue here around, surrounding the popliteal artery. And this is the fracture of the medial epicondyle. So the distal femur replacement was planned. And this is the patient, painless, almost after 10 years of the primary surgery. He became painless and complete knee ROM. And patient has a bit limp. This is the 45 days post-op. He has a bit limp. And when he is using a short knee brace, that limp is not at all visible. So coming to the robotics in the role in the revision TKR, this is a single study where only 19 patients have been underwent the revision surgery. With the use of the revision surgery, all the surgery are Mako assisted. And this is the preoperative planning. The preoperative planning is done with the implants in situ, and the registration is also done with the femoral and tibial components in situ for the revision TKR. So this is the way the registration is done. And the femoral component after the registration will be removed like the conventional way, but the tibial component usually is removed with the tibial component in situ by doing the tibial cut below the tibial plate. And this is another study of the role of the robotics, where the fully autonomous robodoc or semi-active systems both are involved, and most of them are the THS. And one study is from the UKA to TKA revision, and one case of THA arthrodesis system. So amputation is the last resort, as we know, when the virulence of the bacteria is high or the patient is not able to continue the antibiotic or so weak. And this is the treatment algorithm. Whenever the acute PJ is enrolled, you know that it is the difficult to treat infection. Okay, then you go for the process exchange. If you don't know, and you will go for the debridement. Okay. And if a chronic PJI, process exchange is the main criteria, there is no role for the debridement. And if it is a difficult to treat, if it is known, then you plan a 2-stage. If you don't know if it is a difficult to treat, then you plan for a 1-stage revision. So this is again the 2-stage procedure also. After 2 stages, if you know that the infection is difficult to treat, you take a long interval. So these are all the different types of the surgical procedure. In the acute stage, you do the retention. In the 1-stage exchange, another thing, when you don't know that or you identify the bacteria and it is not Staph aureus and it is sensitive to the many microbials, then you do a 1-stage revision. And 2-stage revision, when it is a difficult to treat infection, and a long interval when the bacteria is resistant and limited antibiotic and patient needs some time to cope up. And TB in prostate joint infection is another thing, challenging thing. And it has same thing, recurrence of previous TB or dissemination or reactivation of the latent. So treatment strategy, first we usually, if the knee is not much symptomatic, ATT is tried. And then if it is an early onset infection, or it is a clinical findings are there, or it is sensitive to the anti-tuberculous drugs, these three should be defined, and based on that the treatment is different. If it is a late onset PJI, usually it is the 2-stage revision followed by the ATT after the 1st stage. And knee arthrodesis is most commonly a preferred option if the treatment is not responding for the ATT. Thank you.
Thank you, sir, for your valuable information. Now I call Dr. Adarsh Annapa sir to give panel discussion on Mako robotic TKR. Please welcome, sir.
So my panelists are all here, Ashok Raju sir and Dr. Kishore. Anybody else here using Mako hip here? Okay, so I think it's just three of us. So we've already seen a beautiful Relive surgery from Ashok sir, and we've also spoken about anterior hip with using the Mako with Supreet. So I'm just going to take a few basic questions that we have on the Mako hip. I won't take too much of your time. First thing is, as far as I know, I think only Mako at the moment has the robotic hip. I think the Smith & Nephew has also come. It's more of a navigation. Sir, how was your first experience when you started doing robotic hips? Did you find the learning curve was a lot or not too bad as expected?
I think you're good at video games and all. Most probably I'm not very good at those. So it took a little time for me to get adjusted to that.
Okay.
Other than that, I think it didn't really bother me much.
Right.
But the good part of it, so when you do conventional, you size based on repeated, you go from a smaller size to go to the next size, and then you get a hang of it, and then you know what size. Here, the Mako tells you what size,
Right.
one size up and down. You can already plan and look into it, and you generally don't change your cup size once you have determined that. So that's one thing, and dreaming becomes so easy, and I think,
Absolutely.
and if you look at it, you will love the way it is reaming.
That's true.
Than
Yeah,
your
it's,
conventional.
you get a kick.
Yeah, so the cancellous bone, what you see, gives you a different feel than what you do with hand.
Correct.
So that I think really changed, and yeah, with the enhanced flow, yeah. I think what has really helped me in, I never understood the spinopelvic parameters to be very true. It took me a long time, but yeah, now I can just put them and see through the virtual range of movements.
It takes you through without having to use your brain.
I can flex, I can abduct.
Yeah.
Off late, I imagine myself like put my flex hip, abduct. How are they going to get onto the scooter, two-wheeler?
You replicate
so you
those.
can replicate that on the C and where it is impinging, and you can change your cup on the femur.
Yep.
Those things are really beautiful, I think. Yeah. But caution of word, just don't go by it. You need your own knowledge about what.
Definitely.
That is very important.
I think what sir is trying to say is, I don't think you can be a great a robotic hip surgeon unless you're a good conventional hip surgeon.
No, a conventional hip surgeon.
Wonderful. So going to Kishore, have you seen much of a difference in the immediate post-op in terms of the clinical outcomes in the patients between robotic hip and conventional hip, and radiological outcomes between the two?
No, I think radiology, it's excellent. I think with whatever is in your mind, whatever you want to execute and whatever you want to see, all the positive things are there with Mako.
Correct. Yeah.
Conventional, probably that version inclination, maybe it's a little bit of error based on the experience.
Yeah.
But I think clinically,
a bit of trial and error is there.
Yes,
Yeah.
it's there. And size-wise also probably we need double check. But I think robot is doing wonders in that. And there's a surgeon, there's some surgeons who open the cup even before opening the joint.
Yeah,
So
I think you had experience recently in the US.
So they're doing the surgery on the acetabulum on the CT scan, the robo, and then they're opening it.
Correct.
So I think.
So you're saying radiologically, definitely there's an advantage because you're replicating 100% of the time what you planned. But what about clinically? Does it really make a difference?
I think what we are seeing in our institute is not much of a difference clinically unless it's there. But confidently, I can say robot will do better because radiologically it's 100%.
Correct.
Maybe it's 99% conventional. But definitely robotic hips are doing.
So I think what Kishore is trying to say is definitely the value of the robo is there in terms of radiology. We even published a paper on that. 100% of the time, you're planning everything before. You can even see the pre-op X-ray, what it looks like beforehand. 100% of the time, your X-rays will replicate what you have planned.
And even before we cut, before we cut, we can see an X-ray on the screen.
Exactly. The pre-op visualization of the X-ray.
Yeah.
But clinically, whether it really translates to better or faster recovery, probably not, because there's not much different you're doing. But in terms of dislocations, yes. I don't think we've ever had touch with a single dislocation in robotic hips because of this virtual range of.
Yes.
Yeah. So I think I'll put one more point in terms of radiographs. your cup at 40 and you can see the same, you don't have to get an X-ray. You can get with the cup, head, neck, everything, and you can see the X-ray, how it is going to look on your screen by putting those things. You want to change your offsets, you don't understand because I understand mainly X-rays. So I put back my X-rays on the virtual thing and see whether it is working well. So you don't really require to get a post-op X-ray. You can see the X-ray on the screen itself. That's the beauty of it.
So I have a question for Ashok, sir. I have my answer. I'll tell it after you. But have you felt that after doing robotic hips, has it changed any of your approach in conventional hips?
Has it changed? I
As in
think
small nuances that you've picked up from robotic, which you're now replicating in conventional hips, anything like that, or they're independent of each other?
yeah, I think the major advantage of a robo is you get live search, live values.
Yeah.
That is making a lot of difference. And that gives me, I don't have to think, okay, what my X-ray will look like or how it is going to be in the post-op.
Correct.
Because I've been doing for so many years conventional, I don't find much of a difference or any change. In fact, I use my knowledge to put it into that and get the best.
100%, yeah.
Yeah. That way it is more helpful.
Yeah. So what sir is saying is just blindly trusting the robot doesn't always work. You always have some nuances you've picked up from your conventional surgeries, which you can input and get better results. What I felt is after doing robotic surgeries, I realized that probably in my conventional, I've been putting my cups a little too antiverted. So then after doing robotics and seeing that even lesser antiversion, as long as the combined antiversion is good, you don't need to put it so on. So I started reducing antiversion in my conventional hips as well. So that has given me that bit of
So you are going to change a little bit after
seeing something new.
Saying something new, definitely. But the things what you could not do without a robo.
Correct.
With your knowledge, you wanted to see how the cup is going to be at 30 degrees or 40 degrees or 20 degrees version. I think those things will help you a lot.
Definitely. So Kishore, I have a question. So a lot of people do ask initially when they're considering taking a robo or not, for hip especially. I'm talking about hips. Are there any contraindications where you say this particular patient, I don't want to do a robotic hip, or you feel that can be done in any case?
What will definitely give you a better understanding of the joint.
Yeah.
I think especially in complex cases, it will help you more.
Correct, right?
Rather than a simple one.
Yeah.
Because it will give you a 360 picture throughout the surgery.
Yes.
And at each step, it will show where you are. So we can change accordingly. I think definitely in complex cases, it is.
Yeah. So it's not like you should only do in these particular cases. Any case you can end up doing, especially in fact, dysplastic hips and all, where you know where the bone stock is.
I think the only disadvantage of a robo comes when you want to do a very narrow canal and you can't use that striker implant.
True.
So,
So then
that
at
is
least
the
you can
only,
execute the cup with the robo and then do the stem independent.
That's fine. What I'm saying is those are the only limitations because of your non-availability of your implant or that is the only thing is a major disadvantage.
Actually, sir, so a lot of people don't know because in India it's not there yet, but you can use the Mako with the exeter stem and you can do a cemented if you want for a very narrow stem. So, but we haven't used it. But it can be done.
We're opening robo a little instead of a closed system.
That would be a good idea. I mean, if that happens in the future, I don't think it'll happen.
So what I mean to say is if you want to do osteotomy in a thing, I think that is when it becomes, you can't use the same implant. So there, that is the only restriction.
Correct.
Cemented, uncemented, all our options are available. So
let's talk about, so you spoke about learning curve in terms of getting used to the robo. What about the time taken? Did you find that initial days it was taking longer, and how are you now compared to your conventional case? Are you taking a little more time, little less time, or almost the same now?
See, my cup size is I reduce my time in determining what the cup size is. That way it is very helpful. And when I broach and check for the version of the femur, I don't have to check what is the angle, turn the leg this side, measure. All these things are gone now with a robo. So that way it is very helpful. Yeah, we can open up the implant and keep it with that. But we are a little scared because it's going to cost us another, if by chance it goes wrong, then the whole purpose why we don't open is another 40,000 for the patient or to me. Anyway, so that is the only reason why we don't open the cup prior, I think.
Right.
Yeah.
So
Yeah, overall, I think definitely as you go by it, once you get used to, you see the points what I've done it very slowly to record it.
Yeah.
You generally do it. You don't even have to look. You blindly look at it and you start doing it once you get used to it. There you don't lose time at all. I think finally either they are same or definitely it is a little shorter than.
Yes.
Yeah.
Fantastic. So I'll conclude with the last from both of you. I'd like your opinion. Going forward, do you think, like for surgeons, now we've talked about for patients the advantages. Do you think that it makes sense to, I mean, if you get the opportunity to adopt robotics for a total hip or not? Just a summary. What would you feel?
Definitely, definitely. First thing's accuracy and execution. Second thing, I can sleep well.
Yeah.
So I'll be happy at the end of the day.
Yeah. The question is, first, I'd actually break it into two parts. Is there an advantage for a surgeon to take robotics? Secondly, is it the only way to go for hip replacement?
I think every time we learn new things and the technology will make your things much simpler. So yes, it is going to the future and you should keep up with it. And finally, I think what is important in surgery is precision. And that precision, I think you need a instrument or something to say, yes, you're at this point. Your naked eye cannot tell that.
Right.
So yes, definitely with you want precision, you need a robot.
Absolutely. And I probably add one point to that. So as both of them said, it does give us a lot of advantages, not only for the surgeon because we have the peace of mind, but also for patient in terms of reduced dislocations, etc. But if you ask, is it the only way to do a surgery? I would say no. Definitely, dude, conventional hips have the beautiful results over decades. Yeah. It's just going to be another armamentarium to get better results. That's all.
As of now.
As of now.
In the future.
Maybe
yes,
even better.
yes.
Yeah. Yeah. Right. Well, I thank my panelists. Yeah, please, a question. Yeah.
Done in a subtrochanteric region.
Okay.
And it's malunited, does it help you?
Yeah, you can still do the procedure. So as mentioned by sir, why don't you take that, sir? Because
I think if you have a CT scan, you have your registrations done. And if you think your stem can go in, you can go ahead.
Yeah. So it's also
the
giving
whole thing is it's a closed system.
Yeah.
If
So you
it is
can't
a
use other implants. That's
other
the only
implants.
disadvantage.
So you have a revision stem in that you want to go ahead. Yeah, definitely.
Especially
one advantage
the
you
point
can
of
use.
entry because the canal is wavy or
It doesn't help there. Like
that
it doesn't
is
help
my
there.
question.
Yeah, it doesn't help there.
So
he's talking about broaching.
Malunited
trochanter, either your entry point has to be medial or lateral. So to get into the
Or
center of the
anterior or posterior.
anterior. So through the image, what you get through your cross sections of the CT scan, you can point your entry point. And on live, once you have registered, you can pinpoint, yeah, this is the point of my entry. You can do that.
Thank you, sir.
Yeah. Yes.
Sir, since you are a pelvic surgeon,
Yeah.
had you any advantage in old malunited acetabular injuries? Had it helped you in the form of removing the metal hardware prior and then do the surgery, or directly one-stage surgery with the help of robotics?
See, robo will help you to know, yes, if I ream, this screw is going to come in between.
Yeah.
So I have to remove this screw. So I just have to search for that screw to get it removed.
If I may add a point here, sir.
Yeah.
We have done quite a few cases, even sir was there with me when you've done it, where we've actually managed to avoid taking out even one screw just by doing a little bit of movement of the cup, because we can actually plan where to put the cup now. Earlier, we would have to go in, take out the cup, screws. But here, just by moving on the planning, the cup a little posterior, a little inferior, with still good anterior-posterior fit, we managed to not even touch one screw. A couple of cases, if you remember.
It's all about
together.
how you play with the video game.
Yeah.
But within the range, not out of the
yes.
range. You can't keep somewhere outside and then say, okay, I'm not going to.
I avoided the
Yes.
plate.
Yeah. So you try to do those things. Yeah, it is inevitable to remove a screw. You know you can remove that screw, but you can avoid it. But just a tip, you can just either change your cup this way, anterior, posterior, laterally or medially. That is how you can adjust. But in terms of using a graft and filling up, I think if you're using, it might help you in reaming and knowing the size of the cup, but you have to do revision based on your knowledge again.
So
Putting a
just
augment or something.
a small trade secret. We've actually seen the what do you call, the place in Delhi where they're actually coming with research and development, and they're coming up with revision hip soon, maybe next year or 2026, where you can actually even remote the augment place, and it'll even let you know where the screws have to go. It's coming even to the next level. So the future is bright for robotics.
Yeah, that's what I said.
Yeah.
As of now, no, but
It's good.
future, yes.
It'll be even better.
Yeah.
Yes. Nagarjuna? Yeah.
Thing is, as you were mentioning that your robotic arm will limit your movement once we reach the limit or perimeter of the reaming that is supposed to be mapped. Do we have to be at a caution when we try to ream on a disclassification, whether it should be while reaming or after the reaming while placing the implant? Or do we have any specific precautions that we ream over a graft or something that we limit the robotic arm to protect our wall in a specific case like that?
See, even if you have put a graft and you have kept it in place and you have done the thing, you can go ahead and ream on the graft as it is.
Yeah.
Prior to that, you have to do a registration. So that is very important. How you use this tool for your final outcome is very important. So when you have a very small cup, and you try to, that's what I was saying, you have to use the software for your best way to put your cup for your best results.
So if I can just add a point here, I would feel the best value, at least till now, of what I've used the robo is in this plastic hips, because I can plan where the best bone struck is. I don't have to follow the crows now, like crow 1, 2, 3, I have to have a high hip. It's not necessary. I can actually plan where I want to go. I can plan the depth of my cup. I can see where my anterior posterior fit is best, taking out the least amount of bone. And as you said, it doesn't actually restrict your movement. It has a funnel haptic where you can actually move around as long as you're within that 15 degrees of funnel. And the beauty of this is you know where the bone is going to be. So you're not going to knock out, blow out any bone anywhere. Once you've planned it well, you just go ahead and ream without even thinking twice. That's the beauty of that.
My one more question is there just a ream mode in these robots, or there is a ream and protect kind of scenario? Or does it happen with these robots?
What do you mean?
Protect, I mean, like protective or guarded reaming, or just ream? How does it happen?
Force you use. If you want to push it in or move it anterior or posterior, it will automatically tuck बोल के बंद हो जाता है.
I mean, outside that 15 degrees, it allows you some movement.
No,
but outside 15 degrees, it doesn't allow you. Yeah.
So the moment you're going to get out of that precision area, your haptic boundaries are the best in this robo. So you cannot go. So even if I want to put it, there's a boundary, but if you cross that boundary,
shuts off.
You can't even move anything.
Yeah.
And then again, you have to call somebody to do it.
To put it crassly, it's like the condom. It doesn't allow you to mess up. Right. Thank you so much to the panelists. And
just one last question.
Yeah. Dr. Karthik, yeah, please.
Nowadays,
all the robotic systems are the closed systems, but more and more cases are being done in the primaries. Coming days, the revisions will be done with the robotic. Do you think the companies need to open up and make them the open systems, or even the closed systems will work for the revisions?
Please.
I think we desire open, but they are
not practical.
They are business people. They have to earn, they have to sell, so they will keep it closed.
They are spending millions on this.
Yeah,
so they're not
not just that.
Future,
They spend a lot on research, isn't it? So
but they might be losing on the
I
revision.
make something, I want to keep it for myself, isn't it? Yeah, that's how it is.
But it as I said, revision is coming. They are coming with the revision software. It's fantastic. So I'm just waiting for them to unveil it. So it's coming maybe in the next year itself.
Even with the closed system.
Yeah, you know the closed system. I mean, Striker already has a very good armamentarium for revision cases. You can do a revision on a implant which is done from another company, but you'll have to end up putting in your striker probably.
Only the striker.
Yeah. Okay. Thank you so much. Thank you. Thank you, sir. Thank you, Kishore.
Thank you, sir. Thank you for your valuable discussion. By this, we came to know new more information. Thank you so much, sir.
Yeah, really thank you, sir. Now I request Dr. B. Vikas Reddy, sir, to discuss about planning and workflow of MISSO Robotic TKR. Please welcome, sir.
Good evening, everybody. I thank ONUS Hospital and the Robocon for inviting me for the talk today. I thank Balaraaju for inviting me to give this talk. As you all know, we're talking about the MISSO pre-plan, which is almost close to the CUVIS that you all had seen previously. This is a image-based robo with a fully automated system. So it has got a CT scan, an AI-based software, which will give you a bone mapping and bone cuts prior to the surgery. So the CT scan has a protocol which is done from the hip to the ankle, which has got 1.25 mm of bone cuts with in an axial plane. All these images of DICOM, which are then put into the software, which will give us a 3D mapping, which can then be used as which can then
Aditya, sir,
be used to determine your bone in space. So we'll start as you know, it's CT based from the hip to the ankle. You get to do the femoral axis first, which you get all the images from the axial to sagittal to coronal, and including the 3D image, wherein you can determine the hip center, the condylar center, the medial epicondyle, the lateral epicondyle, the medial posterior condyle, the lateral posterior condyle, the medial distal condyle, the lateral distal condyle. All these are put up by the AI system in the laptop by itself. You just need to make sure that they are in the right positions. If they are in the wrong positions, you have a cursor that you can shift them to the right positions. So then you come to the tibia, wherein the proximal center, the ankle center, the tuberosity center, the PCL fossa center, the medial and lateral epicondyles are also given. Then you do the registration, wherein these registration marks are taken up in your live surgery. So all those you have to point in the pre-planning. So this sequence gives you where you have to put your points and which can be registered during the live surgery, registered during your surgical time. So the medial epicondyle, the lateral epicondyle, the distal notch, the anterior part of the femur, the anterior medial, anterior lateral, the posterior medial and posterior lateral parts of the femur are put into the system. Then the tibia part is registered. All the points that need to be mapped out. So all this mapping will give you the pre-sizes of the bone that has been imaged. So as far as this knee goes, it has been sized to size C in the Meril with a tibia size of 2. With this, you can you can even change the flexion extension if you are in a notching scenario. You can do external and internal rotation depending on your how you want to determine your axis and your varus valgus. All these all this is only determined to the bone, as this is not, as no information has been given to the system about the ligament balancing. The AI is only giving you the pre-planning only for the bone cuts. So this is to the tibia. The size has been given as 2. So you can do the sloping of the tibia, internal and external rotation of the tibia, and the varus valgus cuts of the tibia. So eventually you will get a image which gives you a distal lateral cut of 8.5 mm, distal medial cut of 9 mm, posterior lateral cut of 2.5 mm, posterior medial cut of 7.4 mm. All this will eventually, so finally you need to know the hip knee ankle, which is 173 degrees, which is giving you a varus of 7 degrees. So after the correction with the implants, it will give you a 180 degrees, that is neutral, that will give you a mechanical alignment. So this is as far as the planning goes. Then the workflow, all this pre-plan is imported into the robo. Then the calibration of the robo is done. The fixation of the femur and tibial markers are done. The bone mapping is done. Gap balancing are checked and bone cuts are made. Trial implantation and final implantation are done. My colleague will be talking about the same patient's relive surgery. He will explain to you with the ligament balancing in this scenario. Thank you. I would like Dr. Anil to come and talk about the relive surgery of the same patient. Thank you.
Good evening, everyone. At the outset, I'd like to thank Balaraaju and his team for organizing this conference and giving me an opportunity to present this MISSO Relive surgery. MISSO is similar to, I'll start the video to play. I think we are short of time. So let's start with the video. I can talk while the video is playing. So this is a 70 years old female with a varus knee. These are her X-rays. Can I speed up this video? Yeah. So this is the pre-plan which Vikas has already presented. Yeah, thank you. For the sake of time, I'll start from where the bone arrays are put. Bone arrays are basically the markers from which it's not playing there. Yeah, so we'll start the video from the bone arrays where the markers are put. These markers are the ones which are fed to the robo where it picks up the actual bone. Here I am doing the registration of the points basically. Femur and tibia mapping are done basically in the pre-plan. We have to reproduce the same thing in the live surgery as well. It's quite receptive AI software where it doesn't take much time to make the registrations. Initially, it collects few points for each part. Then we'll have to map each part with around 5 or 6 points, which will actually give the robot exact position of the femur and tibia. It has a learning curve initially, but it doesn't take much if you have done enough knee replacements. Most of the times, if you do the pre-plan by yourself, you should be able to manage this mapping easily. It will take around few cases, around 20 to 30 cases, but after that, you will be able to map without much problem, basically. Once the mapping is done, then you can go to the next step where the robo gives you the gap checks between the femur and tibia. There you can actually adjust the gaps based on the ligament tension as well. Because in the pre-plan, it doesn't have the ligament tension. It actually just gives the cuts based on the femoral and tibial axis. It will give you a mechanical axis cuts where the knee alignment is basically 0 degrees, neither varus or nor valgus. But once you come into the intraoperative situation, based on the ligament alignment, you can put the tibia in 1 degree varus or 2 degree varus, or probably 1 degree valgus or 2 degree valgus based on your extension gaps or flexion gaps. So once this mapping is done and the gap check is done, before you can start the bone cuts, you can adjust those things here. It'll take MISSO is slightly more time taking here because it takes more points than all the other systems present. Either CUVIS or Mako, which are both image-based systems. MISSO will take more points, probably because it's been designed after the previous two where they had previously it's been designed after the CUVIS where they had few issues. So to increase the safety of the robot, they have taken more points to during the registration and mapping. Once the mapping is done and the RMSE is basically error is less than 2, then you can go and check the extension and flexion gap. So it gives the spaces. Basically what it says in the bottom right corner in the maximum is basically when you stretch the knee to medial and lateral, it will tell you the gaps in valgus and varus strains. And when you flex and do it, it will tell you the gaps in flexion as well. So the max gaps is what is based on the ligament tension. The captured gaps are basically what it has given by cutting the bone, basically. So once you try to match the max gaps, you will probably be in a good gap management, basically. If you only go by the captured gaps, it only gives you good alignment, but you might not be balancing the soft tissue. But if you look at the max gaps as well, where it tells you the state of ligaments, based on that you can adjust. Because I've seen in the extension, the lateral gap is less. I have put the implant in 2 degrees valgus to increase the extension gap in the lateral side. Then basically I have rotated the implant external rotation 2 degrees to improve the gap on the medial side in the flexion. Once you feed that data to the robot, and then you can actually get the robo close and fix the robo with a pin into the femur. There are 2 pins. You can fix the robo with a pin to the femur and tibia as well. But I think I have gotten used to doing it with 1 pin. So I generally put a pin into the distal femur and fix the robo to it. And after fixing the robo to it, you actually validate 3 points again so that robo knows the bone is not moved much. Then it starts cutting, basically. So during the cut, you'll have to, if you have a leg holder in place, if the leg doesn't move much, the cuts are smooth. But if you are doing it with a basically sandbag or something like that, then the cuts will take some time. Sometimes bone movement actually delays the cuts. So I'll run through the cut for the want of time. All the cuts are done. So you can see how the robo cuts, and it also depicts where it is cutting once you see in the robo. It tells you the path of its cut as well. If you think the robo is going beyond bone anywhere, you can actually stop it, and you can finish the cut with the saw if you want to. So this is the posterior chamfer cut. You can see the robo doing as well as it's showing the path where it is cutting. You can always see where it's cutting on the robo, and if you don't want to go deep into the lateral side where the neurovascular structures are there, where the ligaments are there, if you want to stop it, you can stop and finish with the saw at the end, or you can just nibble off the remaining bits, basically. So I'm running through this because we'll avoid wasting time here. So once all the femur and tibial cuts are done, then you can, this is the tibial cut where you can adjust the position of tibia. You can put the tibia slightly anteriorly, where earlier another surgeon was telling how you can cheat robo by preventing it to go posteriorly and injuring any neurovascular structures. You can put the bone window slightly anteriorly so that it doesn't go back on the tibia and cause any damage basically. So once the tibial cut is finished, yeah. So this is posterior cuts I have done later of the tibia, after the tibia cut is finished, because sometimes because of the cruciate retaining knee, if the flexion gap is tight, we can do tibial cut and come back and do the posterior cuts of the femur. So this is after the cuts. We do trials and we can recheck the gaps. How are they? If you think gaps are not appropriate, you can still adjust at this stage. So with Max implant or Meril implant, you have UC poly. If you think around 100 degrees or 110 degrees, if the poly is lifting or if the flexion is tight beyond certain degrees, you can actually release the PCL and go for a UC poly. This is after the final implantation where the gaps are reasonably matched with 1 mm tightness on the medial side, both in extension and flexion. If you are into medial pivot joint, you can plan so that 1 mm tight in the medial side to have biomechanics almost reconstructed in the knee, basically, because normal knee is close to the medial pivot joint. That is what a lot of research is going on right now. So if you want to keep medial 1 mm tight and reproduce that kind of biokinematics, you can do that with this well as well. Okay.
Thank you, Dr. Anil and Dr. Vikas.
Yeah.
For demonstrating on the very new system of the robotic.
Yeah, it's an indigenous system. It's not very inferior to any other robots I have seen. I have seen CORI and CUVIS as well. It's not inferior, but it needs still some ironing out. It's good that it is quite, it comes at a better price than other robots. And probably because it is an Indian made, probably it can evolve and be available at a more better price in future.
Do you find any major difference between CUVIS and MISSO?
Not much. MISSO has lesser footprint than CUVIS, so it is easy to maneuver. MISSO has more spatial orientation, so you have to know where to put your markers better in MISSO compared to CUVIS, basically. Yeah.
Is it as sensitive as the CUVIS?
Yeah, it's as sensitive as CUVIS from what I have seen. The feedback is good, and the speed at which it registers is probably better than CUVIS from the way I have seen it, basically.
Even CT planning is also quite faster in this.
CT planning is quite faster. CUVIS takes around probably 45 minutes for AI segmentation and 3D reconstruction. This takes around 10 to 15 minutes.
And during CT planning, when you're doing the femoral registration regarding the epicondyles, do you mark them originally as the native
there
points?
are two aspects in the registration.
Yes.
One is femur axis and tibial axis calculation. Yeah, femur axis and tibia axis, I take it exact
Original points, yes.
But registration, I slightly deviate because I do a mid-vastus or subvastus approach.
So you want
I want my points to be accessible while I'm registering on live as well. So basically, registration, you don't need exact points because it's only to map the bone.
Exactly.
But
You just want to replicate on tape.
Yeah, because cuts are based on femur and tibial axis, not just based on registration. So you can adjust your points so that you can easily register during live surgery.
And excuse me, I'm asking my own doubts because I'm also very new to MISSO. In the gap checks, what do you look at? More at the max values or the captured values?
I do more look at the max because initially I looked at the captured values. My final gaps when I did trialing was around 2 or 3 mm off from the captured values. Once I switch it to max,
based on the ligament tension. Now I don't go much wrong, maybe 1 mm difference, but not 2 or 3 mm like I used to. So basically you look at max gaps because it is what when you do tensioning and see the gaps. And still I keep a medial tight in most of the knees if I am doing varus knees. I don't still match equally on medial and lateral side. I keep 1 mm or 2 mm tight on the medial side. And once I release the deep MCL or remove the osteophytes, I am most of the time equal to the lateral side or probably 1 mm off. I'm not much off. So if you keep it initially itself both equal, then sometimes the medial gap opens up. It is not a situation you want. You want medial to be tight to reproduce medial pivot dynamics. So it can be medial 1 mm tight, but you
can end up in 2 mm tight also.
Equal also I don't mind, but I don't want medial loose compared to lateral basically. Robo doesn't help with the long-term outcomes as I've seen. I've not been a proponent of Robo, but Robo will definitely help you become a better surgeon over time. If you are decent or average surgeon, you will pick up a lot of nuances with Robo. It will make you sleep better. That is good.
At least it will tell you what you're doing, right?
Yeah. If you want to put in 1 degree varus, you can put it. In manual, I used to want to sometime balance and put 1 degree varus, which I didn't do because I don't know whether I put it 1 degree or 5 degrees. I was very happy doing manual, but sometimes I had issues where naked eye cannot make out 1 or 2 degrees varus or 1 or 2 degree valgus. So you can do those adjustments in Robo. It will definitely help surgeon more than patient. Patient long-term outcomes, we'll have to wait and see. Patient short-term outcomes, I have done not too many cases. I have done around 30 to 40 because this MISSO was launched in August or September. We got it basically. I've seen patients are satisfied. Whether that is because of me or Robo, I'm not sure. Okay, because I had some patients happy even manually. Maybe the percentage of unsatisfaction immediately post-op comes down. Whether that is coincidence or probably because of Robo, we need more studies to know that.
Any valgus knee experience, sir?
I have done only 1 or 2 valgus. It's not bad valgus, so I can't tell whether it helps. Maybe if I do, I can. Yeah.
Thank you.
Yeah.
Thank you.
The last.
Yeah. No, he's asked enough questions to me. So
the best way of offense, defense is offense. That's why I asked you the question. And one last question regarding MISSO, because I have used MISSO only for 10 cases till now.
Okay.
And regarding the max values.
Yeah.
Like, okay, once you got the max values out doing the gap checks,
Yeah.
and then you start playing with the implant varus, valgus, implant
yeah,
shifts.
yeah.
Are the max values changing?
Yeah, they change. If you do adequate rotations or valgus varus, max values change. It's not just the capture values which change, max values change. But you have to use the reset where once you change and you press the reset button, it will tell you the change in max values as well. If you don't press that reset, it will only tell the change in captured values, but not max values.
Yes.
Basically, if you want to know the ligament tension, you have to understand that you have to balance the max values rather than the captured values.
Thank you.
Yeah. Can you open the one more video slide? So today morning we did a UKR done by Yashoda Hospital, Dr. Sunil Dachepalli, sir. He wants to show how patient recovered with a robotic TKR. After 3 months, they have taken video and X-ray. I request our team to open the PPT. So this is the post-op X-ray, immediate post-op X-ray. And can you play the video once? I think video is rotating. Open it. Open in the WhatsApp better. Open in the WhatsApp. Yeah.
Okay. Sunil sir mobilizes the case immediately post-op within 3 hours after surgery. Patients will be very happy to walk within 3 hours after surgery. Many surgeons are claiming after 4 hours, 6 hours, 12 hours. Sunil sir, especially all his patients mobilization will be done within 3 hours after surgery. Excellently done. Thank you, sir. And last video, Dr. Kushal, he is in other country, so he specially made one video, which is the last presentation of the day. And what happens if something very difficult case or something mishap happens in the surgery. Very important video, last video, but very powerful video. I really liked it when I was in Goa. I requested Kushal, even though you are not here, and he specially recorded this video and sent here. Thank you, Kushal, for sending this video. Medial and lateral epicondylar osteotomy. What is the last tool in your armamentarium? Thank you very much, Kushal.
Last option, which is sliding wheel. So expensive and also should be so the worst cases where also is went for the she's running on the book Despite maximum efforts to the students and probably these policy, actually, naturally, and instead of independent balance, and also natural balance. So, information. For single use information. We have a few KRs, we will just for we also so five days of what you can just think about. So when you have that's slide window, that's what I see. And the results.
So thank you, sir. Today is a proud moment for ONUS Robotic Hospitals because as explained by Dr. Balaraaju Naidu, sir, during his presentation also. So today, Dr. Balaraaju Naidu, sir, has performed 100th robotic knee replacement surgery. To celebrate this momentous occasion, I request robotic hospital staff like Pushpa, Manasa, Lakshman, Munimohan Reddy, Sairam, and Meril supporting team, please come on to the dais to cut the cake and celebrate this momentous occasion. Please come on quickly. Thank you.